Yes, there are a few.
They'll interact through this thing, maybe.
Oh, this is nice city. It's we are in quite new area, but there's old town.
Okay.
This is very interesting. So do we have two? Still 1 minute to go. Okay, dear colleagues, good afternoon. My name is Ferenc. I replace at the moment Remo Albiero, who is now on probably flying to Warsaw because of some flight delays. Welcome to 19th European Bifurcation Club meeting, annual meeting here in Warsaw, first time in Warsaw, and we start now with the first parallel session and with the topic Bifurcation PCI trick-based cases. And with me as Mila and Sanjay, and we have in the panel Dr. Sharma, Dr. Katakoglu, Dr. Sagetarian, Dr. Korsandi, and Dr. Alonso. Yes, welcome. Hi. And we will start immediately with the first case presentation. Really very interesting title, 3 rooms, 3 vibes. Nicola, welcome.
Good afternoon to everybody. I would first to thank the EBC for the invitation, and I'm really glad I could present you this case. No, okay. So 3 rooms, 3 vibes, and I will explain you the title. It's a 77-year-old man who is referred to our Center for Coronary Angiography. Cardiovascular risk factor include gender, age, and hypertension. His medical history is significant for COPD, and he presented the first episode of acute heart failure, revealing a cardiomyopathy with, as you can see on the TTE, severely reduced left ventricle ejection fraction, around 30%, with apical dyskinesia, severe hypokinesia on lateral and basal wall, and he also has a mild mitral regurgitation. This is the coronary angiography that will confirm what we expected, a severe coronary artery disease, including a distal left main lesion with a trifurcation, CTO on the ramus, severe eccentric calcified nodule on the ostium of a very dominant circumflex, and a diffusely calcified tight stenosis on the LAD with a slow flow on the mid and distal LAD. As you can see here, the first diagonal looks okay. And as you will see, the right coronary artery won't be very supportive because it's fully occluded. So to guide our strategy, we decided to propose this patient MRI in order to assess the viability of the myocardium. And the conclusion of the radiologists were that there was a severe left ventricular ejection fraction. Okay, that's true, 25% of LVEF. A severe global hypokinesia with an apical akinesia and The surprise was that there was no myocardial viability on the left ventricle apical wall, but there was some viable myocardium elsewhere, including the most proximal part of the anterior wall. So the patient was proposed for the heart team meeting, and the decision was to propose this patient a percutaneous revascularization on the left coronary artery lesions, which included left main, prox circumflex, ramus, prox LAD, and first diagonal. We won't go for full revascularization of the mid and distal LAD because there was no myocardial, no viable myocardium. So I think at this point we have to discuss the potential technical solution that we could propose to these patients with these 3 different type of lesions and a very challenging situation.
Yeah, definitely very complex anatomy. So you have decision now to go with PCI, right?
Yeah.
And LV function is severely reduced.
Correct.
So the first question will be, do we need here protected PCI, yes or no? I think this is extremely complex PCI, difficult anatomy, ejection fraction 23. So for me, it will be protected PCI.
I didn't understand just whether this was acute coronary syndrome or not.
No.
No, okay, because this ramus maybe, I cannot see collateral circulation for ramus.
There was a very discrete collateral, a very discrete Rentrop-1 flow on the very distal part of the ramus.
Okay, because otherwise it would be like infarct-related artery.
Correct.
Ramus, it seems just to me. Okay, is there any other comment? It's like left main trifurcation case, and we are eager to see how you solved
And
it.
without any right coronary artery,
Yes,
which
without,
I think is
yes.
also the tricky part.
Excuse me.
Yeah.
Can we neglect LAD in this situation according to not viable
According to
territory
MRI.
of the apical and consider just PCI of ostial left circ and ramus because left main, if there is no any contrary from imaging, but left main looks not so diseased in this patient.
Yeah, I mean, I can understand the point. The initial strategy was to neglect the LAD, but then we realized that there was still some myocardial, some viable myocardium on the anterior wall, on the proximal part of the anterior wall, and so we tried to, in this situation, although the guidelines are not so clear, I think it's worth the shot just to provide the best revascularization as possible in order to improve the ejection fraction. And about your question on the left main, to me, well, that's a point that we can discuss, but nailing the ostium of the circumflex without entering the left main appears to me, at least in my hands, very challenging, and I'm not 100% sure I can do a good job without involving the left main.
Yeah, one more question.
Yeah, I was also would like to have in hand a left ventricular assist device, maybe in the lab, an impeller or something else, and probably a calcium modification, for example, a rotablator, maybe in the laboratory before I start the case.
Okay.
I think everything everybody said, definitely protected PCI with a low ejection fraction, complex lesion. The right coronary is non-dominant. It's a left dominant system, so we can ignore the right coronary. And I think, I'm sure everybody's going to do an intravascular ultrasound to define it better. It'll help to see if the plaque starts in the left main or not, because you can change your strategy if there's no plaque in the left main.
You will go for just a circumflex ostiums PCI?
If there's indeed absolutely no plaque in the left main, I would debulk the LAD, debulk whatever I can, especially if it's calcified. Shockwave does very well at bifurcations. And if there is no plaque in the left main, I think you can put a stent at the ostium of the LAD at the same time with the circumflex and open the ramus. The ramus does appear that it's relatively subacute. In late images, you could see a little trickle of the flow, and I agree, it looks like it may be the acute lesion. but intravascular ultrasound to help.
But what you should know, if you just wire this distal circ, it could happen that you have cardiac arrest, and then you are really in trouble. So protected PCI is, from my point of view, definitely a must. And I think if you have Impella in place, Impella CP, then you can wire all the branches, and I think it will be useful to start to recognize ramus, this intermediate branch. I think it should go antegrade.
Okay.
Any more suggestions or comments from the audience? Everybody agree, or? Okay, go ahead.
Okay,
There
yeah.
is one question, I think, from the audience.
Thank you. Thank you. It's a great case. If that was in the UK, we're currently randomizing such patients to a trial of Impeller, i.e. mechanical support, or not, because we're trying to understand whether actually, in this type of case, it does make a difference. That's the other option.
Yeah, in Europe and in US is already PROTECT 4 study ongoing, and this is exactly the patient for such study.
Yeah,
Comparison of protection with Impella or PCI without Impella.
so can I just verify from other views and this early rising OM, is it visible for future CTO recanalization, or it is just practically, it is not a trifurcation, it is just the CX and the LAD, and we are not sure about the if you are going to address this OM in the future or not. We need to know if it is indicated for future intervention also.
Okay.
So would you suggest not to touch ramus, just go to
It is totally
SIR?
included. We need to see it in other views. Is it visible for recanalization or not?
There is a view in
There was
EP
some
caudal.
microchannel
There is
maybe,
some-
and there is
So-
viable myocardium.
Yes.
And
Yeah.
the decision from colleagues was absolutely correct to perform complete revascularization. So
So we
I
start
fully
with the
agree
ramus
with you.
or with the left main and circumflex?
As we understood, complete revascularization, starting from ramus, then left main tackling
Well,
left main trifurcation
I
case.
will propose you this, the debate is rather interesting, and there is obviously a consensus about using an Impella, if I'm correct. If I
Okay,
correctly
who of
understood,
you
although
would use Impella? Okay, I think majority. Who
Dis-
would go
despite very
with,
few clinical
who
evidence.
would go without Impella? Nobody. Okay.
So maybe my question will be, how many of you would use Impella based on their clinical experience? And how many of you would use Impella in this case based on the clinical evidence? Which is different, because we decided to go for Impella because we had some troubles and very bad outcome in patients with this kind of situation, low left ventricle ejection fraction, occluded right coronary artery, and left main intervention. And we do that. It's not, practice. It was a disaster without any support. But if you're looking at the data so far, there is no strong evidence.
Yeah, but please go ahead now because we are
Ahead
running
of
out of time.
So, as mentioned, we went for Impella implantation. The first step, so it's a multi-step strategy, and because we're in Impella, we try to do everything in a row. So start with a CTO, integrate the occlusion of the ramus, then moving to the proxial AED that we wanted to revascularize, and because of the long diffuse calcified character, we went for rotablation, and finally on the ostial circumflex and left main. Because of the eccentric aspect of this calcified nodule, we felt that IVL will be more efficient than the rota. And we're gonna finish with a two-stent strategy for left main LAD and circumflex with a tap technique and IVUS control.
So LAD was for your side branch?
Yeah, because if you're looking at the size of the circumflex, which is extremely large, and we thought sometimes I prefer just to go because of the angulation, especially when you get this calcified nodule. I feel it's easier just to put the stent from a LAD, left main to circumflex, and then the reopening of the LAD is easier.
Yes, like
Correct.
assigned side branch
Yeah.
LAD in this case.
So it's a double femoral access with ultrasound guided puncture. Impella is inserted in the left femoral access. And the right femoral access is 7 French access with a 7 French EBU 3.5 guiding catheter. You see that the CTO, the occlusion was not so complicated with the use of a Caravel microcatheter and a fielder. We then pre-dilated the lesion and implanted a 2.75 38 millimeter synergy stent with this result. And you see that it's a large ramus. We just feel that there was some spasm and concern and remodeling on the distal edge of the vessel. Then second step was to put the rota wire down the diagonal in order to debulk proximal LAD towards diagonal with pecking motion approach, 180,000 RPM and a 1.5 burr. Finished with pre-dilation and implantation. And this point is tricky because we did not implanted the stent at this point, and we moved to the third step, which was the IVL therapy of the ostial circumflex and distal left main with a 4.0 shockwave catheter, 80 pulse. At this time, we didn't have the C2 plus. And then we go for the tap, first implanting from left main to circumflex with Megatron 4.0, potting up to 5.5, and then putting the stent on the LAD, a 3.5 per 24 synergy, doing and finalizing with a triple kissing with 3.0 balloon in LAD, 2.5 in ramus, and 3.0 in circumflex, and controlling the result with the IVUS. And we observed a nice expansion of the stent in the circumflex despite the calcification. You see that the expansion is not fully circular, but it's very difficult just to get a circular expansion in this kind of calcified nodule lesion. And the minimal stent area on the ostial circumflex was 7.8 with IVUS, which is completely in line with the recommended goals. And if you go more proximal, you see nicely the neocarina of the tap on the number 3, the slice number 3. And the distal left main MSA was around 10 square millimeters, which is also okay. The good part was the improvement of the left ventricle ejection fraction after 1 week of survey. You see that, of course, the apex won't recover, but now we have much better wall motion on the lateral wall and septal wall. So I think that this case illustrates that the calcified left main can display a variety of lesions, and in this case, each of these lesions might require specific technique, and deciphering the complexity is the key. So you have to carefully analyze the anatomy and prepare a nice plan with a team, ideally. So at this time, we had 2 senior operators, and the procedure took us 3 hours, so it was very long. But all the dedicated tools for calcified plaque preparation improved the PCI efficiency. And I think that also this case illustrates the need of large guiding catheter in case you want to do some complex procedures. And left ventricle assistance device, in this case, was, I think, a great help. Thank you very much.
Okay. Thank you. Great case. I think you had a very clear strategy. You follow your steps, and this is the result is great. And as you see now, a significant improvement of ejection fraction, and this should have influence according the survival of the patient.
I hope so. It's also, I think, this kind of case also advocate for the need of evaluating the need of PCI in case of chronic ischemic cardiomyopathy. I know that it has been very debated that in France a lot of people say that PCI doesn't add anything to these patients, and I think if you carefully select your patient, you can
That's correct.
help them.
Okay, thank you so much, Nicolas. And we go ahead.
Now we will go for the virtual case presented by Evandro Martins-Filo. I hope I pronounced this well. Left main bifurcation PCI with retroflex LCX entry. So we hope that the connection
This
is
will be online, right?
online, yes. May we have a case presented?
Are you connected? There is no connection at the moment? No? No connection? Okay, then we go ahead.
So meanwhile, there's just one question. In the previous case, we chose the strategy for bifurcation as to be the TAP strategy. So what are the, on the hindsight, TAP versus QLOT in that particular case? Why didn't we go with the QLOT? Because TAP, we always know that there are stent struts lying at the POC, which may further bring the patient with an ISR or stent thrombosis. So why not QLOT?
Yeah, you could also go with Dickey Crash, you know. This is the technique with the best data at the moment, but I think it was still some provisional approach, Planet. And
it was a two-stent dedication strategy from the starting itself, because we knew that the apical part of the LED.
Yeah, finally, probably, I don't know where's Nicola, but he used that approach. He can probably do it in his way, on the best way. You know.
I don't know what was the size of the stents in circumflex and LAD, but if there is the circumflex was much bigger than the LAD. LAD was like a side branch, so the strategy was, according to my humble opinion, was good, but also QLOT is possible, of course. But I think that you should apply the technique that you are most familiar with.
Exactly. I think this was the way.
Recorded case, so they can play it. So we should.
Okay, you can play the recorded case. Thank you.
Hi, my name is Evandro. First of all, I'd like to thank you all the organizers for the kind invitation. My case is about left main bifurcation PCI with retroflex LCX entry. So the clinical presentation, it's a 69-year-old female with hypertension, dyslipidemia, with a previous PCI to meet LAD in 2021. She had a normal renal function and normal LV function with EF of 60%. She had a positive SPECT with lateral anteroseptal ischemia, and she persisted with angina, CCS2-3, despite optimized medical therapy. So this is the angiogram. We can clearly see there is a disease on the distal left main involving the origin of the LCX. In the middle LAD, there was a stent and some kind of diffuse disease. So the idea was to treat the left main and to access both branches. I just showed the distal left main IVUS. We we had an area of 4.3 millimeters square. So we have a lot of plaque and a lot of plaque burden. This is the IVUS after we wired in the LCX. I will show we had a lot of difficulties to wire the LCX and we had to use advanced techniques. This is just to highlight indication of the procedure. We have a severe lesion on that distal left main. This is the pullback from the LAD. So this was the the initial step of the procedure, we wire the LED, and we have a lot of difficulties to wire the LCX. This is a part of the procedure that we use a double lumen catheter. This 2 marker is not a balloon, it's a double lumen catheter, twin pass, and we are attempting to wire the LCX with different wires run through filter FC. So after many attempts, trying to reshape the wire, different bending, and different wires, as we said, we moved for different techniques, advanced techniques, so-called the reverse wiring technique. So it's very important for the interventional cardiologist to recognize this kind of steep angulation entry. It's important for the case planning, and also to change the strategy, because when you have a very steep angulated side branch, you probably gonna have a lot of difficulties to wire because of the natural tendency of the wire to keep going towards angulated branch. And also the wires lose a lot of torque when trying to navigate to this tortuous anatomy. So we can have different angles. It's important to recognize, and also the plaque distribution can play a role in the difficulty of the side branch or side branch access. So this kind of carina angle and carina and also the side branch takeoff is very favorable for the reverse wiring technique. Is the technique we're gonna highlight in this case.
Okay, this is a nice, probably it's going to be a nice example.
So I suggest reading this article that I made myself in 2021 about reverse wiring technique. It's a step-by-step with all the tips and tricks to do this technique. I also highlight some kind of variations of the reverse wiring technique as the so-called streamlined reverse wiring technique that was described by this group of Japanese guys, and all the devices, the materials, the best wires to do this. So it's very interesting if you could read this. So in our case, we use the reverse wiring technique with the support of a double lumen catheter. We made some short of 30 centimeter bending on the filter FC, and we deliver with the help of the twin pass DLC double lumen catheter through the tool heap. And this is what we did. We advanced the hairpin pre-shaped filter FC, and we could do the reverse wiring of the LCX. You can see here it was quite easy. We pull back the double lumen catheter, and the filter FC gently slips towards the retroflex LCX, and we could remove the double lumen catheter. We advanced the FC a little bit further, and we did this pullback of the double lumen very carefully to not lose the wire position. This is the crucial step of this technique, not to lose the position. And we finally retrieve the double lumen catheter inside the guide catheter, and could trap and remove. We start with a predilatation with a 3020 NC balloon, and was followed by a Wolverine 3015 millimeters on the osteal LCX. We decide to use the decay crush technique. This is a stent 30 millimeter DS and a balloon on the LAD site, and we deploy 4 ODS from left main to LAD. We did the kissing, and we did the final IVUS with very good position of the stent, and the carina was very nicely open. And this is the final result of the case. We had a little bit some kind of recoil of the LCX origin, despite our predilatation also with cutting balloon, but from IVUS was very acceptable result. This is another view of the final result, very nice. And as the learning points, the take-home message of this case, during any bifurcation PCI, it is advisable to have wire in both branches. These are crucial steps to guarantee side branch patency throughout the whole procedure. Double lumen catheters are very important tools in the armamentarium to access and re-access difficult side branches. And the reverse wire technique is an important technique to facilitate access to very angulated and retroflex side branches. Thank you very much.
Okay, thank you so much. I think the next next case report will be very similar, and then we can make discussion for both cases together. I think Maciek Lesiak will present his next case, and the case was done by Michael Lesiak, your son.
Yeah, thank you. Thank you, Mirek. Actually, I'm replacing my son who couldn't make it to come here. So, but the truth is we did the case together. And to add some spice to this case, the patient was my classmate, a surgeon. We discussed with him even the option of surgery, but of course he didn't agree, as usually with surgeons. So I have nothing to disclose in relation to this talk. So we have a 61-year-old surgeon admitted to a hospital due to crescendo angina, class 3, no troponin elevation. He actually was admitted to some remote hospital, not mine. They tried to fix the lesion. You will see it soon, but they failed. So this is the angiography done in another hospital. You clearly see that there is a dominant circ, large vessel, and there is something in a proximal LAD at the bifurcation with a large diagonal branch. So as I mentioned, they tried to wire the vessel, but they failed. And why they failed, you can clearly appreciate at the right-hand side of this image, because the wire should go like that. So perhaps I will stop now shortly for discussion. What are the options? We just heard one one solution. Any other proposals?
There are microcatheters now to make life easier. They come in a variety of angles, up to 120 degrees, which may be suitable for this. The other option, if you don't have access to these things besides the reverse wire technique, fortunately, debulking systems tend not to close side branches. So if you are able to wire one of the vessels and debulk the lesion, you tend to be more successful in wiring the side branch.
Yeah. Yeah, one.
And maybe another option could be to inflate a balloon in one of the side branches, so you can reflect the guide wire to the other branch.
Mm-hmm.
I think this is not the first choice. Okay, go ahead.
Yeah, so the point here is you see that the ostium of the LAD is very tightly stenosed at the bifurcation, so that makes it a little bit, unpredictable with just ballooning. Then, of course, a rotation atherectomy would be an option, but still I'm not sure whether we reached this point of debulking just to open the ostium to the LAD. So what actually we did, we first did IVUS, the vessel, because we wired very easily diagonal, and you see that there is a a kind of slit-like ostium of the LAD, very tightly stenosed, and a large diagonal. What was, a good observation is that there is no much calcium there. And of course, we started to think, thinking of reverse wiring the vessel. The only problem is that it is very easy if the problem is only the angulation, but here we have both angulation and very tight stenosis. Anyway, we tried first several wires, very soft polymeric wires like Filder XTR, SUO3, but of course you see the wires, the wire never went into the lesion. And then we tried this technique that was published many years ago by our Japanese colleagues. So you know now how to do this. I will not spend much time on bending like a hairpin shape of giving a hairpin shape to the wire. And this is nice demonstration how this technique works on a patient. So over Sasuke dual lumen catheter, this hairpin wire was positioned distally to the lesion, and then by pulling the wire, you see that we were lucky to reach this very tight lesion of the LAD, angulated lesion of the LAD, and finally we managed to wire the vessel. Then usually you need some wire, another wire to be replaced for replacement. So we trap the wires. You remove the dual lumen. Usually we take just a regular microcatheter to replace the wire for some more supportive wire. And you now after pre-dilatation with 2-0 balloon, you see the IVUS of the LAD. One thing is that the disease was very diffuse. Here you have still more than 50% of plaque burden. So we had to cover a relatively long stretch of the vessel with stents. And this is the calcium at the ostium of the LAD, but generally there was no a lot of calcium there. So we decided on decay crush, so positioning of 2.5 triglutating stents, crushing first with 2.5 balloon, then a proper crush confirmed with boost with 3.5 adjusted to the proximal LAD diameter. Then 2 stents, then of course high pressure post dilatation, first kissing, and 2 stents into the LAD, 1 stent more distally, the second stent more proximally, and you know all the steps, POT, another multiple sequential high pressure inflations, which this is what we usually do in complex 2 stents technique, followed by kissing 10 atmospheres, 2 properly sized balloons, final POT with 3.75 balloon, and this is the final result. You see a huge diagonal branch, very nice opening of both vessels, and of course everything was confirmed with IVUS. That's the distal part of the LAD. No plaque burden above 50%, mid-LAD, bifurcation. You see MSA very nicely, distal 5.7, more than 7 millimeters area. So I think we obtained a nice success. The whole hospital stay of my friend was uneventful. So, reverse wire technique facilitates, of course, wiring very angulated side branches. It works well with soft polymeric wires. So our default is Filder XTR, or in this patient it was SUO3. the hairpin shape should be done within the soft part of the wire, just at the distal port of the wire lumen of the dual lumen catheter, and sometimes you need a single lumen microcatheter to exchange this wire for a proper wire, workhorse wire. Thank you very much for your attention.
Yeah, congratulations, wonderful result. Do you have in your cath lab angulated microcatheters? Super cross?
Yeah, we have super cross which have different angulations. The problem here was the tightness of the stenosis, and you need, for those catheters, you need some space, some room in a vessel to angulate. Perhaps it would work, but given the slit-like, ostium of this LAD, they should be very. I think we could very easily, close the vessel, during this procedure. That's why we tried this one first, and it worked.
Any comment?
Yeah, sir. What was the wonderful case? First of all, what was the MLA at the ostial diagonal, and the kind of carina of the ostial diagonal? Because it pretty appeared quite roomy, and there was some plaque, but the MLA appeared to be good. So the question was about the provisional strategy versus the decay crush we used. So MLA of the ostia, of the diagonal?
Of the LAD?
Of the diagonal.
Diagonal?
Yeah.
That was a large vessel, I don't remember exactly, but that was quite sizable vessel.
So that's the point, that why didn't we go for a provisional strategy rather than going for a decay crush?
Yeah, of course we could, but in this complex situation, we just, wanted to be sure, because that was very, very large. But I admit that it could be done with provisional.
It was the LAD which was difficult to wire.
Provisional and then stenting after, if anything happens to diagonal. But I agree that it could be done also with provisional technique.
I was beautifully shows in the horizontal view the spiky carina and all that, so we can always see that angulation of the branch vessel.
Okay, there was one more question.
Yeah, just one comment. We saw two reverse wire cases, and both showed different techniques of reverse wire. In the first case, when you advance the hairpin, the whole assembly was pulled back. Whereas in the second case, Dr. Lesiak did was that he advanced the hairpin and then pulled back the double lumen microcatheter and just pulled the wire. So there are two different techniques of doing the reverse wire. Generally, what Dr. Lesiak did was actually probably works more easily when you put the reverse wire system beyond the lesion, you pull back the dual lumen catheter and just pull the wire. It is more easy to control, whereas like in the first case, when you pull the whole assembly, it depends upon the orientation of the second port. If it is opposite to the bifurcation, sometimes when you pull the double lumen catheter, the wire also comes out, like was coming out when he was pulling it. So in the second case, he did it in a different way.
Yeah, the point is to point the tip of the angulated wire towards, the ostium of the side branch of the LAD here. Yeah, so sometimes this manipulation is easier when you push down a little bit more distal your microcatheter. Yeah, so it's a kind of play.
And also you can do it before, and also in the coronary artery. There's also two different procedures that you can make this shape of the wire, like in the coronary artery over the dual lumen microcatheter, and also before.
Outside.
So
you can even do the reverse wire with the guiding catheter. When the wire is in, you just float it into the aorta, then push everything. It becomes a reverse wire, and then you wire.
Here is Dr. Evando with us, so.
Yes.
He can comment his case.
Yeah.
Thank you.
Thank you for the invitation. I agree. An important point that I want to highlight is you can also make the hairpin inside the coronary tree. You can wire a distal side branch like a septal branch. You can bend just to keep the memory of the wire, and you push with the double lumen catheter. You wire the side branch distal to the angulated side branch that you want to access, and you can push the double lumen catheter, and you can make the hairpin inside the coronary tree.
This is a variation of the reverse wiring technique. And the other point I want to emphasize, highlight, it's when you do the reverse bending, it's important to do like a gooseneck. The tip of the wire bending, it's the opposite of the bending of the hairpin shape. So you can have a better control of the tip of the wire while pulling back the whole system.
Okay. Very good. Thank you very much.
Thank you so much.
Thank you to both presenters for 2 good cases. We'll move on to the next case, which is a bifurcation stenting of calcified left main with a difficult to wire circumflex from Annette Mazniczka.
Okay, so good afternoon and dzień dobry. I'm Annette and I'm a fellow from Bern in Switzerland, and I'm very happy to be here in this country that I love to present this interesting case about a difficult to wire circumflex during left main bifurcation PCI. And I did this case when I was in the UK doing my CTO fellowship in Leeds. The case is a 78-year-old man who presented with stable angina. He had a stroke 2 years previously. Ventricular function, hemoglobin, and renal function was normal, and he had anterolateral ischemia on a myocardial perfusion scan. The angiogram showed a dominant right coronary artery with no significant disease, and it supplied collaterals to the left system. There was critically severe calcific left main bifurcation disease, which we classified as Medina 111. And there was also severe disease at the OM branch of the circumflex and severe disease in the mid-LAD. After discussion in the heart team meeting, he was turned down for surgery because he had bilateral varicose veins, so there was lack of conduits for grafts, and because the LAD disease was diffuse. The planned PCI strategy was crush left main bifurcation stenting, and we planned to do rotablation to left main and LAD. We used a 7 French Voda 3.5 guide via the right radial artery, and then did rotablation with a 1.5 burr at 160,000 RPM from left main to mid-LAD. Then I used a microcatheter to remove the rotor floppy wire in exchange for a cyan blue wire. IVUS showed deep concentric calcification, especially in the left main and proximal LAD. We took a 6 French guide liner and deployed a Xience 2.25 by 28 stent in the mid-LAD, and this was overlapped proximally with a Xience 2.75 by 38 stent. The mid-LAD stent was post-dilated with a 2.5 non-compliant balloon. Unexpectedly, it was very difficult to wire the circumflex, and prolonged attempts with a cyan blue wire were unsuccessful. So what we did at this point is we did an LAO caudal view, which we hadn't done earlier during our setup shots. And at that point, we realized that the circumflex ostium was retroflexed. So perhaps now might be a good point to pause and ask the panel for opinions on what they might have done differently and how they tackle this circumflex wiring.
I think, it's an extremely difficult anatomy, and I personally would also go ahead with a supercross microcatheter. Another point will be to use here shockwave balloon to prepare the lesion to make it access a bit softer, or to use it primary a larger burr, 2.15, for example, to perform to achieve better debulking progress.
Carlos? Yes, so very interesting case. I think the question, well, now it's too late, but it's why you wouldn't debulk the circumflex ostium as well as the lady. Because also you said before that you had classified the lesion as Medina 111.
Yeah, but this is always the problem with bifurcation lesions. If we have to approach really very severe calcified bifurcation lesions, and if we have to use rotablator or orbital atherectomy, we can have in position only one wire, and that's the point, you know. This is something sometimes very difficult, you know, to rewire. You can have a dissection, whatever, and then some people are very, very unhappy about this. And if you go primary with wiring of both branches, you can use it even shockwave in both options, if possible.
We'll take one more question and then we'll let you continue.
Do you think that after rotablator the ostium of the circumflex became more severe, more difficult to wiring, or not?
It's
because as Mark says, you can start with 2 wires and change the strategy. No?
It's difficult to say. I think what we regret in this case is not taking the LAO caudal view at the beginning. So we didn't have anything to compare at baseline to what it looked like at that point. But the difficulty also was the feeling at the time is we definitely needed rotablation, and so we would only be able to have 1 wire, as was mentioned by the panel already. So I'm not sure if it would have changed our strategy if we'd known about that.
So I think there's probably a nice learning point in that, isn't there, in terms of some of the starting point for procedures like this, in terms of it's easy to jump to what technique we're going to use, whether we're going to use imaging, but that angiographic assessment of the bifurcation as the first port of call in a thorough way often gives you a lot of clues and may save you trouble later. We'll let you carry on, thank you.
Thank you. So the first option we considered was an angulated microcatheter, for example, Supercross 120. But the difficulty is that I'd used the last one of those earlier in the week, so we didn't have any left in our department. So the next options to consider are a dual lumen microcatheter and the balloon backstop technique. So I think this was mentioned briefly earlier, and the balloon backstop technique is where you inflate a balloon on the main vessel wire immediately distal to the bifurcation to enable a second wire to be deflected into the side branch. But if we'd used the balloon backstop technique, this would have caused LAD ischemia. And like the other 2 cases, we decided to try the reversed guide wire or hairpin wire technique. The image on the left shows the setup that we used for the reversed wire technique. We backloaded a hydrophilic polymer jacketed wire into a dual lumen microcatheter, and this wire had a small curve at the tip and then a second 180-degree bend 3 centimeters from the tip of the wire. To recap, as was discussed earlier, we advanced the hairpin curve beyond the target side branch and then pulled back on the wire. And because of the hairpin hook, this enabled the tip to engage into the side branch. So for this reversed wire technique, we used a Pilot 200 wire. And when engaged into the side branch, the Pilot 200 wire was advanced by gentle counterclockwise torque. But unlike the other case, we see the difficulty we have here is that we've got severe disease at the ostium of the OM branch. So we weren't able to advance this Pilot 200 wire any further down the vessel. So what we did is we carefully removed the dual lumen microcatheter and we exchanged for a Caravelle microcatheter. And this enabled us to wire past that tight OM lesion. And then once we had the microcatheter further down, we exchanged for a cyan blue wire. And this process required an anchor balloon in the LAD. At that point, we decided to use intravascular lithotripsy with a 3O shockwave balloon to the left main and proximal LAD. We then deployed a Zients 2.5 by 48 stent from the OM to the ostial circumflex, and when the circumflex wire was removed, we did crush with a 3.5 by 15 non-compliant balloon in the LAD. We then deployed a Zients 3.5 by 48 stent from left main to LAD, and POT was with a 4.5 non-compliant balloon. We required an anchor balloon in the LAD to rewire the circumflex with a Gaia first. And then we de-escalated to a cyan blue wire. IVUS confirmed good wire position, and we dilated the circumflex ostium with a 2.5 balloon. And then we did kissing balloon inflations with a 4.0 NC in the LAD and a 3.0 NC balloon in the circumflex. We had a beautiful final result with TIMI3 flow in the LAD and circumflex. And we also had a good result on IVUS with a left main MSA greater than 10. In conclusion, the reversed wire technique is useful for accessing highly angulated side branches. Limitations of this technique include small main vessel diameter and a severe stenosis proximal to the bifurcation, because this can hamper delivery of the reversed wire system. I'll finish by thanking Abdul Mozid. He was my supervisor in Leeds in the UK. Thank you very much for listening.
Yeah, thank you. Great case. I think, so from my point of experience, I think in 80% of cases you will cross using supercross microcatheter, but sometimes in 10, maybe 20% of cases you need swan neck technique. Yeah.
Mm-hmm.
Any comments? And then there was one more question.
Did you have any concerns about the choice of wire to use in these circumstances, that you're going to kind of retroflex in such a way, disrupt polymer sort of wire damage? Is there anything you wouldn't use for this kind of procedure?
Well, we've done this about 3 times probably, and each time we've used a polymer jacketed hydrophilic wire, and it's actually worked quite well. Perhaps if you had multiple attempts with it and it wasn't working, you could risk damaging the wire, in which case you'd have to bear that in mind and take the wire out and try a different one. But it's worked the 3 times you've tried it.
Yeah, but this final question, yes.
Yes, just that would have been my one remark, that in our experience, maybe 10 years ago, for this technique we used whisper wires, but now we switched to cyan black wires, which is much more of a more friendly wire, because the pilot has the tendency to go everywhere. And we saw that maybe there would have been some subintimal passage on the proximal circumflex, but you're lucky to get the true lumen, and you were lucky to escape with that. But I think maybe my advice would be just to try at least a couple of times to use the cyan black, because that's much more friendly and it finds the true lumen in a lot more options, a lot more cases.
Yeah, I think in every cath lab, everybody should have this best wires available. Okay, thank you so much.
Thank you.
Great case.
Now we are going for the second recorded case from Annika Sabo. Can you
play?
Dear Chairman, thank you for the invitation to present at the EBC 2023 meeting. The title of my presentation is Tackling Abdominal POT at Left Main. This is a case of a 56-year-old man. He came to our clinic with clinical presentation of chronic coronary syndrome. He had history of stage multiple PCI and planned to undergo left main PCI. RCA PCI was performed 6 months ago, and 3 months ago, he underwent complex and prolonged procedure with rotational atherectomy and 3 DCB at LAD and 1 DCB at circumflex. His echocardiography showed regional wall motion abnormalities at anterior wall, and his renal function was within normal limits. This is the left coronary angiogram. We can appreciate that the left main is severely stenotic with diffuse lesion extend to proximal LAD. And at the left main bifurcation, we can see it was Medina 110. And there is also severe stenosis on the distal circumflex. Our plan was to perform OCT evaluation to LAD and circumflex. And if OCT result is supporting, we will perform provisional strategy to left main LAD and spot stenting at distal circumflex. And here is several OCT cutoff images. We can appreciate here On image 1, the left main is severely stenotic with minimal lumen area of 2.6 millimeter square. Astial LED was also diseased as shown in image 2. But astial circumflex was good. However, there was severe stenosis on the distal circumflex as shown in image 5. We proceed with spot stenting with 1 DES at distal circumflex, followed by lesion preparation at left main LED with predilatation with NSC balloon, and crossover stenting at astial left main to mid LED. Unfortunately, both guide wires were unintentionally pulled out. Hence, we perform rewiring. And the next step is POT. During balloon delivery, there was no resistance nor difficulty. And due to awareness of the risk of abdominal wiring, we also check the balloon position from multiple view using stand views, which suggesting true intrastent position. POT was performed with 4.5 NC balloon inflated up to 12 atmosphere. However, after that, we saw deformation at proximal stand segment, probably due to abdominal POT.
Yeah, go ahead with the presentation.
We tried to perform rewiring, which directing, and hopefully could go into the true intrastent entry point. And we also switched the OCT into IFAS because we want to evaluate wire root at the astial segment. And here is the still image of IFAS evaluation after rewiring. Top images are cross-sectional view of point A and B. We can appreciate here on the image B, which is at the astial, this is image B from here, that the wire not intrastent, was not in the intrastent. And the yellow line here is the stem, and this is the illustration. But in image A, which is the POC, we can see that the stent was not deformed here. On the longitudinal view, we can see at the astial, the stent was deformed, and the wire entry point was through the strut, here this time, with intrastent course. And this bottom picture illustrates the IFAS longitudinal view. After several attempts, we still cannot redirect the wire to go into the true intrastent opening. Hence, we decided to perform balloon crush at the deformed proximal stent segment, followed by stenting at astial to shaft left main with 4.09 mm DES, and POT, and also astial flaring with high pressure. And here is the final IFAS run, which we can appreciate here. The stent was well expanded. And on image C, we can see the new stent have good apposition and complete stent coverage at the astial with slight stent protrusion here. On image B, the yellow dot line here represent the crushed stent, and the red dot line represent the new stent. Hence, this side has triple layer with good apposition. And this is the final results, which we're pretty happy with this. And this is the 1-year follow-up, which revealed good results. And to wrap things up, unintentionally pulled out guide wire in left main stenting before POT or ostial optimization can result in abdominal wiring and catastrophic outcome if not detected. IFAS should be considered for use in assisting with troubleshooting aorto-ostial stenting. and managing a deformed ostial left main stent involves several crucial factors, including the radial strength of the stent, wire position, and results of IVUS analysis. That's all from me. Thank you.
Thank you.
Is Aninka now online?
Yes.
Yes. Yeah. Congratulations.
Thank you.
Very nice case. As you already noticed that problem came up when you pulled out both wires from the LAD and circumflex. So, and maybe luckily it was short segmented that the wire went abluminal. So you could do it like with another additional stent just at the ostium of left main. Otherwise, if it would be, for example, the longer abluminal tracking of the wire, maybe it would be more difficult to tackle, to solve it. But congratulations for your case.
Thank you. Of course, it would be difficult if the abluminal wiring is up through the LAD. It would be more challenging.
Yes, but the problem was the stent was 3.0 and the left main was 4.5 or 5. So this was the another problem. Yes.
That's the issue. The proximal LAD is rarely, if ever, less than 3.5.
Yes. Yes.
The initial stent choice would have been better to be a 3.5. Also, of course, in retrospect, it's easy to say, I think it was a beautiful case. You guys saved it very nicely. When you lose wire, you always want to loop your wire when you go back in, so you don't end up behind it. And you could have considered, I think you ended up kind of doing a crush. You could have considered turning it into not a mini crush, but a DK crush if you wanted to open the circumflex. I don't know if you tried to open the struts or not. Well done.
Yeah, congratulations.
Thank you.
Okay, thank you.
We'll move on to the last case. So the last case presentation from Victor Sassi, modified gel balloon technique and double kiss culotte with IVUS guidance for left main PCI in the acute setting. Thank you.
First, I would like to thank you for the organizers and the community to let me present one of our interesting cases. And let's just go on with the case, okay? So it's combining some techniques, and sometimes you need to think that there is some potential risk of losing one of the vessels that you try to treat. So I would like to present one of our cases. It's about a 68-year-old male. He has risk factors of smoking, hypertension, hyperlipidemia, some peripheral artery disease, and some non-significant carotid artery disease that was proven before. And in the gym, he just felt sudden chest pain and just collapsed. And to his luck, there were a couple of people that tried basic life support, and there was an automatic defibrillator there that gave 2 shocks, and then the patient was transported to the emergency room. Now, since they were not sure what was going on, at first they tried to clear if there's nothing wrong in his head and maybe there's no bleeding. So that was cleared with the CT scan, and also CT angiography just ruled out some pulmonary embolism and aortic dissection. On his initial ECG at the emergency room, there was sinus rhythm and some anterior lateral ST depression, and there was bedside echocardiography performed, and that showed about 40% of ejection fraction, anterior and lateral wall hypokinesia with no major valvular disease, and then the patient was transported to the cath lab. I would like to highlight on the images here that maybe the circumflex bifurcation is just one problem to solve, probably, and also the LAD ostium was quite hazy, and we saw ST depression on that, and there was a basically right coronary artery that was not playing a role in his task and in his life, probably. Now, at the initial case solving, what we did was we did a double kiss culotte to the circumflex marginal branch, and we did the LAD from the ostium, and you can see from different planes that I think we were quite satisfied with the result, and that's when we just finished the case. And after that, it was an uneventful for the patient. It was uneventful recovery, but after a couple of
weeks, or maybe not weeks, but 2 months or 3 months, the patient started to complain about some chest pain, and once when he felt that it was very strong, he just returned to the emergency room, and he felt that he needed to go in, and because he was afraid of another infarction. Now, the patient at this time was with slight troponin rise. He presented with some ST depressions also, and on the control angiography, this is what we saw. It was 4 months after the procedure, and we can see that the circumflex and the marginal looks patent, the LAD stent and the LAD course looks patent. So what we can see that the LAD ostium, the distal part of the left main, and the circumflex ostium looks very diseased. So what we did is did IVUS, and on the IVUS, the LAD stent, even the distal part, was quite okay. We were quite happy with that. We did IVUS run to both sides of the circumflex, and what we saw that the opening of the marginal branch was excellent, the opposition was excellent, and the double kiss part, the double layer part of the double kiss culotte was excellent. Now, if we move on, yes, to some still images, you can see some haziness on the left main and the both osteums, and the distal part of the left main was quite diseased. So that was when we started to talk with the patients, and there was a short discussion with the surgeons, so that they said that with the IVUS results and also the syntax score we just calculated just bedside, that and also respecting the patient's will, that we were thinking of doing PCI for this particular patient. Now, we didn't want to get into trouble, so at least we tried to palpate, or at least try to do kissing pre-dilatation with just 2.5 millimeter balloons, just to see how it's expanding, or if there's something else that we need to treat. And we thought that we would go on with double kiss culotte since it worked before, and I'm just a big fan of that. I must be a believer of that. And that's why we implanted the first stent. It was a 3.5. According to IVUS, it was a 3.5 millimeter stent. Now, I was absolutely afraid that maybe just because of the plaque in the LAD ostium, absolutely afraid that maybe because of some plaque movement or plaque shifting or maybe coronary shift, that we would lose or at least we have a decreased flow in the LAD. So we also used the modified gelled semi-inflated balloon technique with a 2.5 millimeter compliant balloon, just to have the vessel open at all times. Now, if we just move on, this is the this is the angiography just right after pulling back the stent balloon and the 2.5 millimeter compliant balloon that was placed in the LAD ostium, and you can see that the flow is patent in all the course of the LAD. Now we did POT with a 4.8 millimeter balloon, and after POT we can see that the rewiring of the LAD was quite simple, and it was quite easy to do. Now the next step would be we open the cell towards the LAD with a 2.5 millimeter balloon. We did the second kiss with a 3.5 millimeter balloon, and according to IVUS, I did use a 4.18 stent from left main to LAD. After that, just an image just to see and why double kiss is important, and just to show that the stent part in the transition zone is not elevated towards the middle of the left main, and that's why, and also with the POT once again, and the re-kiss, and probably re-POT after that. Now, I'm just trying to show you some images of the LAD ostium and the circumflex ostium, which we were quite happy with the result with the stent areas. Final POT was performed with a 4.5 millimeter non-compliant balloon, and IVUS was performed also just after towards both directions, towards the circumflex and also the LAD, and we were quite satisfied with the opposition, and we were quite satisfied with our result. And I'm going to show you the last moving images And if you appreciate, I think this is a still image, and also these are the moving images that look, I think for me, and as according to IVUS, we were quite satisfied with the result. We didn't see the patient only just for a treadmill test after that, and that was patent, so the patient has not been to the cath lab ever since. Now, I have some, at least case learnings, at least for myself, and maybe it's just some thoughts to raise for different operators also. For complex left main bifurcations, I think imaging guidance is really helpful, which we all know that. Acute coronary syndrome could potentially worsen the outcome of the unprotected left main treatment if we choose PCI. And if upfront two-strand strategy is needed, which in this case I would have been, well, not really, I would have been very nervous to leave it like this, that I was very keen on using this two-strand strategy. Culotte could be a good option. In the setting of acute coronary syndrome, the modified gel balloon inflation during the stent implantation towards the other vessel can absolutely be helpful to have patent flow during the whole course of the procedure to avoid plaque protrusion or plaque shifting. And if dissection would limit flow in the vessel to be stented secondly, conversion to DK crash is also an option because we always have the vessel and we have the way to go. As verified in earlier publication, if planned two-stent strategy is chosen, double KISS would warrant, or at least we must have thoughts that it is absolutely much better stent position in the crucial locations of the bifurcations. And if anatomy is suitable, we had a publication in intervention with that. Double KISS culotte should be utilized. I'm absolutely a believer in that. In the setting of ACS, modified gel balloon technique can help keep sufficient flow in all treated vessels during the course of PCI. Thank you very much for your attention.
Thank you.
Thank you. We've got a couple of minutes for some final questions. I'll start the ball rolling. So you seem very convinced about double KISS culotte in this setting. Can you just sort of elaborate on that for us? And is there evidence base to support that experience?
Yes.
How are you making the choice?
Yes. I think angiographic images would support that there is no big difference in the vessel size of both sides, both daughter vessels. And the angulation would, I think, for me and for myself, and we did with Gabor Todt, we had a Euro intervention we had some publication on that, the double KISS culotte and the flow after that, and for later, it's probably better than DK crash. And that's the reason that we are absolutely believers in double KISS culotte, but sometimes you need to modify double KISS culotte if you are afraid of losing one of the vessels or maybe the vessel to be stented secondly. So that's why we must know that sometimes gel balloon technique, if we don't want to, if we just go on provisional stenting with a balloon to vessel ratio of less than 0.8, would also help just to keep sufficient flow in the vessel, not to be wanting to stand.
Okay. I guess I would just highlight, though, in your comments there that you commented on the angle of the bifurcation, and we've seen some cases today with very extreme angulations where double KISS culotte might not necessarily be the choice you would take.
Yeah. Would you consider gel balloon technique in all bifurcation cases, Medina 111, or just for a complex bifurcation according to, for example, definition to study? Because this one in ostial LAD there was no plaque burden more than 10 millimeters in LAD, or maybe I didn't see.
Okay, but you see that the LAD ostium was not stented. So if you just, I mean, the stent was like 1 or 2 millimeters. We proved it with IVUS that I would not be able. I think for me, it's not an option to leave it like that. So if you treat left main circumflex like that, and we treat it like that, untreated, unstented. So I think that in this particular case, no. But I think gel balloon technique has its advantages in acute setting for sure. If we use provisional technique. And if the lesion of the daughter vessel, I mean the vessel, or maybe just the side branch, if we don't want to treat or we don't want to stent, then I think for drug-coated balloons for later years, and maybe just normal semi-compliant balloons, not to cause any dissection or perforation, would be probably a good option.
Okay,
thank you. Another just question regarding the length of the jailed balloon, because there is like a jailed balloon technique and modified, like the shorter one, which is just.
In 5 or 6 years ago, we started in our cat lab with one of my friends. We started to use this technique, and we have good data on that, and also Francesco Burzotta is here, so everyone in Category is here. So I think I don't have to explain some of that technique, but nowadays, not to have a stent distortion at the proximal part of the main vessel stented, my personal belief is going to modified jailed balloon technique.
Just one clarification for the jailed balloon. When you were implanting the stent from the left main to circumflex, the balloon in the LED was inflated, or it was?
Absolutely, it's 12 atmospheres inflated. That's why it's semi-inflated. Not to cause any trouble, not to cause any dissection or perforation, just in case. Just in case, just to keep it open. That's all.
Okay, we'll need to stop there.
Okay, thank you. Thank you so much. In summary, dear colleagues, so we saw today really very difficult cases, well done by usually 2 operators, which were staying for even few hours. And what we can summarize, of course, you need skills. Of course, you need special devices in your cath lab. And what I personally also believe, if you have very difficult anatomy, then you can check the strategy and final result by imaging. And all cases were perfectly done. Thank you so much. And now we have 30 minutes coffee break.
Right. Okay, hello to everybody. Welcome to the afternoon session, 2:45. First comment, Bernardo Cortese, he's not here. He's got a viral condition called COVID.
Yeah, strange.
Yeah, that's very strange. I thought that was a few years ago. Let's call up the panel, please. Doctors Lucic, Rathore, Brulik, Wakutsu. I shouldn't have started that, should I? Chiwani and Yakovu, please come up. Right, everybody's still having a cup of tea, and we're going to ignore that. I haven't seen Xiaoliang Chen yet. Ah, okay. So, thank you. So, we're very lucky to have Xiaoliang Chen talking to us about his DCB study. This is going to be a very interesting and potentially controversial session. So I don't know, I'm going to look at the IT crowd and say, have we got a link to Xiaoliang Chen? We do.
Hi, David.
Xiaoliang,
good morning.
How are you doing?
Hi, how are you doing? I'm doing very well. Thank you. So let me share my screen. So can you see my slides?
Yes, we can.
Oh, thank you. Once again, congratulations to the success of EBC meeting in Warsaw. I cannot be on site to meet all my friends. Also, I thank the organizing committee to invite me to present the rationale, design, and the current status of DCB bifurcation trial. This is our new bifurcation trial. So this is a study flowchart. I tried to simply summarize the study design. So at the beginning, so the patient should be in true corner bifurcation defined by Medina 111, 011, or 101. But the side branch diameter should be minimal 2.5 millimeters, and the lesion length must be shorter than 10 millimeters by visual estimation. So following the step provisional standing technique, so we need to wire the main vessel and side branch. After standing main vessel, after port technique, if the osseous side branch lesion length greater than 70%, so the patient will be randomized to provisional standing with NCB convention non-compliant balloon group compared to provisional standing with DCB group. So basically, after port technique, so in both groups, we need to use a NC balloon to dilate the side branch. But in DCB group, after NC balloon inflation, so we need to use the DCB to dilate the side branch again. After dilating side branch, we have to do kissing balloon inflation with NC balloon in both groups followed by final port technique. So after balloon inflation, if TB blood flow less than 3 or the presence of type 3 calcification in the side branch, so additional side branch stent is recommended. So in general, for this trial design, we have to enroll simple bifurcation lesion according to the definition criteria. Standing main vessel, then NC balloon inflation or DCB balloon for side branch. This is a multi-center randomized clinical trial. Before the design of this trial, we need to know, should we pre-dilate side branch before standing main vessel or dilate side branch after main vessels standing? So this is a test to measure how many particles scratched from the DCB from the balloon. So the left figure, you can see most of the particle diameter is less than 3 micrometers. On the right panel, you can see if there is standing in the main vessel, So crossing the DCB into the side branch would increase much more drug sound from the balloon scratched by these metal stent struts. So finally, you can see the number of particles greater than 1 micron increased by more than 50% if there is a stent in the main vessel. So finally, I decided we have to follow this provisional stenting technique. After stenting main vessel, we can use the DCB for the side branch. This is the organization of our trial. So the primary endpoint is a MACE at 1 year follow-up, including cardiac death, myocardial infarction, or the clinical-driven TLR. Secondary endpoints including all-cause death, myocardial infarction, revascularization, including either TLR or TVR, incident stenosis. Also, crossover rate from 1 stent technique to 2 stent technique. Safety endpoint is a stent thrombosis. This is a calculation of sample size. Basically, the assumption is that in provisional stenting with NC balloon group, so the 1 year mass rate will be 17%. But in the DCB group, it will be 10%. So finally, including 10% loss to follow-up, so a total of 784 patients was required. So these are the general requirements of inclusion criteria: Medina 011, 101, or 111 true coronary bifurcation lesion, side branch diameter minimum 2.5 millimeters. But the key point is that side branch lesion length should be shorter than 10 minutes by visual estimation. And also, after stenting main vessel, they also show side branch stenosis should be minimal 70%. So let's go through one case. This is tissue left main Medina 111 true coronary bifurcation lesion. So we wire the RID diagonal as well as circumflex. So after stenting main vessel from RID to left main with an jet wire in circumflex. So after stenting main vessel, we perform sequential port technique to make sure the full expansion of the stent. After port technique from the apical, you can see osteocircumflex stenosis greater than 70%. So the patient was randomized to our DCB bifurcation trial. So firstly, we use the NC balloon to dilate the osteocircumflex. So after the NC balloon dilation, we use a DCB, a long DCB, to dilate the whole lesion length from the circumflex to the left main. After DCB dilation, we perform the final kissing followed by final port. Even still, there is a compromise at the osteocircumflex, but it looks much better. So finish the procedure for this patient. Thank you very much. Thanks for your attention.
That's great. Thanks very much, Xiaoliang. Stay with us for a few questions. And just a show of hands, if you can, from the audience, who currently uses drug-coated balloons in the side branch ever for bifurcation? Oh, the word ever prompted some hands. Okay, okay, fair enough. Some questions, any questions from the panel for Xiaoliang about this interesting study?
Do you hear me? Yes. Do you have any protocol for predilatation of the side branch? Precise protocol? How many inflations? How many times do you use any scoring balloon? And what are the criteria for successful predilatation of the side branch?
Yeah, it's a good question. According to the provisional stenting technique before stenting main vessel, so we do recommend to predilate the side branch using scoring balloon, cutting balloon, or any other devices. After main vessel, standing main vessel, I think it will be not easy to use a scoring balloon or cutting balloon for side branch. So we only recommend to use NC balloon to dilate side branch before DCB. Thank you.
What is the criteria percent of the residual stenosis after the predilatation? If you have to bail out stenting of the side branch, what would percent of acceptable residual stenosis will you define? What will you define it?
Yeah, I think I can show you this slide again. Can you see my slides? Actually, after dilating side branch, if the side branch TME flow less than 3, or if there is a type 3 dissection in the side branch, we will deploy the additional stent in side branch. So it's independent of the side branch diameter stenosis.
Great question from the floor.
One question, Dr. Chen. You said that the side branch length stenosis should be less than 10 millimeters before we include them in the study. But the case that you showed, the drug-coated balloon looked like much longer, looked almost 30 millimeters in length. And not only that, after that, we use a short balloon to do a kissing balloon dilatation. I mean, don't you think that would influence the way in which we're going to do something about the side branch? Because we're putting in a long balloon and then inside that a short balloon in a dissected segment. After all, a balloon is a controlled dissection. So is there some subgroup in which you're going to look at the length of the balloon that we use, the DCB that we use in the side branch?
A very good question. This case was not included in the DCB bifurcation trial. Basically, we tried to include the patient in the trial. But as you say, because we didn't have the short DCB balloon at the same time, so finally we did not include the patient in the trial. In China, before the initialization of this trial, we didn't have a short NCB balloon. So minimal DCB balloon length, I think, will be 15 millimeters. So for some cases, it's not easy to use it. It's not good to use long DCB for the patient.
Hi, Shaolin. This is Sudhir here, Sudhir Rathore. Could you just expand more on your sample size calculation? Like you said, primary endpoint of 17% versus 10% in DCB and NC balloon usage. So is that based on combined endpoint of cardiac death, TLR, clinical TLR, and MACE events, or?
Yeah, thank you, my friend. Actually, the primary endpoint is 1 year MACE. So according to our previous DKQACI-2 trial, which included all bifurcation lesion. So from that study, we extracted the subgroup for patients with simple bifurcation lesion. I mean, the side branch lesion length shorter than 10 millimeters. And also we calculated the 1 year MACE rate. Also, we have our DKQACI-7 trial. Also, we get the 1 year MACE rate from these 2 trials. So finally, we estimated the 1 year MACE rate in the NCB group will be 17%. So finally, I think this calculation, this estimation is very similar to the EBC main trial. But EBC main trial is only for distal left main bifurcation lesion. I think it should be a little bit different. This is the reason why we calculated the final sample size was 784 patients. Thank you.
Thank you very much. Two last short questions, and then we're going on to the next session.
Hello, it's Olivier. A question, your DCB is plaquette accelerating, and if you put a second stent in the side branch which had the DCB before, what would you put in terms of drug or bare metal or drug eluting also, but a different drug? What do you put?
Yeah, exactly. for this trial, paclitaxel-eluting balloon is only available in China. So after DCB, if we need to deploy a second stent in side branch, there is only one choice of using sirolimus-eluting stent. So I think this is a combination of different drugs from DCB and also from stent. But from previous animal study and also clinical trial, there is no any conflict report about the side effect of the combination of the paclitaxel DCB with the sirolimus-eluting stent. Thank you.
Very last one.
Dr. Shen, just wanted to ask a question, because in this we are only treating the side branch after we've already implanted a main branch stent. So do you think that calcified lesions can be enrolled in this trial, because we don't have an option of using cutting balloon or rotablator if it is a calcified ostium of the side branch, even if it is a short lesion?
Yeah, very good question. Because my presentation is very short, I think I could not very clearly present the study protocol. Also, we have many exclusion criteria. For example, if there is greater than moderate or severe calcification in side branch, patient should be excluded. So actually, for simple by true coronary bifurcation.
Okay, fantastic. Thank you very much indeed, Xiaoliang. The music's slowly getting louder, so we're going to move on. Franz Kleber is going to come and talk to us about the current evidence supporting DCB use. Franz.
Thank you very much, Chairman, ladies and gentlemen. I think it's wonderful that the DCB and the EBC world meet here, and I think I'd like to thank the organizers for inviting me. I have no conflicts of interest. So actually, treatment of bifurcations with DCB is far more than 10 years old, and still we don't have a lot of data, really. What was the reason why we really got into bifurcations? Well, one reason, we have less or no carina plug shift with a balloon contrary to stent. We have positive remodeling of the ostium of side branches. We have the easiness of the procedural workup, and we have good casuistic cases. So let me introduce you now through the history of this development, what we have. We don't have a lot, I have to say. This actually is a case I presented 12 years ago at the Asia PCR. You see the LAD D1 bifurcation with late follow-up. One of the first studies was done very early when we had instituted the, at that time, German drug-coated balloon group, and did the first consensus paper. This was a study with a DCB in main branch and side branch, and a BMS in the main branch. At this time, we thought that the combination of a DCB and a BMS would give a good result. You see the result in the side branch, where only the DCB is quite good, and the main branch is not as good. Then the debut study was performed. Problem of the debut study was that the DCB was without an excipient, and you see three groups, one with the DCB, and one with the bare metal stent, and the third one with the DS, and the DS was better than, of course, because this was basically similar as a regular balloon. The next study I have to mention is the Babylon trial. Here you see a bare metal stent again with the DCB in the main branch and side branch, and the DS in the main branch. And what you see here, if you go through the data, you see that the side branch restenosis rate, the DCB group is quite good, while in the main branch there is the DS is better off. Then we have the study by Harador, not randomized, 50 patients in each group, serially performed. And basically, what we can compare is the DCB in the side branch versus POBA in the side branch. And here you see a huge difference, both in MACE rate, as we just heard, 11 versus 24% MACE, and late loss 0.09 versus 0.4. So in the side branch, much better results with the DCB. Then the study BioLux 1, and again we look here at the late loss in the side branch, 0.1. Again, a good result in the side branch with the DCB, and this was for the first time a drug-eluting stent, not a paclitaxel, but a limus-eluting stent in the main branch. So this was a step from BMS to paclitaxel-eluting stent to limus-eluting stent. Very similar Sarpedon study, also a low late loss in the side branch with the DCB, similar procedure. And then we have the Chinese study by Qing, Beyond study, and here we have again the DS in the main branch and the bingo PCB in the side branch. Astonishing to me that they had really Medina 111 in about 90% of the cases. Hard to achieve really, but they had a lot of cases. And the major endpoint was QCA, target lesion stenosis, 28 versus 40%. All differences highly significant for the side branch. Similar as in the other studies, but this now is a randomized trial. You see diameter stenosis 22 versus 34, late loss here for the first time, a minus late loss, so a late lumen enlargement in the side branch versus 0.18. And then we have the depth side study with a dedicated bifurcation stent, a NIRPAC stent, and the PCB in the side branch. And again here, a negative late loss of 0.04. So this goes basically through the studies, as you see. And then we have the first observational study, actually from my group. Antonio Schulz presented this data with DCB only in both branches. And you see here in the side branch, which we look at here, again, 3% restenosis rate, and the distal main branch 6.6%. Then we have the registry by Leonhard Bruch, also a former co-worker of mine. He presented 127 patients. A little more than half of them had bifurcations, 53%. And for this group, the DCB only group really showed good results, as you see here below. Actually, oh, sorry for this. You see here, this is the DCB only group, and this is the DCB group plus stenting, DS stenting. Then we did, in my group, the first small randomized trial, DCB versus POBA in the side branch. The Medina 111 were excluded, so the main vessel was excluded. Some of the investigators were worried at that time, and you see the MLD was similar. Follow-up was the MLD was better. At follow-up, late lumen loss was considerably different, and binary restenosis rate 6 versus 26%. I think this is from the data I showed you now. Every study showed the same. This is now in a randomized trial. I think the side branch DCB is clearly better than a POBA in the side branch. So, do the next. And then I think this is a very important small mechanistic study by the group of Dr. Shin. Her published this data, and they basically used the DCB only in the main branch and looked by OCT how do the side branches behave. And as you see here on the left, this is the early result with the dissection. And you see, this is the ostium of the side branch initially, and after 9 months follow-up, you have this opening of the side branch, which is clear. If you open the vessel by the drug, if you have positive remodeling, also the side branch has to open up. And she could really show this very, very nicely. And this is here more downstream in the side branch vessel. I think this is a very, very important study to show that you don't have necessarily to touch the side branch, really. And this is again from her data, because you see the mechanism here in the main branch. You have the initial improvement in lumen, and then it continues further due to the drug. And in the side branch, you don't have the dilatation, but you have the improvement in lumen caused by the drug, which is there at the side branch ostium, and actually the side branch luminal area increases quite considerably from 1.0 to 1.4. Yes, I think this is about what we have. This is a bifurcation we did with long DCB application, 7.7 centimeters overall. You see the late follow-up. We actually did the late follow-ups earlier than usually, already after 4 months, because from the pathology standpoint, and I talked to Reni Vermani about this, nothing happens anymore after 4 months of DCB only application. So let me briefly summarize. DCB in bifurcations is a promising and established technology. DCB, having been around for over 12 years, has still a shortage of data, a huge shortage of data. DCB in side branch and DS in the main branch is more widely proven than other technologies and more widely accepted. The DCB with a bare metal stent is no more in. We should not do that. And the DCB sequentially applied makes bifurcation treatment more easy. And I think that positive remodeling and less or no carina and plug shift are the determinants of the beneficial effects of DCB. Thank you so much.
Fantastic, thanks. Let's open it for discussion. I'll start. What happened since 2016?
Too little, as you see.
Yes. Why?
Well, there, of course, are some data from large studies with subgroups, but I don't think that subgroups bring us any further. I think we really have to have dedicated data.
I agree with you. There was this meta-analysis from Megali and collaborators from 2018, and they only included basically 4 trials at that point, and it was in 2018. And up to this date, we don't really have a lot more randomized trials.
Questions from the floor.
The data is so scarce and it is so fudged up that probably the questions are also not going to come up, because I think the usage is so low. It's just anecdotal. Predominantly, you use it for our understanding probably of drug-coated balloons comes from restenosis, instant restenosis, where you know that it performs well. Extrapolating that data to side branches, to main vessels, to left main bifurcations, I think, I mean, if you believe in the fact that you're not going to leave any more metal in that bifurcation if you're going to use a DES, a drug-coated balloon, sorry, nothing beats that. I think.
I don't agree that the data are anecdotal. There is a number of centers which just uses the DCB as default, and this for 10 years. And if it's so bad, if it's so anecdotal, it wouldn't be like this. But I agree that we have to do a proper study for this. This is correct, and I think then we have what we need and want.
Yeah, I kind of agree with it. Yes, because when we had a show of hands, everybody in the audience have used drug-coated balloon in bifurcation setting, despite being any solid like randomized controlled trial or a clinical trial. And it does make sense. Obviously, we don't have data because we have not conducted a randomized study, proper randomized study, which is relevant clinically. Because obviously, if it's a small side branch, you won't be looking for mortality benefit and things. So I think it has to be done in a large side branch, left main setting. There it will have impact on TLR and clinically driven TLR and myocardial infarctions, and even if you avoid 2 stents, reduce stent thrombosis and mortality reduction as well. But we need to test it, test the hypothesis.
I agree, not for the side branch only. The side branch only, I think, is clearly shown in two randomized trials. We don't need anything for the side branch, but we need for the procedure itself, do we need a DES in the main branch, or should we not use a DES in the main branch, and what does this to the bifurcation and to the plug shift and all these things? I think this is important.
Question from Professor. Do you have some specific data regarding the type of the side branch for which you use the DCB? Was that, I mean, the size, was it proximal, ostial and proximal? Other data, because if we generalize for all side branch DCB, I think we will not, the data will be diverse. We need to know more details, which side branch you promote for the DCB better than second sense.
I think what we learned is that the ostial side branch has a clear benefit because it also has the drug from the main branch. If you have long lesions in the side branch, I think they will behave like other small vessels.
Okay. Thank you so much. And I would like to introduce Simon Eccleshaw, and he will speak about the need of IVUS more or less during DCB treatment.
Great, thank you very much. My name's Simon Eccleshaw from the Norfolk and Norwich in the UK. That's the title of my talk, Do we need IVUS more or less with DCB treatment? So my personal view is less. Currently we use it very rarely in our centre and we do an awful lot of DCB work. I guess we better look at what data there is out there, and actually, a bit like in the last talk, there isn't much. So, imaging and DCB. Well, imaging we know for stents is really important to plan the procedure, tell you how you've done your lesion preparation, and then optimise the stents afterwards. It may be helpful for in-stent restenosis and is strongly advocated in the further treatment of it, particularly identifying the cause of stent failure. Franz has just told you about late lumen gain at the ostium of the side branch, which I think is particularly pertinent here for a bifurcation discussion. And yeah, it's all about main branch DCB really. So what else is there out there about IVUS in the study of DCB? Well, there was a retrospective study of cases from 2014 to 17 published by Konishi. 900 DCB cases, 240 were de novo, only 188 were eligible for their retrospective analysis. Essentially using lots of good lesion preparation, what they showed that target lesion failure was predicted by a residual plaque area of around 60%, and that seems to run through some of the data that we'll see in a minute. So there is one study that I could find which is looking at the use of IVUS versus angiography to guide drug-coated balloon in de novo vessels. It's called Ultimate 3. It's in high bleeding risk patients. It's between IVUS and angio guided for de novo with a sequent please balloon. 7-month angiographic follow-up with a primary endpoint of late lumen loss, secondary endpoints at 6 months. As far as I can work out, it's still recruiting. So what about IVUS guiding balloon angioplasty rather than DCB? So we're now going back about 20 years. In 2000, it was shown that if you use IVUS, it promotes larger balloon size. Larger balloon size means more vessel dissection. And the IVUS criteria for dissection grades from none to a partial tear to 50 cent plaque diameter into the media with secondary lumen were not predictive of early complications or late restenosis. In 2002, there was another study showing that MACE with residual dissection was again predicted by IVUS area stenosis for around 60% or more. And then more recently, but still 20 years ago, the BEST study looking at aggressive IVUS-guided balloon angioplasty. They were so aggressive that they had to bail out in 44% of cases, and they were bailing out for flow-limiting dissection and greater than residual 30% residual stenosis, that's on angiography, and IVUS greater than 30% area stenosis or less than 6 millimeters squared MLA. There was no difference in TVR, but in those that were stented in the balloon group as compared to the stent group, there was a lower restenosis rate, which would suggest that if you do really good lesion preparation, your stents do better. So, because there isn't much out there, I thought I'd share a little bit of our data with you. I alluded to this a bit last year. We've been working on the data a lot more since. So we've got between January 2015 and November 2019, over 2,000 bifurcation lesions as defined by EBC ARC criteria. We're a big... What happened? Oh, thank you. We're a big DCB centre, and within that 2,100, just over 1,000 were DCB only. That's main branch, side branch, everything. And of those, only 3% used intravascular imaging, which is why it's pertinent to this talk. Just over a little bit more, 1,080, was a stent-only strategy. We removed any that were hybrids. We then propensity matched them down to just under 1,000 in each arm, which tells you already that those big groups are very closely matched anyway. So we propensity matched 1,996. The median vessel diameter of the largest device, stent or balloon, was 3.5. So this is a big vessel cohort. 20% were true, as in complex bifurcations. We got the data in a number of ways. We linked to NHS Digital for death. We get what's called HES data, which is hospital episode statistics, which is every episode that the patient is admitted to hospital is coded with diagnosis and any procedures. And we also get NICOR data, which is National Institute for Cardiovascular Outcomes Research. Every case that we do in our lab, in every lab in the UK, has to be reported to the national body. The national body then feeds into NICOR. So we know if our patients end up anywhere else in the country having a further revascularization. So the composite endpoint, bifurcation composite endpoint for long-term follow-up of these propensity matched patients, as you can see, show a significant benefit to DCB as compared to stents. The p-value is there for you to see. Within that, it's mostly driven, interestingly, by TLR, with an increasingly significant difference between the two. We've actually did a landmark analysis because somebody suggested we did it, and the interesting thing is that it's virtually all late TLR, and actually in the bifurcation group, it's virtually, in the DCB group, it's virtually a flat line after the first year, and this is something that comes through in some of the other studies of DCB de novo work. After the first year, you've got that tiny attrition rate because you have coronary artery disease, but you don't have that attrition rate because you've left a stent in there. Sensitivity analysis suggests that most of the benefit actually is in the more complicated bifurcations. So, and that was all with virtually no intravascular imaging in our balloon group. This is a case of mine that I found that where we did use IVUS, and the reason why we used IVUS, as you can see, top left, a rather complex but very big left main stem. We used IVUS to tell us that actually the left main was 6 millimeters, the LAD was 6 millimeters, the ostium of the circ was okay. So all we did was drug-coated balloon angioplasty, left main into LAD. Didn't need to treat the circumflex. So top left is pre. Hopefully you can spot that that's worse than the others. The middle one is immediately at the end of the procedure, and the way we did it was the largest Scoreflex balloon we could find, which was a 4.0, the largest paclitaxel DCB that we could find, which was a 4.0. It was a very underwhelming result, so unusually we post-dilated it with a 6 millimeter non-compliant balloon. Far right is a 3-month follow-up, again showing late lumen gain. So that's one way you can use IVUS in your DCB de novo work. Some of you may have heard of the solution study. This is a case that Andrew Venices from Nottingham has said that I could share with you. This is from the solution study, a patient randomized, obviously, into the solution drug-eluting balloon arm. Here's Andrew doing some lesion preparation in an LAD. It's a big vessel. These are 4.0 and 4.5 balloons. Rather nasty looking dissections there. Don't know whether people feel that those are ones that you would accept or that you would need to stent. So to my mind, in this, there's essentially two bits to look at. There's the LAD diagonal bifurcation. On the top of the LAD, there's a dissection. The contrast there is clearing. The other dissection is at the ostium of the LAD on the underneath in this view, and you can see the contrast is tracking back into the distal left main stem. So that's one view. There's another view. So the distal dissection now looks a bit more complex, but again, all that contrast is still clearing and it's TIMI3 flow. The one at the top in the distal left main stem, however, there's some contrast that's tracking back towards the left main stem and seems to be persisting. So persistent contrast, generally, you're told you shouldn't accept that and you should stent it. Another view. What do people think? Stent it or leave it? So what Andrew did, because he's a very keen imager, he used an IVUS. And I asked him afterwards, tell me about the IVUS criteria for this, because I wasn't aware that there were any. His reply was he used OCT criteria for leaving dissections at stent edges, and he decided, based on this IVUS run, although there is extensive dissection, none of it fulfilled the criteria to require stenting. He didn't stent it. The patient, according to him, has done very well and remains in the study. So, in conclusion, de novo DCB is still a work in progress in its own right, and there are big RCTs out there now. Intravascular imaging is important in PCI, particularly in the context of stenting and scaffolds. It's not yet found its place in DCB-only PCI, and we shouldn't forget physiology as well. Thanks very much.
Thank you so much. There are some questions. Eve? Oh.
I have seen recently, it was last week, a presentation by Antonio Colombo. He was piloting the procedure of DCB only with physiology, FFR. Have you the experience of this instead of IVUS or OCT?
I know Antonio is very keen on using physiology, particularly to predict dissections that can't be left. Anecdotally, I've seen a few. Generally, we don't actually work on the pressure wire for our DCB angioplasty because we're not good enough operators and the wires don't behave very well in our hands. So we use pressure wire a lot to decide if we're going to fix, but then we work on a normal wire. So I don't have much of my own experience of it. Generally, if we do have it in and we're looking to see a result, to my mind, all you need to do if you're doing DCB-only angioplasty is turn a vessel that is ischemic with whatever parameter you're using to non-ischemic, and then you rely on the late lumen gain as long as it's a safe result.
So in 1981, Grunzek did 3 balloon PTCs of the left main at Emory, and 2 of them died. So it's somewhat cavalier just to leave balloon in left main and not stent it. And because there is a risk of sudden death, even though the left main is large. And I think I'd be very wary of doing this without a stenting procedure, even though it's with a large stent size are available now. Is this just historical? You just don't balloon the left main and leave it alone?
We do, and there are published series now showing safe results.
Most interventionals will not do it.
The last case that you showed, it was a clear-cut spiral dissection from the ostium of the LAD, and it stopped at the bifurcation. So, I mean, it's the gentleman said that the patient is doing well, but I think most of us would stent it. So it will be very interesting to show this gentleman's follow-up, say 4 months, 3 months. I would just say the entire dissected segment would have healed by 1.5 months. Just do an IVUS at 1.5 months, 2 months, just to see how things are. So even if there's a 60% narrowing, he would still be asymptomatic.
So if you have a dissection, your restenosis rate is lower than if you don't have a dissection on angiography after balloon angioplasty or after DCB. Because the dissection, as long as it's a safe dissection, is telling you that you've done an adequate lesion preparation.
So I agree with you, but the dissection here appeared to be a spiral dissection, which if you follow the basics, and these spiral dissections get worse, number one.
Sure. But
Secondly, your injection, your injection makes the dissection worse. So just very low pressure.
I'm sure there are people in the room a bit like us that have done an awful lot of DCB angioplasty, and you don't make iatrogenic dissections from balloon angioplasty worse with injections, except those that are already vessel-threatening dissections that you need to stent, and those you just need to get on and stent.
Just a couple of short questions, please.
Just learning from Dr. Colombo, as we have so many here. So he says that decision to use a DCB should be after the pre-dilatation. So if you have a good pre-dilatation result, you can think about DCB. So why should a trial not be designed where we randomize after the pre-dilatation? So you do a pre-dilatation, if there is a good result with no dissection, good lumen gain, then you randomize to the DCB arm versus a DES arm. Because sometimes in these trials, we see patients where DCB is going to fail. There is long diffuse calcified lesion and it gets randomized to the DCB arm. Why not randomize after pre-dilatation to a DCB versus DES arm?
Simon, just...
Yeah, I think the answer to that last point is, to my mind, there are essentially two ways of doing RCTs for DCB against stents. The first one, which has been used more widely, is the one that you're alluding to, which is that you do good lesion preparation. If the lesion preparation isn't good enough, they're out of the trial and they get stented and they can be in a stent registry. If the lesion preparation is good enough, as per the usual consensus guidelines, then they're randomized to either a DCB or a stent. And I would call that device strategy randomization. The alternative, which hasn't been done much yet, but has been done in some studies or ongoing studies, is what I'd call strategy randomization, which is you take your pictures, you decide you can do everything that needs to be done in that patient, either with stents or with DCBs, then they're randomized, and they're then randomized to one arm, and they have to stay in that arm. So if they're in the stent arm, everything gets stented. If they're in the DCB arm, everything gets DCB'd unless you have to bail out on a specific lesion, in which case you bail out on that lesion, the rest of the lesions remain in the DEB arm. So there's two different ways of doing it. It's either strategy or device.
Very last one, Adelaide.
Okay, so mine is a question just to try to understand the mentality. It's me, look in front of you. Okay.
Hi, yes.
So the mentality, why you could not stent? I mean, stent was invented because of dissection and abrupt closure. So your point is, without having randomized clinical trial demonstrating it's safe, what is the issue of stenting a left main toward LED? We have, more than 100,000 patients treated and they're fine. So the mentality. So why do you think that you don't have to stent and dissected ostial left anterior descending artery and left main? Which is the rationale, because I'm missing the rationale.
So to my mind, the question is the same, whatever vessel you're treating. It's either a vessel-threatening dissection and needs to be stented, or it doesn't. There is no good data out there showing a prognostic benefit of routine stenting in all of your angioplasty. Stents were only invented for the reasons that you just said, for vessel-threatening dissection. When you take those patients out of the equation, there is no prognostic benefit, but there is an attrition rate forever of having a stent in that vessel.
Yeah, but they were invented also for restenosis, because balloon had 50% of restenosis and there was a decrease in restenosis. So it was invented for two reasons, for abrupt closure and decrease the restenosis, and there is no data so far demonstrating that not stenting is even equivalent to that. So we need data, that's all the point.
But that's what
otherwise anything is done is anecdotal and not based on
That's what all the RCTs
evidence.
are showing you currently, is that there is no difference in restenosis rate in de novo DCB work between stenting and DCBs.
You don't have any randomized clinical trial on left main on that. Where is the randomized clinical trial?
But you don't actually have a randomized clinical trial of stents against anything in the left main stem.
Because this is not ethical. Why you should do that? Why you have to
But
put
you
an
have
armful to a
nothing.
patient with a technology that has been demonstrated to be safe?
You have
So-
nothing to compare it to.
Yeah, let's see the randomized clinical trial. Then we can talk.
Our data of left main stem work, a bit like that cohort I just showed you of bifurcations.
I think we can organize a match outside.
Okay. The last comment. So in our left main stem cohort, between DCB only and stent only, there is no difference in outcomes, but numerically the stent arm does worse in every single outcome, but not statistically.
Thank you so much. I would like to invite Bruno Scheller. We'll talk about practical case-based approach for bifurcation.
Yeah, thank you very much for the invitation as an alien here in the stent bifurcation club. This does not work. No, it works. So from the point of a DCB protagonist, we have proposed this algorithm which is called DCB only. Focus is lesion preparation, and the goal of your lesion preparation is to achieve an acceptable result, not a stent-like result, but lesion preparation an acceptable result. Acceptable means the absence of a flow-limiting dissection. This means type A and B are fine, and maybe some type C dissections because it's not the same always. And we proposed a maximum diameter stenosis of 30% you should achieve. So that's the goal. If you do not achieve this, then the recommendation is to use a metallic drug-eluting stent. If you achieve this, you do not have to implant a stent and can use the DCB for local drug delivery. And this basic principle could also apply to bifurcations. We have different scenarios. The first one is the hybrid or blended approach with DS in the main branch and DCB in the side branch. This has been discussed before. The more puristic concept, which I will refer to, is the leaving nothing behind concept, which means we have to prepare both branches, the side branch and the main branch. And then if you fulfill the criteria of an acceptable result, then you can use for this specific branch DCB only for local drug delivery. If you do not fulfill the criteria, then you have to stent it. And then we have a very simple approach, which has been also discussed before, is for smaller side branches, you treat only the main branch with DCB, and you have this effect of improvement of the ostium of the side branch over time. So what do we gain when not implanting stents? Number one, we gain vasomotion. This has been shown in 2 randomized trials. One of these is here. And this is data from France and our group. We see lumen enlargement, typically at 4 months. This means you do not need a stent-like result at the end of your procedure, but you can expect an improvement of your lumen over time. And that's the basic principle. Don't do kissing DCB. You see, there are 2 reasons. Number one, the first balloon you bring in is too long in blood, and you lose drug when being in blood with DCB. And it's a geometrical consideration. You have only limited contact to the vessel wall. The majority of the surface of your balloons has no contact with the vessel wall, and therefore you have very limited drug transfer, and therefore DCB should only be used sequentially, but not at the same time as a kissing procedure. So this is a case. Can you start it, please? Because I have no possibility to do this. Can you move start the movie, please? Yeah, you can see this is a bifurcation we did years ago in the PEPGARD BIF trial. First predilatation of the main branch of the circumflex, then there was carina shift. When treated the posterolateral branch, origin with a 3.015 paclitaxel-coated balloon, and then the main circ with a 3.020. And this was again the initial finding, and this was the primary result. So this is not a stent-like result. We have in the main part, we have haziness. We have not the perfect lumen gain, but we have a good flow, and therefore this patient left the table with this finding, which you can see again on the left side. And here you can see the result. After 6 months, the dissection has healed and the lumen has improved. And this is without stenting, and that's what we typically see. In this specific case, we also looked with IVUS at follow-up angiography, and interestingly, the area treated with the DCB only had more than 50% less plaque area than the areas before and after this treated area. Another example, a few weeks ago, a younger colleague of mine did it when being on call. This patient presented with non-ST elevation myocardial infarction due to this lead diagonal branch bifurcation. First step was pre-dilating the side branch with a 2.515 millimeter balloon. So this was the result after the pre-dilatation. This is, according to our criteria, an acceptable result. Therefore, treatment with a 2.515 millimeter paclitaxel-coated balloon. This was the result after DCB, good flow still, a little bit dissection, but not flow limiting, so you can leave it. Then pre-dilatation of the main branch with a 3.015. This was the result, also fine. And then using a 3.520 paclitaxel-coated balloon. And this was the final result. This is a very simple procedure. It's done in 15 minutes. And you can see this is an acceptable result with good flow, and there's no need for stenting in this situation. Another case, a trifurcation in the right coronary artery. Again, after pre-dilatation, sequential use of 3 paclitaxel-coated balloons in all 3 directions. This was the initial result, looks good with some dissection, and this is 13 months later. Dissection has healed and lumen has improved. The other option has been shown before, so I do not have to go into detail. The origin of the side branch is improving, and this is an example, not exactly looking at this, but shows you the effect of treatment the main branch to the side branch. This was this ostial circ with the intermediate branch. After lesion preparation, paclitaxel-coated balloon 3.015 was inflated from the left main to the main circ, but not to the intermediate branch. This had only POBA, so this was the result, and there was some carina shift, so the left main to the LED was also treated with a DCB, and this was the initial result, and as you can see, especially the origin of the intermediate branch does not look that good, and this patient came recently 5 years later for another angio, and as you can see, there is no stenosis anymore in the ostium of this intermediate branch, and the ostium circumflex also looks good. So this is already my conclusion. DCB and bifurcations, lesion preparation is the first most important step, and it should include in this strategy the side branch if necessary. We have different scenarios. The blended approach has been discussed with the stent in the main branch. And I personally prefer the more puristic approach, lesion prep in both branches, and then accordingly to the recommendations of the DCB-only concept, use stents if you have no acceptable result, otherwise use only the DCB, independent if it's the main or the side branch. And for smaller side branch, there could be the simple approach with using only a DCB treatment in the main branch. Thank you very much.
Thank you so much. Just a couple very rapid, brief questions. Gentleman there.
Principle for the stent, or the concept of the stents, is to avoid the recoils. So how can you guarantee the recoil will not happen 2 to 3 days, months later after the procedure, especially if the case with patient presented with acute myocardial infarction? So I can accept the DCB and side branch in in-stent restenosis, but in patient with acute myocardial infarction, how can to avoid the recoil? And how can you guarantee the recoil will not happen, all thrombosis again will not happen?
I disagree a little bit. In my opinion, the issue of acute myocardial infarction is sometimes that you underestimate the real vessel size. And therefore, you sometimes implant too small stents. If you use a DCB, you can use the smaller size, but you do not have the issue that then there is no remodeling anymore possible if you have undersized your stent, for example.
So one of the challenging issues in acute coronary syndromes is the plaque shifting on bifurcation. When you have significant compromised side branch, what will be the next step?
You mean after treating the main branch?
Yes, yes.
Yeah. Then you have the option to do a kissing with uncoated balloons.
You cannot avoid kissing.
It depends on the result. I mean, the experience is that the side branch gets better over time, and this means you can accept in this situation not a recommended maximum 30% we propose, but it's only fine if you have the 50% stenosis. It will look better over time.
Yeah, but after single inflation, I mean singular inflation, side branch, main vessel, if you have shifting, you can go with kissing without fearing that will not be effective.
Why?
Because you have already delivered your drug by inflating the drug-eluting balloon separately in side branch and main vessel.
Yeah, but
then if you have some compromise, you can go for kissing. Why not?
Why? It's no problem to do post-dilatation. But the point is, if you do not stent, you do not change the natural anatomy that way. And therefore, the need for kissing is much less frequent than if you use stents in bifurcations.
Okay, I have one question.
Can
I? The left main bifurcation and other bifurcations are a little bit different, the vessel size and angle. So is there a difference that to prepare before the DCB, the balloon size, the balloon selection, and the pressure? Is there anything?
Yeah, very important point. I disagree a little bit with Simon with respect to left main. If you have ostial left main disease, you need a stent, in my opinion, because aorto-ostial disease requires stenting. We can start talking about DCB distal from the ostium of the left main. For distal left main, it's fine, but if you have ostial left main disease, you need stenting. If you go more downstream, then there is no real need for stenting if you have an acceptable pre-dilatation result.
I have one question.
Very short.
A very short question over here. There's one situation where placing a stent is always very worrisome for me. That is in cardiogenic shock, because even a 275 stent in the proximal left main looks like it's enormous. Do you have any experience? Obviously, there are no data, but do you have any experience in drug-coating balloons for cardiogenic shock?
Very important point. In cardiogenic shock, you have excessive catechomers in your body. Everything is narrowed. If you implant stent, you induce additional spasm frequently, and that's of course a situation where I only try to do balloon angioplasty, and if I have flow, only if I have good flow. If I have good flow, then I use DCB in this situation. But it's a rare event.
Obviously.
Thank you so much. We have to move on. And so I present Dr. Edelmith about protocol for EBC DCB study.
Okay, there aren't any slides, so I'm afraid you'll have to look at me. So this is a good session, isn't it? It's reminiscent of all those sessions 20 years ago when there was no data and everyone had passionately held beliefs. And there were some quite strong exchanges at times in those meetings. So I'm going to give you a tiny bit of background to what my feeling is about this, and then present a brief protocol for a trial that we are looking for support from you to do for the EBC, drug-coated balloons in bifurcation therapy. So I'll just take you back to, how come we got to stenting in the LAD diagonal? It's always LAD diagonal, and how that initiated the bifurcation club. Because, of course, once you put the stent across the side vessel, you've suddenly got a problem. There's a mesh there, Do we have to open the mesh? If we have to open the mesh, where do we go across? Can we rewire behind the stent? So that's the pot. So we did pot. Suddenly we've got kissing. We've got position of recrossing. We've got use or no use of either. So that's where everything has been for the last 15 years or more. And that's where all the energy has been. But, you know, for me, and clearly for some people who've been doing this for many years successfully, quietly, there's a nagging doubt. And that is that although stents are great, and there are certain circumstances, a bit like the one that was shown on an angiogram recently, where a stent is definitely a go-to therapy, nonetheless, there are problems with stents. It's not a free hit. Once you implant a stent, you can't take it out. And there is a price to be paid for that stent. And certainly my experience personally in the catheter lab is that whereas we used to think that the late stent thrombosis was a feature of, oh, that's Taxus and Cypher stents, it doesn't really happen anymore. That's not right. It's not right. They do come back. And sometimes it's 5 years, it's 8 years, it's 10 years. But you see someone come back with either acute, very late, or acute on chronic, very late stent thrombosis. And you've got a real problem to deal with then, with perhaps a long stented segment, which has become rigid, perhaps a bit calcified, can be very difficult then to treat. How do you treat that successfully for the long term for that patient? So that was my personal experience of this nagging doubt that these things do come back. There is, you know, it's as if the clock was just moved forward by having drug-eluting rather than bare metal stents. There's still a problem here. And then I was influenced by Greg Stone's paper about the attrition rate that you can see when you look at prospectively followed stent groups over long periods of time. You can argue about what the percent rate is. Is it 0.5? Is it 0.7? Is it 1? But it's a percent rate. And there is attrition over time with the implantation of a stent. And as I say, once you put the stent in, you can't take it out. It's a permanent inflammatory nidus. Okay, for 99% of people, maybe it's okay per year, but for 1% it isn't. So, and at the same time, there was interesting data coming out. You know, I used to think, drug-coated balloon, really? Are you serious? I mean, we've got stents. Look how they're fantastic. Look how amazing the stents are. But actually, slowly, personally, I changed my view and thought, well, you know, there is data coming out saying, I don't understand it, but that even the prognosis for these patients might be better. And this wasn't just one group banging at the same time. It was coming from different areas. I think ISAR Desire, the Norwich data, some German data, all hinting there could even be a prognostic benefit here. And of course, intuitively, if you could make sure that you didn't get acute acute vessel closure, and if you could make sure that you didn't get restenosis in the vessel, doing a procedure where you actually don't leave a permanent implant is an excellent intuitive strategy, just as, and this is a drum I have been banging for a long time, just as using one stent rather than two, for example, could be potentially a superior outcome for the patient. And then if we look at it from a slightly different perspective, you know, we all face this problem day in, day out. Oh, you know, that patient you put a stent in, they've got to have a hip replacement. And you go, oh, God, you know, they're on a Pixaban for their AF and they've got clopidogrel, and if we withdraw things, they'll get stent thrombosis. And we all see cases coming back to the lab, stent thrombosis after the stupid surgeon stopped all their antiplatelets, blah, blah, blah. You know, this is a serious problem, which we can't get around. We have to sometimes say, oh, well, you're going to have to stop some medicine and, you know, take a risk. Again, that could be something that we don't have to face, at least nearly quite so much, with balloon therapies which don't leave a permanent implant. So, with that background, I'd like to suggest a trial for you all. We've been talking about this in little groups for some time, and the trial, it's a bit of a tongue twister, sort of EBC DCB. You'll have to get your tongue around that one. And it would be a trial of, again, fundamentally think of it as LAD diagonal, because 80% of them will be. It will be 111 or 011 lesions, non-left main. It will be obviously patients who require intervention based on ischemic criteria, could be acute, could be chronic. There will be two groups. One is the standard provisional stepwise T strategy, which we all know and love. And the other one is a pure drug-coated balloon therapy. Now, the approach for this trial would be just as you suggested, pre-dilatation first, preparation, however you like, rotablation, shockwave, simple balloon, cutting balloon, to the main vessel, followed by, if the result is good, or adequately good, randomization. After that, provisional T, you know the drill. In the drug-coated balloon group, it would be main side, side main. So having prepared the main vessel, the side vessel would then be prepared with simple balloon, then a drug-coated balloon, and then you'd come back to drug-coated balloon in the main vessel. And a bit like the example that Bruno showed us, we could end up in this situation having something of a paradigm shift. I rather hate that expression because it's used so often, but actually this really would be. I mean, it's a bold strategy. Some people won't necessarily take to it, and we've already had discussions this morning where people have expressed reluctance at treating the proximal LAD like this, but I think actually if you start doing it, we've been in the solutions study that Peter O'Cade is leading for the UK, and Simon mentioned, and actually the more you do this, the more you realize what can be done and what can safely be left. So as the music's playing, I'm going to stop there. Obviously there's finessing of the protocol to be done, but that's the bare bones of it, and I'd like to open it now for discussion.
Thank you so much. So, what do we have to do? Please.
Probably not, simply because it will be different in different geographies, and as we found with EBC Main, where we wanted to include randomization for imaging but couldn't, some countries have it reimbursed, some countries don't. We will artificially limit what we can do if we include imaging, so probably not. Yes, again, there will be cost implications. I mean, obviously it'd be great to do imaging and physiology, but cost and time implications may prove tricky.
Yeah, after treating the main branch and then the side vessel with the DCB, you won't recommend a kissing balloon to optimize the result?
No.
David, thank you very much for this excellent talk. I think it's very important to emphasize why we need to do a trial against stents, and that stent is not the final solution. I think there have been two errors around in this discussion today. One is late recoil. There's nothing like late recoil. There might be some vasospasm around this area, but a late recoil after 2 or 3 days, this is a thing that doesn't happen. And the other thing is, if you don't have a carina shift with DCB only, you might have some plug shift, but this is an open plug, and an open plug will heal in any way. Any plug that is opened up, that heals. So we don't have to worry about this if we don't have an acutely impaired flow. And this is the only point that have to be looked at.
Great,
David,
thank you.
Dave, so fantastic proposal. So in inclusion criteria, you said 111. So is there any criteria for side branch disease? Like it should be complex stuff because you will be doing T-stenting in the other group. So it should be more than 10 millimeter, less than 10 millimeter?
We can finesse that. It may be that we choose less than 10 millimeters. Maybe.
And is there an option of not doing T in the other arm?
Sure, yeah, no, it's provisional.
Provisional
to mandatory kissing because it's 111.
And then T if required.
T if necessary, rarely.
Dave.
No, the issue, I would...
Please, Derek.
Just a couple of quick questions, Dave. Brilliant presentation, great design. In terms of numbers, what sort of numbers do you think? And the second question, do you think we should have 3 arms? Do you think we should compare paclitaxel and limus? And I'm in, by the way.
Yeah, excellent. Perfect, thank you very much. You're signed up. I don't think we can have 3 arms. I mean, practically speaking, I mean, If it was funded by a neutral body, that would be great, but I don't think we'll be able to do that. I think probably we're looking at something like 800 patients, but the actual calculations are a little bit difficult to make. Yeah.
So any other proposal? Other idea?
Honestly, I would take out proximal LED, that's prognostic vessel, and I would concentrate maybe to mid-distal LED and diagonal and RCA or obtuse marginal. Take out the prognostic, go in the vessel that are done because of symptom relief, not for prognosis.
Sure. We won't do that. We won't do that. But thank you for the
No,
comment.
I mean, that's the idea. We want, it's a decision.
Yves?
I have a remark that has nothing to see with the protocol. For the specialist, do you think that what you put on the wall may have some structural effect? You say yes? You think so? May I explain that maybe with this DCB, we are also solving the problem of small dissections. What do you think about it? If it's not true, why not? I don't know if the companies are here. Why not thinking about that? Which will be maybe for the future an improved solution.
Professor Clement?
Franz.
I mean, any dissection which is not compromising flow leads to an improvement in prognosis and vessel size. This we know from Andreas Grünzig. Yeah, this is very old. I think in addition we have a drug, at least paclitaxel as a drug, which causes further increase in vessel size within the 2-3 months area. So this is a change we do know. And secondly, we know from the SCAR registry from Venezianos that the long prognosis is better without a stent than is better with the DCB than with a stent. So I think we don't have to address small vessels. I think we have to address any vessels if we do such a study. And if we go beyond the first 24 hours or 48 hours, we don't have any further risky time period.
Okay, I think that we can all think about during these couple days and then having some kind of final.
Perfect. Thank you very much.
Okay.
I'll be around. Everybody could come and chat. Thank you.
Okay, so there is no pause now, we are sorry, but we will keep on going, so please take your seat. And this is a session that was designed together with Women as One. And this is a tradition that started last year, and I hope that it will continue.
And we will keep it.
We will keep it, and it just gives the idea how much as European Bifurcation Club we are for inclusivity and equity. I mean, we like to have inclusivity and equity. And so there was a call that went also through the Women as One website asking for complication cases in bifurcation. There were a number of persons that submitted their case, and then the board decided and other members of European Bifurcation Club. So this was really transparent and open call for cases, and then the cases were analyzed and there were some votes given. And so the ones that are going to present are the ones that have been selected among a number of different cases. It's a pleasure for me clearly to chair this together with Goran, together with Valeria, and together with Jas. I hope I'm doing a crisis of the name, it's complex. And in the panel, it's going to be Stefan Haar, Jessica, I hope it's correct, Adel, and Sarita. I mean, she's online, okay? So it's a pleasure to present the first case that was selected, that is when a complex lesion is not your biggest problem. The presenter, it's another very complex name for me. So maybe if you... Silvia?
Silvia,
W is
that's
like
right.
V. Silvia.
That's
Okay.
right.
So please.
Thank you very much, dear Chairman. It's a great honor to me to present at EBC 2023 meeting. So the title of my presentation is When a Complex Lesion is Not Your Biggest Problem. So let me present the clinical characteristic. It's an 80-year-old male presented with non-STEMI, with multivessel disease and left main stenosis, who was disqualified from CABG because of the high surgical risk. So he had previous STEMI of inferior wall treated with primary PCI. He suffered from heart failure with reduced ejection fraction 35%, atrial fibrillation, hypertension, hyperlipidemia, diabetes mellitus type 2, and nicotine dependence. As you can see in coronary angiography, there is a critical stenosis in distal left main with involving the proximal part of LAD and circumflex artery, so the medina is 111. During the predilatation, I was unable to cross the lesion with a larger balloon than 1.5 millimeter balloon due to severe calcified lesion. So I decided to do the rotablation of LAD with 1.5 balloon bore. After that, you can see there is any significant dissection, so I decided to do the rotablation, also the circumflex artery, because of the difficult angulation of the coronary artery and also calcified lesion in the ostium of coronary artery. So after the rotablation, I exchanged the wire into cyan blue extra support, both into the circ and the left and the LAD. Next, I did the predilatation with 2.5 NC balloon. It was effective predilatation with full expanded balloon. This is an angiographic results without any significant dissection with TIMI-3. And because of the complex lesion, Medina 111, I decided to do the DK crush technique. So I started with the DES implantation 2.5, 20 millimeters into the circumflex artery and left main. After that, I crushed the stent with balloon 3.5 and next 4.5 at the pot position. After the rewiring, I did the first kissing balloon with 2.5 and 3.5 balloons. Next, in the next step, I implanted the stent, DS 3.5/24, with the coverage of whole left main from the ostium. Of course, I did the pot with 5 NC balloon. After the rewiring, I did the second kissing balloon with 2.5 and 3.5 NC balloons, and after that, I finished the procedure with repot with 5 NC balloon. As you can see, there is a IVUS imaging after the procedure. The lesions are quite diffused. There is a eccentric plaque in the mid and distal left LAD with calcification, ring calcification in the mid segment of LAD. But at the end of the stent, there is plaque burden. We will see that. Yes, there is a plaque burden less than 15%. The good expansion of the stent in LAD and left main. There was a bifurcation with circ. And the expansion of the stent in the left main is also well with the short protrusion of the stent into the aorta. And I'd like to show you the final angiographic results. And after that, I would like to ask you for a discussion. So I will show you one more time the angiographic results.
Thank you very much. Excellent procedure. Now it's open for comments and discussion. It reminds me very much to one case that Colombo did live for TCT. And for the last image, he wanted to push a wire to disengage the guiding catheter. And he ended up exactly like this with the distal perforation. So any comments or questions?
One more time, please. The wire
extra
was
support
extra support cyan blue in both circle and LAD. Yeah, and the perforation, of course, was not visible before the wiring removal. So,
Dr. Javi, can we have microphone here?
One. Without the fluid in the first visualization in echo, so. It was so huge at the beginning, but after that I will show you the situation changed.
Vlad?
You used a 2.5 stent in the circumflex?
That's right.
Okay, and did you IVUS the circumflex? We didn't see that.
Yeah.
I just don't see a circumflex being a 2.5
at the beginning.
Ever.
Yeah, at the beginning I couldn't pass the sound through the lesion in LAD and circumflex artery, so it was impossible. And after the procedure, unfortunately, I didn't do it because of the angulation of the circumflex was quite difficult, so it was impossible.
And so you didn't try to IVUS after rota then?
I tried to do the IVUS after the procedure, but
no, I don't mean after the procedure, after you stented, but after rota.
No, I didn't.
So I that would be my only comment, is that's kind of the time, so you know what size of stent to put in. In my experience, is proximal circumflex arteries are not 2.5 ever. I don't know what other people think, but that stent needs to be bigger.
Silvia, a question. Great case. Why did you choose an extra support cyan blue wire? Because the vessel was not that tortuous, and you had already good access, and the position also of the rotor wire was good. So this is a wire which has a a tip which is kind of soft, but is a support wire which can be used for really tortuous lesion and calcified. So why did you go for this wire?
Thank you for this question. Unfortunately, the position of the guide wire wasn't excellent. It was EBU 3.57 French, but it's not so stable. So I wanted to get more support.
Yeah, it was calcified the rota, and then was difficult probably to predict.
That's right.
To be honest, cyan blue wire has a hydrophobic tip, so it's really not prone to perforation. So probably you were stuck in maybe a small branch or something like that. But that's maybe a reason. But it's, for me, in my experience, that are very safe wire. So I think it was a good choice, actually. A question about the use of rotablation. Do you think in such a case, I mean, or a question to the audience, that's probably a good case also for shockwave because you are proximal, the access is relatively easy. I think it's not a bad case for shockwave.
Yes, but unfortunately,
she could not cross with the balloon.
The lesion was not
the 1.5
crossable.
didn't cross?
1.5, it's the biggest one which I crossed the lesion.
Okay.
The bigger one, it's
Sorry,
impossible.
Sorry for that.
to
Okay,
cross,
but
so.
then you answered the question.
Yeah. No, I think you did an amazing job in really prepping the lesion. It's a difficult case, and you did rotablate up both limbs. Shockwave would not cross, obviously, with that angle. Did you see the circumflex? You can actually cut the wire the way you were rotablating, which is goes like that. The wire folds backwards, and you run the risk of cutting wires to it, but you did a good job. So the case was good. It happens to us too. What happens is when we try to do multiple exchanges, multiple recross, multiple balloons, sometimes we forget where our distal wire is. We tell the fellows that all the time. We all have gone through these things. So I think your wire choice was decent. I think the tip is decent. I think, unfortunately, it went into a little branch, and we're going back and forth. But you did an excellent job in the case. You really did.
Thank you.
Did you have to inflate balloon to stop this, or you finished?
Yes, I will show you in the next
please.
slides. Okay, so let's go. So it was, of course, my first step to inflate the small low-pressure balloon proximally to the perforation, and of course the additional support of the blood pressure. But despite the many attempts and many inflation with low-pressure balloon, there is still blood leakage. So the next step was embolization by autologous fat particles. As you can see, through the microcatheter introduced distally to the artery, I tried to embolize the artery, but unfortunately it was unsuccessful. The patient developed cardiac tamponade, so the pericardiocentesis was necessary. We have to try another solution of this problem. So we decided to close the artery with the coil. So I put 3 coils distally into the artery, and fortunately the bleeding was stopped. Oh. Okay, so this is the angiographic final results. There is some myocardial blush in the place of the balloon, but there is no bleeding distally through the artery. So the angiographic result was good. Unfortunately, after 4 hours, the patient's clinical conditions deteriorated due to the recurrent cardiac tamponade. We tried to, because it was on my duty, so we tried to another pericardial centesis. It was ineffective, so we, due to the cardiac arrest, we did the urgent thoracotomy with pericardial sac decompression, and after the open cardiac massage and epicardial electrode implementation, we returned the hemodynamically efficient circulation. But unfortunately, after the 1 day, during the next day, the patient died because of the severe metabolic acidosis and multi-organ failure. So let's go to the conclusion. The distal coronary perforation is often due to the guide wire related vessel injury, and it's more common with hydrophilic wires, as in our case. A looped wire tip is safer than a straight tip, reducing the inadvertent migration into the distal segment and small branches. And with extensive damage to the small vessel, bleeding may continue despite occlusion of the main supplying artery. Thank you very much.
Thank you very much for sharing this. Dr. Girazis, just a very brief comment, we need to go on.
Bearing in mind what happened afterwards, I mean, did you consider trying the ping pong maneuver that you keep the balloon inflated and get a second guide and then win some time without the patient extravasating in the pericardial sac and blah, blah, blah?
It was a common decision, cardiologists and cardiosurgeons, so we
I mean, during the first phase, during
the first case. So
before actually bringing in the coils, etc., just bringing in a second guide via the groin, and then keeping the balloon inflated, working there, and saving time and saving blood.
Yeah, of course, isn't an option. It was considered, but during the all maneuvers, which I did, I was keeping the balloon inflated in the artery, so the bleeding meantime was not so big a problem. And during the putting the coils, the balloon was also inflated, open, so which stopped the bleeding.
Okay.
But of course, it's an option also.
Yeah. Okay. I think we really need to go on. Thank you very much for sharing this. This is really extremely complex case. Unfortunately, ended up with the patient death, but thanks for sharing that. We learn a lot. Thank you, Sylvia.
Pleasure. Thank you very much.
So I would like to invite now Nick.
We will vote at the end of the session because for the moment I think it's not working properly.
It's also better that we see all the cases. So Nicola Ryan, crushing the complication.
Great. Thank you very much for the invitation to present. So this case is a 78-year-old gentleman. I had seen him in the clinic back in February of this year with typical exertional chest pain and some dyspnea. Doesn't have too much in the way of cardiovascular risk factors and was on 2 anti-anginals. His echo had showed some mild LV impairment, a bit of hypokinesis of the posterior wall. His labs were essentially unremarkable, and you can see his ECG down in the bottom right-hand corner. So on this basis, I offered him a diagnostic angiogram, which we might get, yep. You can see his right here, you know, a bit of minor plaque, nothing too impressive. And then we see he has a Medina 111 in his LAD diagonal bifurcation. And then he has a left main LAD circ intermediate trifurcation disease as well. So he was discussed obviously for various treatment options, and at the end of the day it was decided that he would come for PCI. So the initial setup was right radial access, 7 French, an EBU 3.5 guide, and 4 cyan wires, a cyan wire to the circ and to the intermediate, a cyan wire to the LAD, that was all relatively straightforward, and a cyan wire to the diagonal, which was a little bit more tricky to wire, but with a little bit of reverse wiring was wireable. After this, I then went on to IVUS, the circ, the intermediate, the diagonal, and the LAD. For the interest of the case, I'm just going to show you the diagonal and the LAD. So this is his mid-diagonal, where we've got a relatively healthy landing zone of about 2.5 to 3 millimeters. I don't seem to be progressing. Oh, we've gone on too far now, sorry about that. This is his ostial diagonal, his mid-LAD, his ostial LAD, and his left main stem, where we've got a diameter of about 5 to 5.5 millimeters. So given the difficulties with wiring the diagonal with the presence of the disease, I decided to initially do an inverted culotte strategy in the LAD diagonal and then plan for a provisional strategy for the left main LAD. So nobody is particularly interested in the huge steps of the PCI. It was relatively straightforward, 2.75 by 33 Zions into the diagonal back to the LAD, recrossed, did the first kissing balloon, did a distal LAD stent because the healthy landing zone was distal to the bifurcation, stented back to the proximal LAD, all pretty unremarkable at this point in time. Started to post-dilate, so it had taken a 3.5 by 15 millimeter NC emerge because we didn't have anything longer on the shelf to post-dilate. And then again, all unremarkable. And at this point in time, taking the post-dilatation balloon out of the LAD, unfortunately, everything comes out, including the wire in the diagonal, the wire in the LAD, the wire in the circ, and the wire in the intermediate. So, multiple attempts to wire back into the LAD and can't get back into the true lumen of the vessel, continually wiring abluminally. And I've IVUSed this on multiple occasions, and I'm still through the first basically 2 to 3 struts of the proximal LAD stent. So what next?
Okay, so suggestions? Dr. Rab, can we have a microphone here in the first row?
So if you're planning to do a provisional in the left main, why don't you bring the LED stent all the way back in the left main? And then potted it, and then maybe you'd have a better chance.
Yeah, so that was a really good question, and this is something that I had thought about. So my issue was, first of all, I wouldn't have been able to take a long enough stent right back to the left main. And my second issue was that I was concerned if I had come right back to the left main and I had jailed my wire into the diagonal, when I was removing that jailed wire, I would have a risk of having longitudinal stent deformation of the left main stem stent. So that was why I had decided to treat the LAD diagonal bifurcation first and then come back and complete the second bifurcation. Pardon? So no, the wire is no longer inside the LAD stent. When the non-compliant balloon came back, there was inadvertent removal of the wire. So the wire has come out of the LAD, and despite multiple attempts, looping of wires, and I cannot get through the lumen of the stent. I'm continually abluminally for the first 2 or 3 struts.
So if the wire is going abluminally for the first 2 stent struts, it's very difficult to wire the true lumen again. So just put a short stent in the proximal part of the stent, and then it will connect to the true lumen distally. Optimize that proximal part of the stent with a bigger balloon and then continue distally. Probably is what the solution is for this problem generally.
Okay. So what I did was I decided that I wasn't going to be able to get into the lumen of the stent, so I needed to crush the first few struts of the stent. So I started off with just a 1.5 by 15 millimeter small balloon, and I worked essentially all the way up to a 3.5 millimeter balloon. Could the technical team please press play on that bottom image? Could you hit play on the, thank you. So once I had crushed essentially the stent with a 3.5 balloon, I then did an IVUS run back from the LAD. And you can see, while it's not completely optimal, there's a relatively good, and here we see just between 11 and 1, the crushed stent. So I just have some images. This is the distal stent. Here we're at the crushed proximal stent. Again, we see it crushed here. And this is again back into the proximal vessel.
The crushed segment is in left main?
No, it's in the proximal LAD.
Proximal LAD.
Proximal LAD, yeah.
There's an acoustic shadow of a second wire. Did you wire the diagonal too before that?
No, I did actually, yeah, sorry.
So there are two wires there.
Yeah, but what I had done, so I've not gone the whole saga that this was when I was doing the case for this, but yeah, no, I had wired the diagonal then.
So here's the issue. Are both wires through the same strut? You're crushing the proximal part of the stent that's going into the LAD. So for that to work, both wires have to have gone through the same strut.
Yeah, no, so what I did was I crushed it, then I wired into my diagonal, and then I've done my IVUS. I can't see who's speaking to me, sorry. So then I went on and stented the left main to the LAD with a 4023. Did my second kissing balloon in the LAD diagonal. Did kissing balloons in the left main into intermediate and then left main into circ. Did a final pot. Did a final IVUS run. This is the distal LAD, mid, proximal, and left main. And this is the final angio in a caudal. And up here in a cranial view. So basically, my key learning points from this case were that dual bifurcations are a challenge. As suggested, you can either treat one of them completely, come back straight to the left main, and then deal with the second part of it. In this case, I had planned to complete the first bifurcation to avoid jailing the diagonal wire back to the left main and risk longitudinal stent deformation. While all attempts to rewire luminae had failed, crushing the proximal stent struts is a reasonable strategy. Here, IVUS was key to ensure that they had actually been adequately crushed. And when you've got multiple wires, even when you're taking care, there is an increased risk of inadvertently removing the wire. So what was, for me, the most difficult part of the case, or getting the diagonal LAD stented, was relatively straightforward. What took up all the time in the case was completing the case. So we learnt a lot in the lab about paying attention to wires and not pulling on things. In this case, it wasn't me. In lots of cases, it has been me where I've pulled wires, so we've all done it.
Yeah, bravo, congratulations. Can we have microphone over there? And please come in the front part, because most of the people discuss here in the front part, so we need to have microphone here.
Thanks, Nicola. That was a great save. So just going to your last point, I was going to say, why did you have 4 wires? Because personally, I can't manage more than 2. I get confused. And as you say, the more wires you have, wire management becomes more difficult. So with dual bifurcations, I'd probably deal with 1, have 2 wires, and then deal with the second bifurcation in separate.
Yeah, I learned a tip actually from Goran of laying my wires out on the table the same way as I lay them out on the screen, and that's the way I typically manage my wires. With the best will in the world, these things happen.
Can we have microphone here?
You can prevent intertwining. Pull out, just inadvertently pull out something.
Take a microphone in order that
so
everybody...
if you have 3 wires, what she said was, she had a point. When you have 3 wires, there is an increased risk of pulling it out because there could be intertwining which you can't control.
Yeah, you can definitely get wire wrap. That's definitely a valid point.
What kind of wire do you have? Because there is a difference if you have a polymer-coated wire, heavy polymer-coated wire, and if in the case, if you have more than 3, I use some tips to put on the wire in different colors. So it's helped me to remind, and I also tell all my teams which kind of color I use for every kind of the vessel. So I think that's very helpful.
Yeah, I had 4 plain cyan wires.
And what kind of wire you use?
Just plain cyan. Cyan. Fine.
Last comment, Remo.
Yeah, a question. To rewire luminally, do you try a dual lumen catheter or not? You can use a dual lumen catheter on a abluminal wire. The tip will go aluminal. Then you can mount a reverse wire, which is already looped, and then try to go.
No, I didn't do that. No.
This is a tip just.
Yeah, excellent, excellent save. Nicola, thank you very much. Great case.
So we move on with Aninka Sabu. She's connected remotely. She's going to present a case of left main decay culotte stenting in iatrogenic ostial dissection.
To present at the EBC 2023 meeting. The title of my presentation is Left Main Decay Culotte Stenting in Iatrogenic Ostial Circumflex Dissection. This is a case of a 53-year-old man. He came to our clinic with symptoms of typical angina despite optimal medical therapy. His cardiovascular risk factors were hypertension and smoker. He underwent primary PCI at a district hospital 6 months ago, which revealed multivessel disease stenosis and left main disease, which at 2.75 DES was implanted at ostial LAD. And he also had underwent failed RCA CTO PCI 3 months ago at another hospital. LV ejection fraction was 41% with regional wall motion abnormalities, and laboratory results revealed normal renal function. Here is the right coronary angiogram. We can appreciate here that there was CTO at proximal with branch collateral and JCTO score of 2. And here is the left coronary angiogram. We can appreciate here that the previous stent was visualized. However, we could not clearly identify whether the stent was nailed the ostium. And here is the still image. We can see here there was eccentric stenosis at left main, and the ostial LAD and ostial circumflex were narrow, and there was also stenosis at distal circumflex, in which it was also donor collateral for RCA. It was decided to perform OCT-guided PCI to the left coronary artery to prepare retrograde PCI to the RCA CTO lesions. However, there were difficulties during the delivery of the OCT catheter. We can appreciate here that the OCT catheter was derailed from the wire and seems to be knocking at the circumflex ostium. And after repositioning the guiding catheter, and after a more coaxial engagement, the OCT catheter was successfully advanced to the distal LAD. And this is the left main LAD OCT run, which revealed the prior stent was well expanded and opposed. However, the stent was not nailing the ostium. The OCT study revealed fibrotic plaque at ostial LAD with MLA of 2.92 mm². We can also appreciate the eccentric lesion pointed by the yellow arrow at distal left main with MLA of 5.06 mm². We can also appreciate here there was an intimal tear at the ostial circumflex, which pointed by the red arrow. Suddenly, the patient was experiencing chest pain, and the ECG shown as the segment elevation at inferior lid, and careful contrast injection revealed dissection at the ostial proximal part of the circumflex with reduced antegrade flow and compromised collateral flow to the RCA. And we can appreciate here the location of knocked OCT catheter was similar to the dissection location. Our strategy was wiring multiple guide wires was used to ensure it was in the true lumen, followed by pre-dilation with 2.5 millimeter semi-compliant balloon, and after that, a 2.25 DES was placed at distal circumflex. Decay culotte stenting was performed with first stenting at the left main to circumflex, followed by POT and rewiring to LAD and kissing balloon inflation with 3.0 NC balloon inflated up to 12 atmosphere. And the second stand was placed at the left main LAD, followed by report and rewiring to the circumflex. We perform final kissing balloon inflation with 3.5 NC balloon at left main LAD and 3.0 NC balloon at left main circumflex, which followed by final POT using 4.0 NC balloon inflated up to 18 atmosphere. And here is the final OCT evaluation, which revealed no stand edge dissection, good stand expansion and apposition, and 3D OCT evaluation revealed no gel strut while preserving stand geometry. And this is the final angiogram. The patient's symptoms were improved. Hemodynamic was stabilized with normalization of ECG. There are several points that we can learn from this case. First, lesion eccentricity might play a role in off-track OCT catheter delivery due to the complex intraluminal route. Decay culotte stenting is a feasible dual stent strategy for complex left main bifurcation PCI in bailout setting. And OCT usage is generally safe, but in cases with highly tortuous vessels, especially at the bifurcation site, the risk of dissection may occur. And that is the end of my presentation. Thank you.
Presentation is open for comments and discussion. Aninka, hello. Great case, another one today. Thank you very much.
Hi, thank you.
Congratulations on great save and very well illustrated. Do we have any comments? Eve? I think that both of you should be here in the front part.
My comment, friendly comment, is en place catheter is giving you a very strong support. But I think really this is not a catheter for left main because you cannot manage at least a small distance between the tip of the end of the catheter and the stent. And this was not your problem, but this is a great factor of longitudinal stent distortion. So really, my message is clear, don't use implants for left main stenting.
Thank you.
Please.
Yes, just a minor comment on the OCT interpretation. I think you had a great save at the end, and I also believe that the OCT catheter was the reason for a dissection. On the OCT images, however, the small intimal tear that was seen can sometimes be an artifact. If the angle of incidence is very low, then sometimes you do not see very well at this point. So it cannot be evaluated as a tear itself.
Okay, thank you. But also it was impossible to perform OCT evaluation if we suspect dissection in these cases. Thank you.
Yeah, I just wanted to say in the first, the Ambler's catheter was there, but then the guiding catheter was changed later on. I think what happened was that guiding dissected the left main and it did not progress to LAD because there was a stent in the LAD already. And the whole of the dissection from the left main went into the circumflex. So it's not probably that bending of the catheter which has dissected the circumflex, it's the guiding which has dissected the circumflex. but did not go into the LED because there was a stent already in the LED.
Yeah, thank you. Sarita, welcome to EBC this year. Now we see you on the screen. Do you have any comments?
I think it was a great save, Dr. Anenka. Thank you, Dr. Goran, for inviting me here. I think that the entire issue which she had with taking the OCT in was because of the wrong selection, probably of the guide catheter, which deflected the OCT. Especially in lesion situations like this, when we do the forceful injection to get the OCT images, this kind of situation sometimes arises. But I think in the end, she had a great save.
Exactly.
Thank you, Dr. Sarita.
So thanks for the case and thanks for having participated even if online. And so we move to the next case, which is the last case by Ellen. Okay, she's here, Rutledge. And it is Jailed or How to Get Out of It. I like the title, no? Very, very British.
British. Thank you. So, conflicts of interest. I'm female, but there were no females in the lab when this case was done. So this was sent in by my fellow for a complication session. And I think even I had a misunderstanding about whether my fellow was male or female, and he's actually male. So I'm presenting it on his behalf, and I wasn't in the lab. That's my excuse. It's not pretty at all, and a number of mistakes were made, but they are mistakes that we can learn from. But be warned. So, 65-year-old gentleman who's a black belt in karate, and his title is the 4th Dan Shotokan. I don't know what that means, but it's quite important in the karate world. And he was admitted with a non-ST elevation MI with a reasonably high troponin, whatever troponin I means nowadays, but no history of any risk factors. He's very fit. That was his ECG, so we were expecting something in the proximal LAD, and he was taken to the lab on the second day of his hospital admission. So, as expected, he had a lesion in the proximal LAD and then another LAD diagonal bifurcation lesion in the mid. And this guy doesn't get pain. In the lab in France, we used to have anaesthetist, which I quite liked. In the lab in the UK, we don't have anaesthetist, and we just have a bit of diazepam. But this guy meditated all the way through his procedure, which, without giving the game away, went on for 7 hours. And he meditated, and he wasn't anaesthetized, and he doesn't complain of pain. But after this picture, he did actually have quite a lot of ST depression anteriorly, so we felt whatever the discussions about the circumflex, etc., that we should get straight on and treat this. That's another view of the proximal LAD, and his right coronary just had some diffuse mild atheroma. So, wire in the LAD, wire in the diagonal, they're both cyan blue wires, as that's the operator who was doing this case's preference, with a CLS 3.5 guide. 2.5 by 10 balloon pre-dilating the LAD. And then straight on, so the proximal lesion was pre-dilated with the same balloon, straight on to a 3 by 30 onyx stent. And it landed in some plaque, but kind of looked all right. And they then went on to stent with a 3.5 times 15, I think it was, proximal onyx stent. You're all spotting the deliberate mistake at this point. The focus at this point was on, are we getting that stent ostially, proximally, trying not to go too near the left main. Let's focus very hard on where we position that proximal stent. So that looks okay. Pot of the distal stent. I can see Eve getting uncomfortable already. It's not what you taught me, I wasn't there. And a pot, and we all know pot's important, of the proximal stent. And then we've got to take the side branch wire out. Diagonal's looking okay, so we need to take the side branch wire out. Next picture. So the side branch wire didn't come out, and the side branch wire was pulled quite hard because it didn't come out. And at that point, you can see the distal end of the side branch wire is coiled up. You know how the springy bit just coils up like a spring. It's not broken. The back end of the wire is still on the table. It's out at the diagonal. It's coiled up behind the stent. So at this point, a number of things are tried. What you can see on the screen there is the third thing that was tried. The first two things that were tried were a fine cross over the back end of the wire, trying to free up the wire tip and wiggle it out. That didn't work. A 1.2 and then a slightly bigger balloon over the back end of the wire to try and loosen it up, and that didn't work. And this is a telescope or a guide liner, I think a guide liner, again, trying to help with that and loosen it up. And you can see something going on with that proximal stent, and probably something going on with the distal stent. There's a couple of hours and a lot of pictures that I haven't included. You can see there's no wire in the main vessel at this point. So I don't know how clearly you can see what's going on, but there's something slightly odd looking in the end of the guide catheter at that point, which isn't wire, which is the stent, exactly as the front row are pointing out. The stent is unravelled, the proximal stent is unravelled and undone and hanging out in the left main. So, as steps taken so far, so as I say, they've tried the fine cross and the guideline is to take out the trapped wire. They've tried to balloon, and their next move was to call a friend and then another friend. So, ideas? Wire it and crush the whole thing. Okay, the issue with that, you may see better in the next picture. It's not all in the left main, it's in the aorta. So you can see there, and actually it's an onyx stent, and you know that that's made as a long wire, and this long wire is completely now unravelled. Some of it's still in the proximal LAD, and the rest of it, there's actually, when you look at the pictures very close up, there's actually quite a big loop of stent all the way around. Call a surgeon. We're not in a surgical centre, Shazia, sorry. We could, they'd take about an hour and say no, so no, we can't. But yes, you could transfer to a surgical centre, yeah. Yeah.
It is the structure of the onyx stent that has caused all this. If you pull the wire, the onyx is a coil stent.
Yeah.
It just pulled out.
Well, it's the operator that's caused it, not the onyx stent. But yeah, I see what you're saying.
I'm not blaming the stent, but I would say you pull it out, the onyx is...
It's unravelled and uncoiled, yeah.
A solution is just to take a loop and extract completely the stent from the aorta.
Because take a snare, you mean?
Yeah, this type of stents, which is is easy to remove completely. By mistake, I removed one. So it's the Medtronic stent is easier than other stents to remove completely, to extract from the coronary artery.
So one of the operators who was called to help did have a go with the snare, and it's always quite nice calling a friend, isn't it? Because you're feeling awful, but your friend's going, I get to use a snare, I never get to use the snare. So the friend came along and tried to use a gooseneck snare, which didn't work, and then a tulip snare, and just couldn't get any grip on any of that fine material that was hanging around. Just couldn't grip it at all. Any other ideas?
So the guide catheter cannot engage the left main any longer?
Yes, I think the guide catheter can, but the stent is
But then
is
if the guide catheter can engage, you just put in a looped wire into the LED, no matter from where it goes, from the side of the strut or whatever. Then start dilating with small balloons and reconstruct the whole LED with long stents.
But what are you going to do about the bit of stent hanging out in the aorta?
Up to the left main ostium. The one part of the stent that is hanging in the aorta, that's not going to obstruct the coronary flow.
Okay.
So once we can reconstruct up to the ostium of the left main,
Yeah.
the patient is safe.
Yeah.
And then we can decide.
Yeah.
Next
I would
comment.
I would do the same. I would wire the left main. Right now, you don't have anything wired, so I would be so worried that you get an obstruction of the left main, a thrombus or anything with all the material you have there. So I would be very, very scared with that picture.
Yeah.
So I would wire it. I would then balloon it and stent it up and forget about what's hanging out in the aorta.
Dr. Corsandi?
Yeah, I would pray first. then you can try wiring it. I suspect the stent doesn't allow you to engage properly to get a wire down. Put a second guide catheter and get a snare and pull that thing out.
Yeah, I think the second guide is probably a better way to go. Try to do, trying to wire, getting the guide close and all those things with the stent
You'll
deformed
push it
like
more.
that is probably going to be impossible. So yeah, second guide and try to snare, the probably way to go.
Yeah,
I
so that
had-
was, sorry.
I had a case very similar like yours. So I put a wire again, 2 wires, and then I used a bioptome for biopsy. And I took the wire with the bioptome, so it helped.
Ah, okay, yeah. More grip than a conventional snare.
yes.
Yeah, okay.
Helen, show us what
Yes,
you
what-
did
Yes.
until
Oh,
the
yeah,
end.
well, yeah. So second guide, as you say, and it was the second guide I think they were trying to snare it with to start with, and a wire down the vessel at points. And then we decided, my colleague decided to try the 3-wire technique and managed to get 3 run-through wires down to the distal LAD, entangled them with the whole material that was coiled up in that proximal LAD, and managed to pull the whole lot out of the left main of the aorta and into the arm and up to the brachial, and then breathed a sigh of relief. But then the problems are not quite over, but at least they're in the arm and not in the coronary vessels. So, sorry, jumped ahead a bit. So there's this mesh of stenty, wiry stuff in the brachial, and it won't go into the sheath. So what my colleagues then did was try to upgrade to a 7 French sheath in the arm to see if they could pull that material back into the 7 French sheath, and it still wouldn't go. So they called our vascular surgical colleagues, who are usually really quite enthusiastic now that we don't call them very often. But they were a bit like, well, yeah, it's fine, just leave them, we'll take it out tomorrow. I'll put them on the emergency theatre list and I'll take it out tomorrow. And they were happy with that to start with. So with that in mind, back to a guide from the left radial, which was where the second guide went in, to see what was going on up here. So now the proximal stent is removed, the distal stent is really mangled. And there's a bit of distal stent that's kind of, I think, twisted round like a sweet wrapper by the wires that have been pulling on it that I think were twisted. So that needs redoing. So wire to the distal vessel through, and I think, everyone thought they didn't mind whether it went through or to the side, but actually it went through. Some ballooning of that area. It's not letting me advance. Oh, where we are. Some ballooning of that area. 2 more stents, and a final result. And then the 7 French sheath that had put in the radial artery wouldn't come out. So after all of his meditation, 7 hours on, he got intense spasm in his arm, and the 7 French sheath would not come out. So they tried fentanyl, verapamil, nitrates, papaverine, wouldn't come out. So called friendly vascular surgeon back again and said, how about tonight? How about? And so he took the patient to theatre and took the sheath out and took the bit of stent out in a 10-minute operation, which we always forget is really easy from the radial for a vascular surgeon. It's not a problem. So he marked where it was, took him to theatre, and he had an uneventful recovery. This is the Terumo model that they show us how to do the 3-wire technique, and they had actually been into our lab a few weeks before handily, and everyone had had a practice at it, so that was quite useful. Sorry, there's sound effects on that. So these are learning points. My fellow put, don't push, don't pull. and don't double jail a wire if you're dealing with a proximal lesion, which I think Nicola referred to earlier. The final slide. So as usual, the patient where you've caused an awful complication is the most grateful patient ever. And he sent lots of Christmas wishes and said, thank you to the wonderful NHS, and I'm back doing my karate and you're all amazing. And even though, anyway.
Excellent. This is why we need to continue this kind of session with Women as One. It's really innovative, and thank you for wonderful presentation. I think we should try to vote now. If somebody can give us guidance on how to vote. Yes, while we are voting, yes, Valeria kindly accepted to share with us what is the Women as One organization.
Yeah, thank you very much. I'm a spokesperson. I was asked to present you some insights of the Women as One organization. There was already a great success. I was part of it last year, and I'm honored to be part of it as well this year. Can I have my slides? So as you know, Women as One is an organization, and it was founded by Roxana Meran and Dr. Marie-Claude Maurice. They don't need any kind of introduction. That was in 2019 with one goal, which was to promote women and to offer women technician opportunities. So the approach of Women as One is to, first of all, amplify, to give voices promoting individual talents, but how to do that, not just put women in front, but support them throughout some educational program, throughout funding, mentorship, and organizing a professional network, and unify, connecting healthcare professional. How did Women as One do that? That was creating a talent directory. We will see what's a talent directory in a few seconds, throughout some important programs and promoting some messages of equality. So I want to stress out what the talent directory is. First of all, it's a great global network. More than 2,300 women physicians, where every physician can insert their skills and their expertise area of interest. And that's from both sides. So that's important for women physicians, but also for organization, because organization in industry, they can look up in this web directory, and they can find and reach out to physicians, for example, to set up a trial or set up any kind of collaboration. As you see, the talent directory is not focused only on interventional cardiology, but has a wide, broad areas of expertise, cover all area of work. So this is the message of inclusivity, also for undeveloped areas. And the programs. I was part of the program as an attendee. Some women who presented their cases today were also part of the program. Alaida was also in this CLIMBS training program. There was a really unique experience with a small group of attendees and really experienced world-renowned experts. And we had the chance as attendees to show our cases, our clinical cases, and get some feedback from experts. Escalator Awards. This is a program where all women can apply, propose their research programs, and after a careful evaluation, some of them will be funded and they will be carried out. And the RISE is a program which started just last year. This year is going to be held in London, probably during the ESC. So apply for it if you have any chance to go there, because this is something not really conventional. This is a program to develop some soft skills which are not usually taught during our medical university, our medical courses. So it's something else which can really add on our talents and promote a message of equality, stressing out what does it mean to have parental leave, promotion, research, and radiation safety. And as you can see, this organization has grown during the years. Since 2019, we already have, as I said, more than 2,000 women physicians, a lot of opportunities to learn and then to shine. And also, as we know, it's really important to fund some research program in order to provide new evidence. So thank you for your attention.
So thanks, Valeria. So for the one of you who did not vote yet, you just have to use the barcode. So try to do a picture, a photo, and then there will be the possibility to go to the vote. I don't know if we give some other seconds, maybe to have everybody voting. Okay. So maybe we can see the result.
Still counting.
Okay. Maybe still someone is voting.
I think, Alaida, as you did last year, probably we should thank all the participants, because it's not easy to stand up there and present your worst case, really tough complication. So it's thanks to all.
To share experience, it's all about sharing experience, and clearly complication, unfortunately, happened to all of us. So the winner, can we see again the... Okay, so the winner with 78% actually was jailed out, or how to get out of it, Ellen? It was a brilliant presentation, clearly.
I ask you a privilege is to give the gift myself to Ellen.
Give it. It's okay. So
First of all, you have to say
father.
that to Shabazz that he's a friend. Don't worry, he can come next year if he wants.
Yeah, thank you very much. Bravo. So we'll have short break now, and I would like also to thank Alaide, who worked hard this year to make this session possible. Thank you, Alaide. Short break, and we come back.
Yeah.
Could I have the slides up, please? Thank you. So welcome to this symposium kindly set up for us by Terumo. So during the next 25-30 minutes, we're just going to look at the use of the latest drug-eluting stent, so the Ultimaster stent, through its various iterations in complex PCI, and of course focusing on bifurcations because we're all here because we're obsessed with them. So we've got some great cases brought to me by my co-chair, Dr. Aminian from Belgium, and that's going to illustrate the flexibility of the latest generation stents and the sort of cases that we'll be studying in the GOMI complex, which is the registry which has started already. Sorry, it's me doing the slides, isn't it? So first of all, we'll just look back at the development of the Terumo stent for complex lesions. So Discovery 123 looked at a small study, and this was just in 60 patients looking at strut coverage with OFDI at 1, 2, and 3 months, and proved that there was 95% strut coverage at 3 months, and by 1 month, 85% strut coverage. And there was some looking at the clinical outcomes, which were comparable to Xience, but only a small study. And then we went on to Century 2, which was a multi-center trial of Ultimaster, looking more at clinical endpoints, so target lesion failure at 9 months, which was about 4.5%, and comparable to Xience. And that was with 500 patients in each arm, so a much bigger study. And then most of us are familiar with Ultimaster, which was a huge registry. We enrolled about 37,000 patients, all comers, prospective registry, and that was looking at 1-year outcomes. And that was quite interesting to look at the number of complex patients that were included in that. And it comes out at about 20%, so about 10,000 came into the category of complex there. And then MasterDapt was more looking at complex patients rather than complex lesions, so those who needed dual antiplatelet therapy needed anticoagulation alongside their antiplatelet therapy, and whether we could reduce the duration of that. So Century 2 included a bifurcation sub-analysis. There were just 95 in each group, and gave the idea that although there's not enough numbers really to show much statistical significance, that it was comparable to the Xience drug-eluting stent there. And then in Ultimaster, there were 4,400 bifurcations in Ultimaster, which really gave us a big body of evidence to look at what was going on in a large registry of bifurcations with drug-eluting stents. And some sub-analysis were done of those. One of them showed that the endpoints were adverse in the group that had significant disease in the side branch, so the 111 and the 011 or 001. So anyone who had significant disease in the side branch had a worse outcome than those who didn't. And we were able to look a bit at technique. So as in most big registries, 2 stent bifurcations, if you start off with letting people do what they want and people who work provisionally a lot of the time, 2 stents were used ultimately in about 23% of patients. And actually, if you look then retrospectively at these patients and say if people were allowed to do 1 stent or 2 stents as they found appropriate, and about a quarter of them got 2 stents, the outcomes in the 1 stent and 2 stent are very similar, with perhaps just a slight signal for stent thrombosis. And that's an interesting comparison to the kind of randomized 2 stents versus 1 stent study, I think. The other analysis was looking at POT, and probably the word hadn't got out then in that study about the importance of POT. People knew what it was, but perhaps we hadn't preached about it quite so much. And in 66% of patients, there was no proximal optimization, and they had worse outcomes. So that was kind of retrospective proof of what this club have been saying for quite some time. Kissing was also undertaken in a similar proportion, so about a third, but the signal wasn't so big if you kissed or didn't kiss in terms of outcome. And then there was an analysis of male versus female, and surprisingly, there was no difference. So onto the new generation of the Nagomi stent. So that's, for those of you who are using this now, it's got 3 platforms now rather than 2. It's got a huge number of sizes available. You haven't really got room on your shelf in the cath lab for everything that's available there, but importantly, you've got lengths up to 50 millimeters, so 44 and 50 millimeter lengths, and 2 millimeter, 4.5 millimeter diameter stents, and optimized overexpansion capacity. So anything above a 3.5 will go up to 6.25 by the instructions for use. The stent's got a new hydrophilic coating, so it's supposed to be more deliverable than the previous iterations of the Ultimaster, but otherwise it's built upon the evidence and experience of the Ultimaster family. So without further delay, I think we'll move on to some Nagomi cases and talk about some of the patients that are going to be in the Nagomi complex study. So that's going to be 3,000 patients, a complex PCI, and what comes into complex you can see here. So, sorry, on the next slide. So long lesions, left main, calcification, multivessel, bifurcation, and there's going to be QCA analysis of the bifurcation group intentionally, CTOs and restenosis with clinical follow-up. So 3,000 patients. We started April this year. It should finish by September next year. And I think some of the cases you're going to present are already in that registry.
Thank you. Thank you very much, and thank you for the organization to inviting me to present those cases. So don't hesitate to interrupt me at any time during my presentation if you want to comment on any cases that you would like. So the first case is, of course, all cases were done with Nagomi, but it's a 55-year-old male with dyslipidemia, or untreated at the time of presentation, presented with acute coronary syndrome and non-ST elevation MI. The ejection fraction was 55% with hypokinesia and the anterolateral wall. The patient could be considered as a low bleeding risk because the precise DAP score was less than 25 and the renal function is totally normal. So I'll show you the angio. So we can see a very long lesion going from the proximal circ to the distal circ with some spot of very tight stenosis. So we see that the ostium of the marginal branch actually is not really diseased. And there's another lesion on the mid LED, a very tight lesion also. So we decided to treat both lesions ad hoc because it was an acute patient. So here, if you look at the strategy here, so we could say that it's circumflex non-true bifurcation with a Medina 110. So there was two options. One is to put a stent proximal in the proximal circ and one in the distal circ, but we felt that probably we'll ended up in the proximal part in somewhere in the plaque, and we decided to go really cross the marginal and to really do like a bifurcation. It was a long lesion, so we decided to go for a provisional stenting strategy with a POIT side POT. And this is an acute setting, and we are quite late in the afternoon, and it was difficult to go for intravascular imaging, so we went only for angio guidance. This is real life, actually. Anyway, the patient was fulfilling the criteria for the registry because he had 2 vessel disease that we are going to treat, so this was one of the inclusion criteria. So we see that very simply, so we predilated the distal circ and the proximal circ with a non-compliant balloon 2.75. And then you see the crossing of the new size that we have now, the 2.75 50 millimeter Nagomi stent, which was actually covering the full lesion from the proximal circ to the distal circ, actually, which was inflated at 14 atmosphere. Then, of course, the POT with a 3.5 millimeter semi-compliant balloon. We always use, we try to use, in most of our cases, a semi-compliant balloon because we think that the apposition will be better as compared to a non-compliant balloon. And of course, when you stent such a long length of lesion, you must ensure that the POT really covers the full length of the stent in its proximal part. So we went really, we ensured that it was the case actually. Then side branch opening with the 2.75 non-compliant balloon, and the final POT with the same balloon actually. And this shows you that we use the stent enhancement to be sure that actually we are really doing the POT because that, of course, it's a reason. I will show that in the next case for abdominal passage of a wire if you don't POT really the full length of the stent in the proximal part. So still we're not happy with the distal part, so we did another post-dilatation, and this is the final angiographic result. So this is without intravascular imaging control, but we think that the angiographic result was quite acceptable in this case. So this is the first case. And then, of course, the LED was treated straightforward with a pre-dilatation and a 2.75 and 21 millimeter Nagomi stent. This is the final result. So the second case I will show you is more. Yeah, why we use the pod side pod, this is open to discussion, but I had the opportunity to be part of this OCT trial that was actually published in Your Intervention 4 years ago. And this is one of few trials or studies really assessing live intravascular, the one technique, actually pod side pod, and this was done with OCT. So there was a run before, after placing the main stent, and after doing the full report sequence. And what this study shows is that actually it brings very good result in terms of proximal apposition, distal apposition, and also in terms of side branch obstruction, which is actually very low. And most of the time you don't have to go for a kissing, and that's why this is our preferred technique. When we have to do a provisional, we do always a pod side pod, and we do a kissing balloon inflation in only a few cases, and that's really my way of working. And this is further assessed in a large multi-center registry, which has now completed and is submitted actually to a journal under review with, and I can tell you, very good result in terms of target lesion failure. And the second case, so it's an 82-year-old male with a permanent atrial fibrillation. The patient is on NOAC, a rivaroxaban, 15 milligram. He has a known ischemic heart disease with previous DS on the mid LAD and also the distal LAD. He has a previous pacemaker, there's a former smoker, so the presentation is again an acute coronary syndrome, non-ST elevation MI. Ejection fraction is 50%, and the patient has on the transthoracic echocardiogram and hypokinesia on the anteroapical segment. The renal function is normal, however, the patient had several previous serious GI bleeding due to diverticulosis and angiodysplasia. So this is the angiogram of the patient. You see there is a tight lesion on the intermediate branch that you can see on the top of the screen, but also the very complex lesion proximal to the previous implanted stent at the level of the proximal LAD, involving a very large diagonal, which is diseased from the ostium and more than 10 millimeter beyond the ostium, I would say. So who would go here, for example, for a two-stent technique in the room? I think, okay, I have the light just in my...
Probably a minority for two stents.
A minority if we go for two stents. Interesting.
Who's going for no stents?
Okay, interesting. And maybe a DCB, why not? I mean, we have had very...
people going for no stents.
Interesting discussion.
And who would go for just a provisional and ignore the diagonal?
Okay.
Okay.
So here was our strategy. So it's a LED diagonal true bifurcation. So it's a Medina 011 because the proximal is not really involved. The lesion length at the level of the side branch is clearly more than 10 millimeter. This is a very important side branch. So we decided to go for a planned two-stent strategy using one of the preferred technique from David Ildick-Smith, which is the DK crush. He loves that, I know. Every meeting he presents, no, it's a joke. So here we decided to go for a nano crush because we wanted to decrease, because of the angle of the diagonal, we wanted to decrease as much as possible the overlap of struts in the proximal segment. So we went for this technique, actually the nano crush technique, with a minimal overlap of, let's say, 1 millimeter, not more. And just I would show you that I recently had the opportunity to do some bench tests with the Nagomi stent. You know, when we do the bench test and you do that kind of two-stent techniques, sometimes you see very impressive deformation of the stent that you could probably not see live on angio, actually, unless you do intravascular imaging. And even then, you have to do reconstruction and so on. So it's interesting to test this stent in bench test, especially when you do the two-stent technique. So I'll show you here the opportunity to do that nano crush technique. So this is a bench model with a 2.75 diagonal, 3 millimeter distal LAD, and proximal 3.5 at the level of the main vessel. So this is first in the diagonal, I would say diagonal here, a 2.75 50 millimeter Nagomi stent. And this is the crush with there's always a discussion about what size of balloon you should use, but here we decided to go in between the proximal and the distal, but usually it should be close to the proximal main vessel. So it's a 3 millimeter diameter semi-compliant balloon that we inflated for crushing the stent in the diagonal. Then this is the result after the first crush, and then the stent is implanted directly. So the nano crush, you skip actually the first kissing balloon inflation, and you go directly with the main stent. So this is a Nagomi 3.21 millimeter stent. This is of course a pot, which is very important, with a 3.5 millimeter semi-compliant balloon placed at the right spot. Then the rewiring through a proximal strut, very important, and the kissing balloon with 2 non-compliant balloons. And the final pot, which can be, of course, more proximal because the kissing balloon has already done the job at the level of the carina. And you see here the final result. And you see very nicely that actually the architecture of the stent remains relatively good despite all these maneuvers when doing this bench test. So we try to replicate that in live here. So we see first predilatation of the LED, then the diagonal first, and the LED. And then a very long stent, again 50 millimeter Nagomi 2.75 was placed in the diagonal using the nano crush technique because we wanted to cover as much plaque as possible. I know that the advocate of DCB will not be happy with that, but okay, that was our strategy here. And of course the balloon was already placed in the proximal LED for crushing the stent. So this is the placement of the stent and then the crush. And then we placed the other stent in the LED. It was a 3 millimeter diameter and 38 millimeter length Nagomi stent in the proximal LED, and we had to be sure that we were not protruding into the left main, so we had to do a different views. Of course, the pot, very important, the pot with the 3.5 millimeter semi-compliant balloon. And this is the stent enhancement of the crush. And then rewiring, of course, we didn't do the first kissing, so of course the rewiring of the diagonal was not an easy one, but I can show you here that after several attempts it worked. This is, I think, a cyan blue extra support wire. This is our regular one. And then, of course, a kissing balloon inflation. And the final pot, of course, again, more proximal. And this is the final angiographic result. So there is a good discussion in this case about what will be the antithrombotic strategy in this case. We cannot move forward. This is the stent enhancement of this case. Again, it was an acute setting, and we didn't go for intravascular imaging, but I will show other cases when we did it. And okay, in this case, we can also, like Hélène said, build on previous knowledge that we have with I would say, with the Ultimaster Tansei technology that was assessed before in the Master DAP trial. And we know this trial, patients at high bleeding risk were randomized 1-to-1 to receive an abbreviated antithrombotic strategy as compared to a regular one. And if you look, and patients were also stratified according to the fact that they were on oral anticoagulant therapy or not. And if the patient were on oral anticoagulant therapy, and were randomized to the abbreviated therapy, it was after 1 month of DAPT, it was single antiplatelet therapy for only 5 months as compared to 3 months of DAPT in the other group. And what we see in this trial is that this is the two curves, when you look at the right graph, this is the two curves at the top, that the patient that were on abbreviated antiplatelet therapy, I mean only 1 month of DAPT and then only SAPT in patients that were taking oral anticoagulant drug, had less bleeding without increasing the ischemic risk. So we can build on this to say that in this patient, the precise DAP score was very high, actually 71, because all the previous GI bleeding, the OAC, the age of the patient, and so on. And so if we look at the recommendation on the guidelines, we can estimate that this patient has an acute coronary syndrome, but we can estimate here probably that the bleeding risk is outweighed actually the ischemic risk. So we decided to go for this strategy, 1 week of triple therapy, and then only clopidogrel for 6 months with the rivaroxaban low dose. So the third case, it's a 77-year-old male with dyslipidemia, hypertension, a previous also drug-eluting stent in the mid-LED and also proximal LED using, again, pod-side pod, and you will see the result after several years. The patient has angina, he has a good ejection fraction. He has a positive stress test on the anterior wall, actually. and the coronary, control coronary angiography show a significant distal left main lesion. The renal function is normal, the patient is at low bleeding risk. And this is the left main. So this is not the most complex left main that we have seen today, but it's still, I would say, a distal left main. I think this is really the perfect case for stenting because we have seen very complex left main today, and I think probably some of them could be referred to surgery, I think. But this probably is the good case, at least discussed with surgeons, I would say. But this is really the case, I think, when as interventionalists, we can really get a good result as far as we do a correct job, of course, because we need to know the size, we need to have a good apposition at the end and so on. So it's very important. If you treat the patient with stent, you must be sure about your sizes and your apposition, especially for a left main. So it's a distal left main, Medina 100. So I think the best way is to go for a provisional stenting strategy. And here the plan was to put just a stent Nagomi from the left main to the proximal LED. And of course, here we will use an angio and OCT guidance. I say of course because not all cath labs will do like this, but I think left main is really the lesion when you need to do that. I think it's not now in the guidelines, but I think it's really probably the lesion that really needs imaging because of the high risk of malapposition if you have a missizing. So the patient was preloaded with clopidogrel, and I just show you the, so first we did a light predilatation to be sure that the OCT catheter will cross easily. And this is the OCT images. And we see that actually it was a large proximal LED with I would say mean diameter around 4 millimeter. And the left main, it was difficult as always with the OCT to have really the true diameter, but we could estimate that the media to media was close to 5.3, 5.5 millimeter. And so in this case, and the length to cover, because there was already a stent in the proximal LED, the length to cover from the ostium of the left main to the old stent was around 14 millimeter. And so if you look at the overexpansion capacity of the Nagomi stent, we see that from 3.5 millimeter stent, you can upgrade the size up to 6.25 millimeter. This is confirmed by François Derimet, who has confirmed that in bench test. And so this is actually the case. So it was a 4 millimeter stent that we implanted from the ostium as proximal as we could to the proximal LED. So see, this is the result after the implantation of the stent, and then of course a pot. And it's not always easy to have all the sizes of balloon available in your cath lab. So here we had a 5 millimeter semi-compliant balloon. Probably it's better to have very large balloon available in your lab when you do a case like this, but we thought that in this case a 5 millimeter semi-compliant balloon was enough to do the job. At 16 atmosphere, so we can expect that the size went probably close to 5.5, something like that. This is the rewiring of the circ, probably through a distal strut, but we cannot assess it, although I know that there is the October trial that was really looking at this, published now in New England. And this is the first inflation in the side branch, and then a kissing balloon. So we see that I'm not an extremist. Sometimes I do a kissing balloon inflation, especially when the angle is very acute, because I don't want to have a shift, especially if the side branch is extremely large, like here. And the final pot. And at the end, we had that OCT control showing a few malapposition just at the distal part of the stent that we corrected afterwards. And we see very large opening at the level of the proximal LED and also at the level of the left main with very large minimal lumen area. And if we look at the ostium of the LED, it was good actually. We had an opening minimal surface area of 9.6 millimeters square, which actually fulfills the criteria that was previously published when using IVUS, and also the one from Nicolas Amabil with a lemon, which was published in Your Intervention, where we reach actually 80% of the reference lumen area. So we're quite happy with the result, and we see also a very large opening of the struts towards the circ. And for the sake of time, and because it was also a busy day, we didn't do the OCT towards the circumflex. And due to the small malapposition and the proximal LED, we completed the result by another post-dilatation, and this is the final angiographic result, which I think it's acceptable. So the fourth case, if we have time, so it's a 59-year-old male, several risk factors, class
Sorry,
2 angina.
just a second, Adele.
Yeah.
So we'll just look at the fourth case and ask any questions rather than doing the 5 minutes at the end summary. But
Okay.
should we just, so we'll give you a moment to do the fourth case quickly. Are there any questions in the interim?
Yes, case number 2.
Yeah.
The ESC is very clear about the guidelines
Yes.
for short DAPT in HBR patients with ACS. It's 6 months. And for elective patients, it's 1 to 3 months. So is it your normal practice to give short DAPT in ACS patients for 1 month or 3 months rather than 6 months?
So if you look at my slide, the ESC guidelines try to make a balance between the bleeding risk and the ischemic risk. It was an acute coronary syndrome, and we thought here that the bleeding risk was outweighing actually the ischemic risk. And you see on my slide that when it's like that, when the balance is more towards the bleeding risk, they propose 6 months of single antiplatelet therapy in combination with OAC and only 1 week of triple antithrombotic therapy. I can show the slide again if you want, but this is what they propose. If the ischemic risk outweighs, it's exactly what you said, actually. So we have to make a balance. Here, the patient was really a high bleeding risk patient, and also we have evidence from the master DAP trial that actually it works. Because in the master DAP trial, there was only 1 month of DAPT, and after that, the patient was put on single antiplatelet therapy. And actually, there was less bleeding and no more ischemic risk.
The second question, quick.
Yes? Yeah, please.
Ultimaster Nagomi, has it got FDA approval for short DAPT?
No. But, yeah.
The platform and the drug and all of that is the same. I think that, I mean, the antiplatelet therapy question is really interesting still, isn't it? And however many studies we've done, I don't know, how many people give triple therapy for more than a month? How many people stop triple therapy after a month usually, or less? Yeah, which is not, again, not necessarily what the guidelines say. And how many people are happy with a DOAC alone after a year in complex stenting?
Yeah, me too.
Yeah, so again, the guidelines say it, but I think there are still a lot of us who are not confident that a DOAC alone, when you've done crush, culotte, left main, whatever, is necessarily good enough. So whatever the guidelines say and however many studies we have, we're still not quite there, are we, with the antiplatelets?
Another way is beyond this meeting is to close the appendage. But, then you get rid of at least the antiplatelet therapy.
So should we skip through the last case in the last couple of minutes?
I have still time to do that? Okay, well, so very quickly. So 50 ejection fraction is okay. So the patient has a known significant proximal to mid-LED lesion which was assessed by physiology with a positive FFR, low bleeding risk, normal renal function. So this is the case which was done by my colleague and friend. And you see that here it's very difficult actually, with a lot of overlap, and there is actually a proximal LED lesion, and there is several difficult things to consider here. First, the left main looks very big, and then you have like a very large proximal part of the LED just before the bifurcation. And so I think this is a typical case when you really need intravascular imaging because there is a high risk of missizing. I think I can say it's a true bifurcation, but I'm not sure about the side branch. It was very difficult to see where was the side branch. So we went for a provisional because we thought that it will be good. Angio and IVUS guidance in this case. So I show here the measurement. So a very large left main actually, which really preclude us to go from the left main to the proximal, to the beyond the diagonal, because that would be too much difference between the distal and the proximal part. You see the proximal LED is relatively large actually, close to 4.7 of maximal diameter. And the distal one is around, I would say, the mean diameter should be around 3.2, 3.3, something like that. And here, of course, we can use the overexpansion capacity of the mid part. As you can see here, if you use a 3 mm stent, we can go up to 4.5. So usually we should, normally you should have a good apposition in the proximal part. That's what we did actually. So by really trying to find a good projection, so we first we predilated the proximal LED when we put a Nagomi 3 mm, 44 mm length. And then really it was difficult to find the right plane to place it just at the ostium of the LED, which actually I think was successful here. And then a first relatively shy pot with a 4 mm semi-compliant balloon, despite the fact that we saw that the vessel is bigger. And then there was a very big difficulty to go back with the wire in the diagonal. And so really there was a stent enhancement showing that the proximal part was not adequately predilated with a pot. I mean, not adequately opposed with the correct pot. So we went for a more aggressive pot with a 4.5 mm non-compliant balloon. And then we could cross the diagonal and do like a classical pot side pot technique. And this is the final result. And very quickly, this was the final result. So relatively good minimal surface area at the level of the proximal LED, and also a very good apposition proximal without protruding into the left main. And all these cases were done through radial approach, because now we have it's a Terumo symposium. It's not about vascular access, but I think there's no need to go for femoral for all these cases. Most of the cases were done with only 6 French glide sheet slender, sometimes with a distal radial access. And even if, I mean, you still have also the 7 French slender sheet that, so you really can tailor your sheet size according to your indication. Left main, usually I do 7 French slender, but everything else I use 6 French slender. So I think this is also something that we need to consider if you want to decrease the bleeding risk in those patients to go through radial. Always good to go radial instead of femoral. Thank you very much.
Thank you. And they were great cases, Adele, and I think we've got the confidence with the modern stents that we can do all of these sorts of things, but the registry is going to be really interesting, isn't it, to have a large number of complex patients in a registry and see if the outcomes are as good as we think we are. Yves?
Only a few words. Adele, finally you found the good projection.
Yeah.
So maybe you can spend a bit of more time to have the good projection from the beginning.
Sure. There was a lot of overlap in this case. It was a nightmare. And I see all these cases I've shown are included in the registry. Yeah? So it's going to be interesting to see the outcome of those patients. And to really, you have a theoretical aspect of the new platform and so on. And now it's really assessed clinically in a large registry. So it will be interesting. Yeah.
Be interesting to see how much imaging is used as well, because we all say that we always image in complex patients.
No, it's real life. It's real life. I can tell you the second case I've shown, it was without imaging. So,
which is an introduction into the next session. There we go. Thank you very much.
Going to start straight away in the interest of time? It looks like it, yes. So, thank you very much. It's great to be invited here to give this chair. Got a fantastic panel. So we've got some objectives here in this session. I'm delighted to be here. 2 patients. I'm going to show you which one of these patients would you use imaging in, and which one would you just go for angiographic guidance. This is a kind of weird start because that's not how my slides started. So let's play it from the beginning. So if we press play and we'll go back, we'll start the session. So I'm going to thank the EBC committee. I'm going to thank Boston for the invitation. I've got a great panel. Varney, Maciej and Johan are going to give us some brilliant talks. It's going to be a quick 30 minutes, hopefully, be on time. And what we're going to try and cover is the understanding of where imaging fits into our everyday practice, because we've just heard that you don't do it all the time. What are the potential benefits it brings to our practice? Update on some of the evidence, because there's been lots of evidence in the recent year. What are these barriers to why we don't use it? Is it time? Is it cost? Is it skill set? But what can we actually bring to the table? What does imaging bring and how does it help? So in the next slide, you're going to see these two patients that I've treated, hands up in the room, who would use imaging for patient 1? Quite a few. Who would use imaging for patient 2? Who's going to be honest and say they wouldn't use imaging at all? No one. Okay, but there is difference between the two. So, without further ado, I'm going to hand over to Maciej. He's going to give us a talk, and it's going to be a great talk because I've seen the slides.
Thank you, Peter. So let me show you a very practical case, just showing how imaging, particularly IVUS here, works and what kind of benefits can we have doing a procedure with IVUS imaging. Okay, so this is a 65-year-old woman with stable coronary artery disease, quite severe angina, class 3, and what you can see here is the left main stenosis and also circumflex ostial lesion and long lesion in the LAD. Perhaps LAD does not look very severe, but you will see on IVUS that there was significant stenosis as well. So this is Medina 111 left main lesion, and in recent times we used to do all left main cases with imaging, and our approach, our regular workflow is just we are setting the length of the lesion, we look at the plaque composition, and of course we measure the diameter of the vessel. So here are the data. The proximal LAD reference diameter, as usual, is 3.5. Not much calcium, just focal calcifications. Then we have appreciate the minimal luminal area of 3.3. Then we have left main with also very significant tight stenosis, 3.55 minimal luminal area. Not much calcium, and ostium of the circ is on the third image at the 12 o'clock. So the case was done by my colleague, and he decided to do the complex technique. But before he checked the length, of course, of the lesions, and you see he decided to cover LAD and left main up to the ostium. So it's 28 millimeters, and reference vessel diameters you already heard, taken from IVUS. So he started with decay crush technique. So after pre-dilatation, of course, we didn't use any ablation technique because there was no much calcium there. You see the positioning of a circumflex stent with protrusion into the left main. Then crush with properly sized balloon, which is 4.5 here, and first kissing with 2 short NC balloons. Then, of course, a main vessel stent, 3.5 over 33, and again, second POT, second kissing, and just appreciate the final angiographic results. So they were very satisfied of this result. I think most of us would leave it like that, if not for the imaging. So they use imaging, fortunately, and of course, if we use IVUS to check the final result, of course, we concentrate on the stent edges. We look for some dissections or some deformation. Then, of course, a position of the stent is very important. And finally, stent expansion, which should be an optimal results, 90% of the reference luminal area. So this is the image. As for on the right-hand side, you see the edges of those two stents put in the circ and the LAD, and there is nothing wrong there. There's everything okay. Large lumen, no dissection. But during the procedure, they noticed something strange in the left main. So just appreciate this, and then they call me. And of course, most of you perhaps know that if you see more than one layer of the struts of the stent, if you deployed only one stent, that means that you have a stent deformation. And this is, of course, an ostium, but not only the ostium of the left main. So the guiding catheter, which was 7 French from the radial approach, just crushed partially the stent at the ostium, which was completely not visible on angiography. And we know that this complication is not a benign because in Excel study, those patients who were found by core lab having stent deformation, the MACE rate was almost tripled across 3 years, and actually the stent deformation was one of the independent predictors of MACE. So of course, this was quickly corrected with pre-dilatation, but it's still deformation was present, and a short 4.5 12 millimeter drug-eluting stent at the ostium was implanted with POT and good final result. And now you clearly see that the stent is nicely opened with a little protrusion into the aorta, which is nothing wrong, and the procedure was completed. So I think that this case is a very clear and nice presentation how IVUS may work and how IVUS may save lives in our patients. So this is a great data from the huge registry on England and Wales. And you see that after propensity match comparing of left main stenting with and without IVUS, you clearly see that there is a separation of the curves with a significant reduction in mortality after 1 year. But what struck me mostly in this study is that the effect of IVUS was observed very early. So you see, even in hospital, significant reduction in mortality of patients. So I think my case was one of the explanation how and why IVUS might work so quickly in this kind of patients. You will hear more data on IVUS, more new data on, later in the session, but this is just another meta-analysis showing that IVUS reduces mortality in left main stenting in our patients. So just to summarize, the IVUS is a very useful tool in the diagnosis of severity and distribution of left main disease, and of course optimization of the stent implantation. It plays a vital role in the recognition and management of complications during the procedure, and as compared to angio-guided left main stenting, IVUS, we are all sure, I think, improves early results and patient long-term clinical outcomes as well. Thank you very much.
So that's a fantastic presentation. Vine, I'm going to come to you first. What's your main learning from that case?
That you can't correct what you can't see. You know, so we talk about, imaging, we talk about angiographic result, and I think there is a transition where previously we would have been happy looking at an angiogram and saying that looks like an excellent angiographic result. Certainly when I was a trainee coming through in the early years as a house officer or an intern, as you want to call it, you'd read the notes from the cath lab and it would say an excellent angiographic result. But I don't think an excellent angiographic result really correlates to a true excellent result, as we can see, particularly in certain lesion subsets.
Very good. Johan, how do you feel when you see left main done in your institution without imaging?
Well, yes, scared, I guess. I guess we're trying to increase the number of left mains of imaging, and we're about 80% now, but I think sometimes we take the quick route and we don't do it, and then of course we miss things like this.
Amache, do you think you would have spotted it on the angiogram alone?
No. After so many years of practice and a long-term use of imaging, I think that we cannot get rid of this tool during our procedures. So definitely we recommend strongly to any complex bifurcation procedure using imaging, mostly IVUS. And left main is a typical indication to use IVUS because you can observe not only the bifurcation but also ostium of the stent, which was very important in this case. We noticed something wrong, and even we know very well that it may happen, and we pay attention, try to avoid, but still it happens.
Has anyone got a question? Yeah.
Okay. Do you think that the deformation was induced by the guiding catheter? The first question. And the second one is why implant a second stent? Or no, for this type of deformation, a re-expansion with balloon may be a good alternative, avoiding a new layer of metal in a decay crash.
Yeah. I'm absolutely sure that that was created by the guides. As for using the second stent, we try to we first post-dilate again with 3.5 balloon, and the angio image was much better, but still there was a kind of ugly image of the ostium of the left main because it was not covered, so the stent was shortened. Yeah? Of course, we can argue whether it should be done or not. Perhaps we could also. Patients could be left on the safe side with just one stent, but we decided to do this, and you saw that image was quite good, and the area was okay. So I think it's possible to do like that. Jacek has some comments.
In such situation, I believe that first we need to take into account tapered nature of the left main, which is very often, and second that that compliant balloons are better than non-compliant. Because usually, and I agree with you, that usually there is no problem to treat these deformations without any additional stent implantation, just with the balloon, appropriately sized balloon.
Do you think like we have the MLD max algorithm for the OCT? Of course, that works for IVUS as well. So we can make it MLD maxed, MAXD, and add another D for deformation in the end. So that whenever we are checking the final IVUS, we check for medial apposition, medial dissection, apposition, expansion, D maxed, D for deformation. So it always, you will always check it. I always use it like that, MLD maxed.
Very nice, very nice.
Yeah, very nice. It's always nice to have, the very nice algorithm or names, yeah, but definitely what we need, we cannot forget about looking at the edges of the stent. And distal, and other than left main procedures, distal of the stability of the stent is even more important, because if there is something wrong there, then the risk of thrombosis and dissection is much higher.
So I think, Eddie, if there's no other questions, we'll move on. So I think you've shown beautifully how systematic imaging pre, peri, and post gets you to a better place potentially without using it. Now, Johann's going to talk about the evidence behind where imaging sits.
Good evening. Thank you for the invitation to present very briefly a clinical update on evidence for intravascular imaging. We could talk about this for hours, but we only have 2.5-3 minutes. So I'm sure you're all aware of this landmark study published earlier this year, Renovate Complex PCI. In this study, 1,620 patients were randomized to either imaging-guided PCI, OCT, or IVUS versus angio-guided PCI. Complex lesions, CTOs, bifurcations, etc. And I'll just draw your attention to the left main, which we're talking about this evening. 11.7% of these patients had an unprotected left main PCI performed. We're all aware, I'm sure, of the results. On the left here, you can see a significant reduction in TLF in the patients who had imaging-guided PCI. And when we look at kind of pre-specified subgroup analysis, the patients with the left main had really the most benefit from the imaging-guided PCI, which is pretty clear in this slide. Professor Stone discussed this at the ESC meeting in Amsterdam. This is one of his slides. Network meta-analysis of 20 randomized studies, more than 12,000 patients who are randomized to imaging-guided versus non-imaging-guided PCI. We don't have time to delve into all the information here, but studies were looking at OCT versus angio, IVUS versus angio, OCT and IVUS versus angio as in Renovate, and some other studies as well. And there were quite a lot of results. Just one to really focus our attention. The TLF rate was significantly reduced in patients who had imaging-guided PCI, as you can see in this slide here. And I've borrowed his conclusion slide, which shares that really compared with angiographic-guided PCI, imaging-guided PCI reduces the TLF by 31%, and also cardiac death, target vessel MI, and TLR by 46, 20, and 29% of cases, respectively. Stent thrombosis and also all-cause mortality are significantly reduced by using imaging. So I guess, as Dr. Stone also mentioned here, by using imaging in lesions, we can improve the patient event-free survival and enhance the long-term outcome of the patients. especially for IVUS, as we've seen a moment ago in some data presented. Also, lots of other studies, it also permanently, well, it really reduces substantially the TLF rates in complex lesions, and I really think there is a strong case for elevation to class 1A, especially in left main PCI. Of course, what remains unclear is when should we use it, what specific lesions, apart from left main, which I think there really is sufficient data for, what are the optimal techniques, what do we use to optimize the results, and of course, looking at individual cases, countries, what are the issues, are the problems to introduce imaging? Is it legislative issues, is it training, or is it really healthcare and reimbursement issues? Of course, we also wait for the results of IVUS CHIP, which is being completed earlier this year, and hopefully we'll have a result of this, 2,000 patients randomized to IVUS-guided or angio-guided PCI in complex lesions. Thank you very much.
Thanks, Johan. That was very, very good to time. Finally, why don't you give us the barriers now, and then we'll have a discussion.
Great. Thanks very much, Peter. Thank you very much to EBC and Boston Scientific for the session. So these are my conflicts. So I'm just going to go through the UK intracoronary imaging survey data, a very sort of quick snapshot of it. We ran the survey in May 2022 with the objectives of reviewing variations in adoption of intracoronary imaging, understanding the way we distributed training, and identifying core barriers. So we got approximately 318 responses, of which actually captured about 30% of all practicing UK interventional consultant cardiologists. And a couple of key results. I can't move my slide forward. There we go. If we looked at what respondents thought by lesion in terms of the indication for intracoronary imaging, it's what you'd expect. So left main PCI, stent failure, optimization of stent result, ambiguous anatomy or to detect plaque rupture, and calcified lesions were identified as the core lesions in which imaging would be indicated. Bifurcations were lower at around the mid to late 50s in terms of the percentage of respondents. And this was what respondents actually thought the indication for imaging was. But if we actually looked at reality, so the blue line is perceived indications, as I've already discussed. The red graph is reported use in real-world practice. There was a discrepancy. For calcium, there was a 90% perceived versus a 58% use in real world. For bifurcations, it was 58% and 44%. In left main, it was 98% and 84%. And of course, we know from the left main national data in the UK that we only use IVUS or imaging in 70% of all of our left mains. So 30% of left mains don't get imaged. I think that's selection bias into the survey, and that the people that were responding were more high volume imaging operators. And then we looked at the barriers. And the first was procedural time and lab turnover. So respondents ranked their barriers to use of intracoronary imaging. Of course, this we can all understand. And that is that we just need to practice. When you start using a new tool, you're going to be slow. But if you train the cath lab, and as we become higher volume operators, we're going to get quicker. This is the Sigma learning curve, and you have to start the learning journey. The second barrier was training, proctorship, confidence, and competence. So the green line is operators that were trained, the blue line is operators that weren't. And as you can see, if you had formal training during your fellowship or as a consultant, you felt more confident in interpreting different etiologies on imaging. Again, if we look just at confident operators, even within the confident group, there were individuals that didn't feel confident interpreting calcium. Longitudinal stent deformation, as we've seen today, is important. Less than 50% felt confident seeing that on IVUS and being able to call it out. The third barrier was lack of data and guidelines. Well, we've already discussed that in our previous talks. And the fourth was cost effectiveness, which has already been demonstrated in a number of studies. And if you go into more detail on these, IVUS is actually cost neutral in some of these studies at 12 months and cost beneficial at 5 to 10 years on economic modelling.
So I'm going to leave you with a final thought. This was a wonderful paper published by Gary Mintz about 6 years ago, Intravascular Imaging, Stent Implantation and the Elephant in the Room. And these are some of the barriers that Gary Mintz identified and some of the things that would lead into a good discussion. Thank you very much.
That was a fantastic run-through and a very important survey. Well done. I'm going to ask all three of you to explain in your region and in your centres what the barriers are.
Yeah, not later than 2 days ago, I organized a kind of workshop which is repeated every month. It's on a complex coronary intervention. And the last 2 or 3 times I asked the audience, what's the main reason of not using imaging, IVUS? And I can tell you that every time is I'm not too confident with the interpretation of the image I see. And so that was not the time, that was more the lack of confidence. They just see something, but they are not sure whether they know what they are, see, and how to translate it into action. Yeah? So I think they all need more training, more consultations, or I don't know. So it's
training for you.
It's a training for me. Yeah.
Well, yeah, so I work in Belgium. I think there's numerous issues. The 2 main ones for me are, first of all, the reimbursement. I guess to use an IVUS Boston probe is €800. It's not reimbursed at present, so the hospital carries that financial burden. Second, though, of course, I think Boston and Philips are working together to try and submit something to the government to get more money for that. I also think therapeutic inertia, but people think, oh, I've been doing this for years, I'm doing a good job, I don't need imaging. And I didn't show the data earlier during the study, the presentation there, but there's lots of data from Korea where it says that even if you're very experienced, IVUS on top of that improves outcomes. So I think those 2 things can be related, but reimbursement and inertia are the 2 main issues in my cath lab, or in my country.
Fantastic. Varney, what about UK?
Well, I think from what we've shown in our survey, there's 4 main ones, isn't there? But I think if you go into the data in more detail, which we haven't obviously written this paper and published it yet, but it will come out in due course, I think training and education is a big thing. And I think a collaborative and supportive environment for consultants and fellows alike to train without judgment and without feeling like they're being looked down upon for not knowing things, because lots of people come through training programs without high volume of imaging. So we've got to be collaborative and supportive, I think.
That's a very good answer. And now, anyone in the audience with an opinion on why it's question? Opinion.
You have a microphone to.
I'll reflect on the US opinion and tangentially from the guidelines committees. It is reimbursed, imaging is reimbursed in the US, but I think there's inertia on senior consultants and particularly smaller non-surgical PCI centers in doing it because the hospital brings the cost issue up of the console, or unless there's new equipment of the boom where things are integrated, people don't like the mobile card coming up and connecting and all that. So that's a big issue. Personally, there is a drive for a class 1 recommendation setting. I think besides unprotected left main, it probably should be used for sizing in acute MI because it's so undersized. But I think if people just learn 3 things: sizing, stent failure, and knowing calcified nodules, I think that'll be more than enough. But I think there's a great push to try to push it up to class 1 recommendation, but there's a lot of barriers still, and I think it depends on the proportion of people, interventionists and non-interventionists on any committee trying to drive that decision.
Oh, that's a good answer. Anyone else in the audience? Okay, I'll go back to the panel then. Left main, obviously you've shown a great case, and we've seen in the survey and in our real practice, 30% of people are not doing it. Are there any other subsets of cases where if you're going to use imaging, you think is essential? So, Johan, we'll start with you.
Well, I showed the case there of Renovate PCI where it was left main. It was really a good point, but I think also CTO PCI. I'm sure there's some CTO operators here as well, and I think we're using IVUS imaging in about 80% of CTOs, and I think that's another region where it can really improve outcomes, and data has shown that as well. So I think these really complex lesions, calcified lesions, are where we can really, in my opinion, make the biggest difference.
Yeah, to me, the more complex the procedure, the higher the indication to use the imaging. And another issue is any complication. So if you have a stent thrombosis, for example, do imaging because there must be a couple of reasons. If you have issues, problems during the procedure, we just could seen this today crash, accidentally crashed stent out of the lumen rewiring, abdominal rewiring, so you will never see it, especially in the left main, you will never see it without imaging. Yeah? So the more complex the procedure, and if you encounter any complication during the case, then use imaging.
Yeah, I very much agree with the rest of the panel. So, left main, CTOs, calcium, long lesions, ACSs are where they're seen to be more beneficial or most beneficial and have the best kind of value for money, as it were, given that reimbursement has come up. I think also, patient subsets, so renal failure, stent failure, that comes under your lesion, but also diabetics, as we've mentioned. And I think the other important thing to remember is in certain subsets of patients, you do get a health economic benefit with use of the imaging catheter. So for those who are struggling in smaller units where, your administration is saying we're not going to reimburse this because it's an expensive device, well, actually in, patients that are diabetic, if you prevent a stent failure, so insulin-dependent diabetics, renal failure patients, etc., and in a patient that's already got a stent failure where they're much more higher risk of recurrent TLFs, the imaging device will be cost effective. So instead of blanketing it as a use for all, I think actually if those who are in countries where reimbursement is challenging can actually sell it to their administrators as high-risk patient and high-risk lesion subsets, you might find that they're a bit more amenable.
I think renal failure is a very good indication. We have now more and more ultra-low contrast use in almost only IVUS, just one injection in the beginning, at the end of the procedure. So you can really save contrast in this patient. So this is a great indication too. Yeah.
Agree. Johan?
There's a question over there.
There's a question. Yep.
Varney, you referred to ACS as being in the complex subset. So 80% of what we do, or 70, 80% of what we do is ACS. My limiting factor in my lab is time, not money. No one seems to know who pays for what in the NHS, but time is a limiting factor when there are always another 5 ACSs waiting outside. So do you truly believe all ACSs we should image?
No, that's a great question. Just to clarify, so ACS, if you look at health economic data, the ACS population is one that tends to get a better incremental benefit from a cost perspective. So that was more for people in countries where they're trying to fight for reimbursement and show the value of the device itself. I think in ACS, for me, if I take my personal experience, in ACS patients that have high patient risk features or high lesion subset features like calcium or left main bifurcations or, long segments of disease that are 50, 60 millimeters, then I would take imaging.
Good answer. I think we'll take one more question. Yes.
We should not forget about this data presented by Greg Stone and the reduction of stent thrombosis with stent optimization with intravascular imaging guidance. So the most important population of patients for this is high bleeding risk population, which was discussed just at the end of the previous session. So we are discussing shortening of dual antiplatelet therapy, which is of course good for those patients, but it would be much more safe if we before optimize stent with intravascular imaging guidance.
Very good point. Now I'm just going to sum up then, if we just pull up my last set of slides. I think I had a really interesting session. I showed you that case earlier on. You saw the two patients side by side. We just pulled that up. And various people voted for different ones where the imaging would be used. And I think we've got the data's quite clear. We've got the techniques quite clear. And I think we've got some of the barriers unleveled now. We understand them a bit more. I mean, these cases were quite similar from different left mains, but they're both relatively complex. This one here, patient 1 ended up with a DK culotte and got a Megatron and a final pot. And then patient 2 received a DK crush technique and also had Megatron and got a pretty good result, I think, angiographically. Now, which one of those got imaging? Well, I suppose that's the big question. We should, from what I was saying before, I'd be doing it in both of them, but the case that got imaging here is number 2. And the reason is because they went into a clinical trial. So in my lab, I would do all these cases of imaging, but unless there's a clinical trial. And Optimal has just finished, it's just finished recruiting 800 patients. It's going to be fascinating to get this. Imaging wasn't mandated at the beginning, but it was mandated at the end. And I think you get all this great information and quantitative information to take away for yourself, for your patient, and for anyone else if the patient ever comes back. And I think we have now, I've turned the traffic light round, because if we see green at the top, we start thinking we should do it. So I think we should do it because we've got the evidence. I think we should do it because we need training, we need to recognize that. And I think if we can get over the cost and perhaps some of the logistics around integration around the cath lab and the time and the workflow, I think we can be in a better position to offer this to more patients. And actually, I know the studies suggest that it takes longer and there's more contrast, but the reality is, once you're image guided fully, it is quicker. And the studies have got a wide spectrum of participants. Some centres doing very low volume and not very many cases, and of course they will take longer. But once you get slick at it, you get much better at it, and I think that's the key. And I think the next 10 years, if you're going to be using stents, we're going to be using more imaging. Of course, if we're using balloons, we may use less imaging. Who knows? I want to thank my expert panel and thank you all for contributing. Thanks very much.
Welcome everyone for this the last session of the day, heavy day. It's a case session, imaging, best image capture, but the best cases we had to select. And I will ask the first speaker, it's it's Niccolò Ciardetti.
Good evening, everyone. I'm Niccolò Ciardetti. I work in Careggi University Hospital of Florence. And I will present you the case of a 72-year-old male who was admitted to the emergency department in April for a NSTEMI presentation with normal echo and normal ECG. So this is the angio of the left coronary system. I won't show you the angio of the right coronary system because it was normal. As you can see, there is a subocclusion at the ostium of the left circumflex and also a disease of the distal left main and a non-significant stenosis on the ostium of the LAD. So we decided to go for a provisional to the circumflex, and we predilated the circ with a 2O balloon, a semi-compliant balloon. Then we implanted a 3O by 38 zotarolimus eluting stent to the circumflex. We performed the POT with a 3.5 balloon. And then we decided to perform the high-definition 60 megahertz Boston IVUS to understand the significance of the stenosis at the level of the LAD, ostium in particular, but in the whole segment of the proximal LAD. And as you can see in the center of the slide, there is the IVUS frame of the LAD ostium with a high plaque burden, more than 60%, and an MLA of 3.9 millimeters, which can be considered, of course, a significant stenosis on the ostium of the LAD. Instead, the IVUS showed a good result at the carina level and also an optimal apposition of the stent at the distal left main and a good expansion at the distal left main. So, what to do now?
So your original intention was to consider your circumflex as the main vessel?
Exactly, yeah.
And now and had you always had the intention that you might join it up with the second stent dependent on your imaging, or were you hoping to just get away with the single stent?
Yeah, and I think now the discussion is about to stent the LAD or only to try with a POBA or kissing.
So I guess the question to the panel is, does that plaque burden tell you now that we need to do something to the LAD?
Yeah, excuse me. Could we see again the images about the IVUS, because a little bit. So the second images is the ostium,
yeah.
The ostium of the LAD, and the lumen area is 3.88.
Yeah.
3.88. Well, this is absolutely critical. I mean,
yeah.
I don't know how it was before, but this is below the numbers. So probably you put a stent left main circumflex artery. So at this point, maybe to do some kissing, something like that, and to see after that how it is.
Yeah, if you can show the first angiogram, the first slide. See, the left main is narrow. There is a significant plaque burden in the left main. If you just follow Finney's law, I think the left main is left main diseased. If you image the left main, I'm sure you'll find a lot of plaque burden there.
The other question is why image after you've done half of the procedure? Why not image at the beginning?
Yeah, because the patient was during the procedure not so stable, not for a hemodynamic problem, but it's like not so stable. So we decided to put the stent, and then we decided to see with the IVUS.
And your angiogram also showed there is a significant, I would say significant, but there is a plaque burden at the ostium of the LAD. It's very clear on the angiogram.
Yeah, it's
so
clear.
I would, yeah.
Actually, this is a case that can go either way. If you can do a FFR after doing a crossover stenting, and the FFR will be most likely negative in this LAD. However, you can also think that the plaque burden is high. It's a non-calcified vessel. Lumen area is 3.8. The vessel is 3.5. It's a very straightforward culotte or tap, and then you'll get a very nice stent area. And the stent is unlikely to fail in an non-calcified vessel like this. So it can go either way. I think I will only do imaging to decide whether you need to put a stent or not if I want to put a stent. Otherwise, I'll do FFR and leave it. So you can justify it anyway.
Personally, I will do something else. You too? Yeah, the same?
I don't know.
Yes. I think yes. So, okay, show us.
Yeah. So, of course, we decided to do something, but we decided first to try with a drug coating balloon to the LAD, and in particular a 3.0 by 10 millimeters paclitaxel eluting balloon. And then we inflated at 8 atmospheres for 90 seconds, and then we perform a kissing with the same drug-coated balloon to the LAD and with a 2.75 millimeters balloon to the...
If I can ask, did you pre-dilate before using the drug-coated balloon? Wow.
And this is the IVUS.
High pressure.
This is the IVUS after the drug-coated balloon to the LAD. As you can see, there is a high plaque burden after the drug-coated balloon, but an optimal lumen gain and an increase of the MLA from the 3.88 to 5.12 millimeters that now can be considered a good result. And also a good result at the carina level and also at the distal left main with a round shape of the stent. But I think that the most interesting point of this case is the comparison between the IVUS pre-DCB and IVUS post-DCB on the LAD, because the IVUS showed a luminal gain, but in particular clearly showed the deposition of the paclitaxel crystals on the intima of the LAD, which can be seen as a circular hyperechoic layer on the entire segment of the LAD treated with DCB. As you can see, the comparison is very interesting because in the pre-PCI there is no layer, no hyperechoic layer. In the post-PCI there is this high hyperechoic layer. And this is the final angio for the patient. So, in conclusion, drug-coating balloon use is expanding due to the concept of nothing left behind and the good long-term results demonstrated so far. The high-definition IVUS can be used to demonstrate the intimal deposition of paclitaxel crystals, and this is the first reported case so far of direct visualization of the coating of the drug-coating balloon with the high-definition IVUS on the left main bifurcation intima. Further IVUS study will reveal how long this pattern persists and whether its visualization is associated with better drug response and also a lower risk of restenosis over time. Thank you.
So,
Thank you. Sorry.
Can I ask you something?
Of course.
First of all, the concept of drug-eluting balloons is that you cause with pre-dilatation some dissection, so the drug can go into the vessel wall. This is the first one. So I don't understand using drug-coated balloons and not prepare the vessel, even with high-pressure balloon or some scoring balloon. And the second, I never do kissing with drug-eluting balloons. Is it usually that you do kissing with drug-eluting balloons?
I think
because you had the drug-eluting balloon in the LAD and the non-compliant in the circ for kissing.
I think in this case, I agree for not to perform the kissing with a drug-coated balloon in a case where there is no stent in the proximal segment of the main vessel, because in a case like this, there is the stent on the left main. So our purpose was only to deliver the paclitaxel on the LAD ostium and the proximal part of the LAD and not on the distal left main.
Yes,
so,
but you didn't prepare the lesion, and you should prepare because the paclitaxel should go into the vessel.
Yeah,
but you didn't pre-dilatate the LAD.
Yes, but we obtained an optimal result on the LAD ostium.
But it's because of the balloon, not because of the drug.
Well, the LAD is actually much bigger than the lumen that you achieved, so arguably you could have gone larger and have got even a better lumen, because your cell will take that. And go
ahead. First of all, we have seen the paclitaxel on the wall, so it is on the wall. Yes, it is on the wall. We have seen the crystals on the wall. That's the first. The second point is that the lesion in LAD is short. And we know since a long time the phenomenon was described by Bernard Chevalier when in DES you have some elution from strut to distal bed. It's not 1 centimeter, it's 1.5 to 3 millimeters. That's the second point. And the third point is that when you do a kissing with 1 DCB, it was explained this afternoon, so I understand very well what was said.
Yeah.
But here, when doing your kissing, was not to treat the left main, was to treat the LED
Exactly.
with a DCB, you know?
Exactly.
So before the DCB, Francesca and probably Helen can tell what we have done in Massy. I was doing that very frequently. This is what we call an inverted provisional. So you stand from the left main to the long lesion in the circumflex. After that, you do a kiss and you look. And the result was not so bad. And of course, with DCB is much better. So don't forget this, because I'm still convinced, and if you look at the long-term follow-up of Nordic 1 and BBC 1 at 10 years, having a double stenting is a problem what is not necessary. If you are not convinced, because this is Nordic 1 and BBC 1 is non-left main, you can look at the result of the trial of syntax. The syntax at 10 years on left main group, which was nearly half the population of the trial, there is a difference in mortality at the advantage of the single stenting. Again, so it's not because we are in the left main that you have to put double stenting. Okay?
Okay, I think we have to move on. Thank you very much.
Thank you.
Next, we'll have Dr. Annette Mazniczka with side branch occlusion during LED diagonal bifurcation PCI, rescued with an out-of-the-ordinary technique. Dr. Mazniczka.
Just don't forget at the end we have to vote also. Huh?
Good afternoon, everyone. I'm Annette, and I'm a fellow from Bern in Switzerland, and it's a great pleasure to be here to present this interesting case of side branch occlusion during bifurcation PCI, and this was from my CTO fellowship in Leeds in the UK. My only disclosure is that I'm an EAPCI grant award recipient. A 50-year-old man presented with acute non-STEMI. He had several months of angina prior to presenting to hospital. Ventricular function, renal function, and hemoglobin were normal. The angiogram showed a chronic total occlusion of the RCA. From proximal LED to diagonal, there was a short occlusion, which we thought was probably recent, and there was a separate mid-LED CTO, which appeared longer than 20 millimeters, so had a JCTO score of 1. The consensus from the heart team was that PCI or bypass graft surgery were both feasible, but LED suitability as a graft target was uncertain, so he returned to the cath lab for PCI. Our plan was a stepwise provisional strategy with stenting from proximal to mid-LED, with upfront dilatation of the diagonal ostium, and if there was an unsatisfactory result in the side branch, then the bailout plan was reverse calotte. I used a 7 French Voda 3.5 guide up the right radial artery. A recrossed dual lumen microcatheter was used to advance a pilot 200 wire into the diagonal. The mid-LED CTO was crossed antegradally with a gladius wire, and then we de-escalated to cyan blue wires. Interestingly, when we dilated the diagonal ostium with a 2.5 by 15 emerge balloon, the flow in the LAD became less brisk. And when we dilated the LAD with a 3.5 by 20 non-compliant balloon, the flow in the diagonal became less brisk. Here is the LAD IVUS. We see that the LED wire is in the true lumen, and now we see the diagonal wire coming in. There was fibrocalcific plaque. The arc of calcium's less than 180 degrees, and there were calcium fractures. So further calcium modification wasn't needed. We deployed a Zions 3.5 by 33 stent from proximal to mid-LED, and POT was with a 4.5 by 15 non-compliant balloon proximal to the diagonal. Immediately after this, he had chest pain, an ST elevation, and this is the angiogram at that time. So we can see that there's an acutely occluded diagonal branch. It was very difficult to rewire this diagonal despite having a dual lumen microcatheter, and despite having the jailed wire as a marker. We tried changing the curve on the wire. We tried changing to a hydrophilic field or XTR wire, but every time the wire was subintimal. We even inflated with a 10/8 Ikazuchi balloon on the jailed wire behind the stent. Now that should work to restore flow to the diagonal because it creates a passage for blood to go from the LAD behind the stent into the diagonal lumen. But it didn't work, and it was very unusual that this technique didn't work. So perhaps now would be good to pause and listen to the panel for their opinions on the mechanism of side branch occlusion and what they would do next.
So my first question would be, why pre-dilate the diagonal before you start treating the LAD? Because the risk is always then that you're going to recross into the false lumen. And I can see that it was very tight, but there was not much flow in it to start with, so there was no need to restore the flow up front.
I think it was because we saw an occlusion there and we thought it was actually going into the diagonal from the LAD, and we thought that was the cause for the end STEMI. So that was our reason for treating that first, and we ended up dilating the ostium of the side branch for that reason.
Okay, interesting. Your question was what to do. Well, really, I find myself in a little bit difficulties. Probably after several attempts to enter the diagonal branch, probably I will do IVUS or something to see where is the probable ostium of the diagonal after the stenting of the LAD, and we'll try to take probably the ostium with the wire. Probably we'll do that. It's a really interesting, difficult situation.
So yeah, thank you for sharing a very nice case. I think even in the first image we saw a lot of thrombus in the LAD, even on the IVUS, and I think the major concern in this bifurcation is that you are somehow at this point you are feeling that there is a flap in front of the diagonal which has closed the diagonal, so the wire was true to false and true in the diagonal. This is what happens. I think we presented a similar case a few years back. Then we saw on IVUS there was a flap in front of the diagonal. Then you take a dual lumen and a stiff wire like a Gaia 2 and then pierce that into the diagonal. That is what might have happened. Otherwise, it would be very easy to wire this diagonal.
Okay.
So agree with all of the above, but wonder whether you had potted at the level of the diagonal at this point.
Yeah, so after deploying the stent, we did do pot.
Yeah.
But we didn't go to very high pressure because we could see the flow in the diagonal slightly reduced with the stent positioning. But we did pot.
So once you have a dissected vessel, it may be more difficult, but you can still, by doing a really good pot, and I sometimes have to do it several times, it changes the angle and opens up the struts better and may give you better access to that true lumen of the side branch, or at least to be able to find it.
Another question. Do you use usually you use a pilot 50 for crossing this kind of lesion? Is your wire?
I didn't present a few steps with other wires. We started with cyan blue and weren't able to, so we escalated to the pilot.
Okay. Thanks.
Yeah, since the LED was the cause, so in STEMI I would have just first dilated the LED wire diagonal and just not touched the diagonal. I would have seen what happens after stenting, and then that would have just a different strategy.
I think, sorry, I think you can, after inflation with one O balloon, you can go with microcatheter, inject some dye in side branch and see what happens. That could be, I mean, more effective in order to know what exactly you have on side branch.
Okay.
Yeah, maybe we can move.
Yeah, should we see what happened? Okay, all right.
The other thing what we have done is you could have upsized the jailed balloon from 1 to 1.52 and just see what happens. So that was...
So let's see what we did. So we thought it was very unusual that inflating a balloon on the jailed wire didn't work to restore flow to the diagonal. So what we did is we reviewed the LAD IVUS from earlier before stenting. And on the still frame, we can see the IVUS catheter encircled by LAD vessel wall, But we can see the diagonal wire is in a subintimal plane, in a tissue plane at the diagonal ostium. So there was a flap of tissue between the LAD and the diagonal, which was preventing wiring directly into the true lumen. And this also explains why inflating this small balloon on the jailed wire didn't work to restore flow. Due to subintimal passage of the wire from the LED to diagonal, the balloon on the jailed wire was inflated in the subintimal space, and when the balloon was deflated, the mesh from the LED stent collapsed the space. Even if we look at the fluoro from stent positioning from earlier, we see a lucency which shouldn't be there, and that represents the tissue plane between the lumen of the LED and diagonal arteries. So to rescue the diagonal, we did subintimal tracking and re-entry, so the STAR technique. And for this we used a straight tip microcatheter and a polymer jacketed gladius wire which was knuckled, and we advanced the knuckled wire in the subintimal space of the diagonal until it spontaneously re-entered the diagonal true lumen, and this typically occurs at a branch point. This is the IVUS of the diagonal after rewiring, and we see it starts in the true lumen. But as we move more proximal, we can see there's a short segment of subintimal tracking, so now the IVUS catheter is in the subintimal space in the diagonal. We restored flow to the diagonal with a 20 by 20 emerge balloon, and then we did reverse clot with a Zients 2.25 by 23 stent from diagonal to LAD. We did POT with a 4.5 by 15 non-compliant balloon, and then kissing inflations with a 2.5 non-compliant balloon in the diagonal and 3.5 non-compliant balloon in the LAD. We had a beautiful final angiographic result with TIMI3 flow in the diagonal and the LAD. 6 months later, he still had angina, and he returned electively for PCI to the right coronary CTO, which we successfully did with antegrade wire escalation with the gladius wire. This is the final result. At 6 months, he had a very good result in the left system. So he had a good longer-term result from the STAR technique. In conclusion, the main learning point is to look carefully on intracoronary imaging to see if the side branch wire passes subintimally at the ostium. The second learning point is that STAR, we should keep that in mind as an effective bailout strategy for stent-jailed side branch occlusion. And finally, inflating a small balloon on a jailed wire is usually an effective bailout strategy to restore side branch flow, except when there is subintimal passage of the jailed wire when entering the side branch. I'll finish by thanking Abdul Mozid. He was my supervisor in Leeds. Thank you.
Thank you very much. Very beautiful case. Don't forget, of course, the rescue balloon technique described by Francesco. Very helpful in this situation, particularly when you have got chest pain, modification of EKG. It's very useful to recross if you are in a through lumen, of course.
Thank you so much for a wonderful case. Do you think if you did a pre-kissing, even if the wire was subintimal in the diagonal at some point, if we did a pre-kissing, will it prevent occlusion of the diagonal, or it will not be helpful?
Do you mean kissing before we stent
putting
it?
the LED stent, suppose?
Yeah, I don't think so, because I think once the LED stent was there, it acted like a barrier, like a mesh, that even if you dilated behind the stent to make a space, it would just collapse it. So I think it just pushed the flap of tissue over the ostium.
Because this phenomena is very common. I think Dr. Eve will remember we discussed it, how to treat CTO bifurcation, that whether we should always put 2 stents, because some part of the wire is many a time subintimal. And we face this problem when we are doing reverse cart and there is a bifurcation. So it's a very particular problem.
So I think that that appearance may not mean that you entered the wire subintimally, but that your balloon inflation then took it subintimal with the angulation. I see that not infrequently.
Okay, we're on strict instruction to keep to time, so thank you very much, Annette. We will move on to Dejan Milansinovic.
So, dear Chairman, dear EBC organizers, I'm very grateful for being here and given a chance to present. So my case today is about two arguments. One is that ostial, LAD, and circumflex are territories which I think are a bit uncharted in terms of data. So we have neither randomized evidence, but we also do not have large observational trials. So learning from cases, I think, is indispensable, and providing guidance or getting guidance from EBC, I think, is very important. And the second argument will be that these cases are probably much better done with the intracoronary imaging than without it, at least to understand the mechanisms of potential problems and pitfalls that we can face. That being said, I would like to introduce you a case of a patient who was 54 years old, and this was in February 2022, where he presented with an ACS to our lab. This was a proximal circumflex subocclusion, as you will see shortly, and he was treated with a stent. Afterwards, a year afterwards, he presented with an episode of a chest pain, and non-invasive testing showed inducible ischemia in the anterior wall territory. There was no LAD lesions described that would suggest that something was wrong in the initial angio. So this was suspectable, and we then performed in April 2023, following this positive stress echo follow-up angio. And this is how the case began, and you will then see and, of course, have time to discuss. So this was the initial angiography with a subtotal occlusion of circumflex, an ACS patient, a young ACS patient, and what we thought at that time was a nice final result on angiography. There was a question about the need for intracoronary imaging in ACS patients. Of course, given the multitude of these patients, it's at the moment not possible to perform intracoronary imaging in all, and we were satisfied with the result here. This is the angio 1 year later. Now, the question is, of course, what happened? There's a big question mark, and we thought that if we leave it by angiography, the question mark will remain a question mark. So, yeah, please tell us. Please tell us. I think this is the place to stop, and then I'll give the case resolution. But there are actually two question marks. One is what is it, and the second one is what to do next.
I think we discussed the stent has elongated, and it has come into the circumflex stent has elongated after dilatation into the left main. And then you can convert it into a string culotte. You can just put a wire into the circumflex, put a dual lumen catheter from the first strut of the circumflex, which is protruding into the left main, put a wire in the LAD and convert it into a string culotte, which will be perfect for this, I think. But
now,
I don't know what you
The question is, do you think it is, whether it is relevant to know what is the stent in the circumflex if we are going to pursue that strategy, given the actually big discrepancy in diameters that you can guess on angio and might quantify on imaging?
Yes, I think that's a very important point, that not every stent can be converted into a culotte, but also it's very difficult to crush this stent, so it's a problem.
I will do something different. 2 wires, a balloon, a single balloon toward the LED, and then look at what's the result.
Yeah. Original details, and is he symptomatic?
Probably kissing, and that's all.
We are in an imaging session, so maybe we will do image.
What are the original details?
Thank you for your support. Yeah. So we need imaging, you think? Okay.
Yeah. Is he symptomatic?
Yeah, so the patient, I don't know who's asking, so yeah, so the patient had one episode of not really typical chest pain. So we sent him he came actually to my clinic. I did not do the first case. I met the patient 1 year later, and he came to my clinic. And the reason why I actually did this chest echo was because there was some non-culprit disease that was described on the right coronary artery, which was not significant at that time. But that was actually the reason why I sent him to stress echo. But when the result came of inducible anterior wall ischemia, then I was puzzled. So this was actually the reason why I triggered the coronary angio afterwards. Okay, so should I show the yeah. So the next step was OCT from circumflex. Now, you can already see on the longitudinal dimension that there is a large protrusion of the circumflex stent that actually covers the ostium LAD almost completely, and that protrudes into the left main. You see in yellow, enlarged, the part that shows that there is a tissue now covering the LAD that actually is an overgrowth tissue over the LAD ostium. And then you, of course, see the malapposition of the stent in the left main in blue highlighted. Now the next question is, what should we do next? This is the resolution of the first question mark. And I think this schema may show what we have, and that is a fairly large amount of tissue now that basically obstructs the LAD ostium. So the question is, what's next?
So I guess there's two options. Shall we vote? Do you go
Yes,
through
I would like to know
Do you
that,
go
yeah.
through it, or do you crush it?
Yeah, that's exactly the dilemma. So
Hands up for crush.
So the problem is there's tissue over it.
Yeah, yeah, that actually is what I wanted to hear. Yeah, because you said whichever way the wire goes. Yes. And I think that's an important point. Yes?
You can wire this proximal strut, the first strut.
So that's the two options we've heard here: is a bit of a culotte or a crush.
May I go a step back and say, okay, on that imaging that we showed, if you want to be systematic, it was important to know first what happened, so what is the mechanism of what we see. But the same imaging run, we use also to see the diameters. And we know that the stent is 3.0. And what we could see is that the left main was 5.5. So now my strategy of culotte becomes, I think, a little bit less attractive than the crush, for example. Then, if we think systematically, the next step will be, how can I perform either? And there we come, I think, to your very important point. Once we place the wire into the LAD, we will need to know where that wire is. Now, angiography is probably not going to be sufficient. May I perhaps proceed? So I will show you that. So this is exactly what we did. So I was thinking, okay, based on the first imaging run, what I know is that culotte may be problematic with a 3.0 stent, and it was Orsira actually, and a 5.5 millimeter left main diameter. So I crossed the wire, and now I have a question mark for myself, a second one, because I really want to know where that wire is. So my next step after placing the wire was to repeat the imaging. And you will see now where the wire was. It's outside of the stent. Good. I could not have known this without this repeated imaging run. So I would be in doubt what steps to perform. And we know that the steps of culotte and DK crush are different. So without imaging, from this point on, after placing the wire into the LED, I would be uncertain which way to go, unless I performed imaging. So this was done. So this is once again circumscribed the stent. But look at the longitudinal image. I think it's nice to see how much it protrudes. You see the probe? It barely goes behind the stent struts. So it was a large protrusion, completely unrecognized on angio. And it was a young ACS patient. This is why I think that these details do matter. So after having the wire there, yes, please.
So I agree with the crush step. However, you mentioned that there was overgrowth of tissue.
Exactly, that's a problem.
So that's going to be a problem.
Yes.
And you may need a much more than a workhorse wire to recross that.
I agree. We were lucky. We could do it with a workhorse wire, as you will see. So this was the first step, crushing with a smaller balloon. Then we did with a larger balloon that was sized to the left main. And in the end, this is how it looked like. So it was DK crush, step by step. What you can appreciate is there is a neocarina, which is covered by tissue. So you're not going to get rid of that tissue. That tissue was there. We were just concerned, or we were aiming at centralizing this carina as much as possible and achieving the diameters in the ostia of the LAD and circumflex as much as possible. And this was a 3D reconstruction. Once again, we needed imaging to ascertain that. And this is what we did with the 3D reconstruction. We could see the neocorina, and you see in yellow the circumflex pullback, and you see in blue the LAD pullback. So these were our conclusions. We actually had 3 images that we thought changed the course of the procedure. There is always a question, and I think following October trial, there will be more and more questions. What it is that makes this trial positive? What are the steps? What are the images that help us really achieve procedural results? And here, I think we can list 3 steps and 3 clear images that guided our procedure, and I hope helped the patient at the end of the day. The first was the mechanism of the stent failure. So we realized there was a large protrusion of the stent 1 year ago. Then the second, moving forward, second step in the second image was, where is our LAD wire? If it's outside of the stent, we can proceed with the DK crush steps. We would not have known this without imaging. And then the third image was evaluation and optimization of the steps of DK crush that we performed. It's a complicated technique and it needs to be optimized in the end. So these 3 images, we thought, changed the course of the procedure and hopefully impacted the procedure for the better.
Thank you very much for the great case. One question?
What do you think about inflating with a bigger balloon the protruding part of the stent and then proceed for stenting? I mean,
Yeah,
you have the portion of the stent protruding in left main still under expanded relatively to the left main. So if you will dilate this part of the stent with bigger balloon, then you have more chance to cross the stent with the wire.
You mean kind of a pot almost in the left main part of that stent?
I mean, I agree that would have been possible. And just a short, so we published this in neurointervention, and there was another case which we published 2 years ago, also, which we solved like that with Colot. We really think that ostial LAD and ostial circumflex do present problems, and we really see that in our everyday practice. We see really that stents do protrude, and then we solve it in other ways. So I think Colot is also an option.
It's a good solution also with DK crush anyway, but just to underline that it could be done also differently.
Yes, we have done it differently in past as well, so we really did Colot as a solution. But we thought in this case that the discrepancy was too large. This is why we thought that the crush was better. Yeah.
I guess that this is really nicely done, but what is the main lesson of this case?
What's the main lesson for me? The first lesson is ostial circumflex and ostial LAD lesions should be guided by some sort of consensus, because I think there should be a clear message behind not nailing it. And then secondly, intracoronary imaging should be taken into account for guiding these procedures.
It's lesion dependent though, right? I mean, if you have a lesion right to ostium, there's absolutely no way that you're going to land it and be right most of the time. So probably the best thing to do is to actually cross over.
Last question here.
I do think we need a table of maximum cell size for all the different stents and positions within the stents. So for instance, Synergy's got more connectors on the 2 end runs, because we've seen quite a few cases now where we've re-entered through the side of the stent, sometimes in the left main, and we really need to know, and we need to have a nice table to show how big we can open that. I mean, the Megatron stent, for instance, got loads of connectors, and I really don't know how big you can open up some of those sides. If you were to protrude, you know, with a circumflex Megatron and then try and go through with a Colot, then you may only be able to open it a small amount. I think we really need that for all the stents.
Thank you.
Thank you very much. We have to move with the next speaker. Thank you. Great case. Yoshi, Dr. Mursato, please. Oh, it's okay?
Okay. Sorry.
Not so far.
Thank you, Chairperson. It is a great honor to be selected as a presenter in this session. My topic is a coronary intervention for severe in-stent restenosis in left main bifurcation. This right? Back. The cases of a 66-year-old male with silent myocardial ischemia. He underwent the previous PCI 5 years before, the long stenting in RCA for the old myocardial infarction, and LM2 LED crossover stenting using the 2.75 by 28 millimeter stent was performed. Clinical follow-up had been performed every 1 year. Although severe chest pain had not been complained, treatment ECG has been changed to positive. His risk factors were hypertension, dyslipidemia, past smoker, and 1 year before, he underwent the operation for small intestine carcinoma. This is the angiography. Here you can see the severe left main 111 restenotic region. Fortunately, we can perform both imaging of OCT and IVAS. Here you can see eccentric at heterogeneous ISS tissue with thick fibrous intima and stent under expansion in distal left main. Stent malapposition in proximal edge was also found. This is a static images. Comparing the large left main proximal reference, stent under expansion is apparent, and the proximal edge of the stent has malapposed the proximal side of the left main. And please click the screen. In terms of the stenotic tissue, the heterogeneous layer was found. Low intestinal tissue is in the deep side, and the thick high intestinal tissue covered with the low intestinal tissue. And the layered pattern was found in the IVAS. So we diagnosed this intestinal stenotic tissue as an organized thrombus plus thick fibrous intimal coverage. This is a list of the left main reintervention. The rate of the reintervention varied from the 4% to 90%, mainly treated by PCI. However, the clinical result of re-PCI is worse. MACE rate ranged from the 13 to 47%. Especially complex stenting has a worse clinical outcome, about 47% of the MACE. And even in the CBG, 3-year MACE was worse. Clinical outcome of the 3-year MACE is around 30%.
So, just a moment. Maybe we can ask the audience who, at the stage for restenosis and the complex left main, who go to surgery. Okay. PCI with preparation and DCB. No, in this case. Yeah.
So I think there's a mechanical cause for in-stent restenosis. Can be corrected.
Okay. Other?
I guess is the stent big enough? I mean, that we don't know that, right? That it can actually grow into the left main.
Okay. Thank you.
Okay. This is a representative study of the reintervention of either left main. They investigate the region location. There is no significant difference. Distal osseous body location and stenting technique, single kilo T stenting, there is no significant difference. And in the treatment, POVA, stenting, CABG, there was no significant difference. 5-year mortality, each treatment reached to the 5-year mortality around 30%. So how should we treat the severe left main ISR region? Left main PCI is not so rare, range to 4 to 90%. Worst clinical outcomes reported, 3-year MACE 20 to 35%. No difference among the PCI, CABG, and medication. Especially PCI, simple procedure with DCB better than complex procedure such as two stenting or additional stenting. And the shorter DAPT period favorable for the patient with a history of cancer. Please transfer to the discussion. Okay. Okay.
I don't think if you go for stenting that you can use shorter dual antiplatelet therapy in this patient, because you have a stent which is too small for the left main, so you have to correct it, and it will be difficult. And I don't think he can get shorter dual antiplatelet therapy after that.
So I think that to reopen the stent, we may use laser. We have done that several times in my place, or even in the older times, we were using rotablation to remove the metal. But
so Yves, the laser does remove the metal? You've had that experience?
No, the laser removes the tissue.
Yeah, removes the tissue.
The tissue outside the stent. We have seen that. We have done that. That's been published also.
You still have to make sure your stent is big enough to grow into the left main, right? Maybe it was a 3 millimeter stent.
Because will be difficult to optimize the stent now with probably hard tissue outside. So the result to open the stent will be difficult. But he has another solution, I'm sure.
Okay, our solution is directional coronary atherectomy. Directional coronary atherectomy using a special catheter, and which has face windows, and the windows face to the atheroма, and touch the atheroma like this. And the contralateral balloon inflated and push up to the window to the atheroma, and deflate the balloon and rotate the catheter to the direction of the existence of the atheroma, and remove the atheroma like this. After removing the atheroma, we plan the DCB treatment. This is the actual images post-DCA. Although some mild HMO dissection were found, sufficient plaque reduction was achieved inside the stent. Here you can see some mild dissection was found, but IVAS images, complete removal of the atheroma was found. So we performed the preparative balloon dilation to gain more lumen and well stent deposition in the proximal site. We dilated the SX ostium using the 3.0 by 4 mm short balloon, and the KISS balloon was performed 4.0 for the LM2 LED and 3.0 mm balloon, and the report was performed using the 4.0 mm balloon with high pressure. And then DCB treatment was performed. 3.5 mm DCB inflated in the LM to the LD, and 3.0 mm DCB inflated the LM to the LSX. And the kissing balloon inflation was performed using 4.0 and 3.0 mm balloon. This is the final imaging. Sufficient lumen gain due to atherectomy and minor dissection that was unlikely to cause thrombogenic occlusion in LSX ostium and the proximal LAD. Actual minimal lumen area was enlarged from the 2.2 to 6.7 millimeter in the proximal LAD, and the distal left main 2.3 to 8.0 millimeter square.
Do you know what stent was used originally? Yeah, Onyx, but what size of stent was used in
2.75.
2.75.
Yeah, not so a huge one. This is the actual static images. Yellow arrow indicated in the OCT. In the distal left main bifurcation LD ostium, instant tissue is completely rejected. And proximal LD minor dissection was found, however, it is acceptable. In the IBAS, that finding is also observed. However, image quality is much better in the OCT. Final CAG is acceptable. The APT shifted to the single antiplatelet therapy with aspirin 6 months after the PCI. The patient has not complained any chest symptom or showed any ischemic aesthetic change in the treatment ECG for 3 years. This is take-home message from this case. LM bifurcation 111 lesion due to instant restenosis was effectively treated with directional coronary atherectomy and subsequent DCB treatment. It provided wide lumen gain with minor dissection, and any additional stenting was not required. Imaging guidance using both IBAS and OCT was useful for this confirmation. It is also effective to reduce thrombogenic event and to shorten DAP period. Thank you for your attention.
Very nice case, and very nicely done. So this is a device only available in Japan, or?
Yeah, only available in Japan.
Only in Japan. Okay. So Eve, you had mentioned laser. What size would you start with, and how high would you go? I know there's several different. Okay, fine.
This is something I forgot. You know, it's part of my process to become older and older. So I forgot. But we were using this also for to cross a lesion that was in instant restenosis for CTO, to cross the CTO when we were not able to push a small balloon. So we were destroying some tissue. It was after that we were able to inflate the balloon.
Any direction, preparative direction is not necessary for advanced DCA catheter in such region. According to the OCT images, high intensity tissue covered, very thick high intensity tissue covered with low intensity tissue. However, low intensity tissue is a soft tissue. So we diagnose this tissue as organized thrombus in the lower layer and thick fibrous inchima covered with organized thrombus. So in some meaning, the tissue is very soft. So we can advance a very rigid catheter, a special catheter to the distal. So maybe a laser will be effective. However, high intensity tissue, laser ablation is not so effective as DCA.
Last question, Iman?
Yeah, a very small comment. I think the main problem in this case is the undersizing the stent at the original, the baseline procedure. Then left main was 5 millimeter on IVUS, and 275 will never get 5, even if you are inflating with a bigger balloon. So this is the main problem in this case.
Yeah. Agree. Thank you very much. Thank you. We have to move. Thank you. And we move to the last case. Dr. Ignacio Amat Santos, por favor.
Muchas gracias. Thank you so much. Thank you for having me. Thank you to all the audience for the patience. Being the last speaker of the evening is full of advantages. One of them is the audience is tired, even the panel of experts is tired, and I'm sure you will be very understanding with some of the decisions that were taken by the operator who did the first case, because she was very tired. It was 3 a.m., it was the third PCI that night. So the patient was a 76-year-old male, and he was presented in the hospital with a STEMI. It was a posterolateral STEMI, and the culprit lesion that I will show later was the circumflex. And that was very easy to treat. And when things are very easy for interventional cardiologists, we have to look for something more challenging. And this is what happened. So this was the circumflex. It was already treated, the stent is placed, but you can see that the LAD is occluded from the ostium. So my colleague first, when she did the circumflex, decided just to try a little bit the LAD. Maybe there was some thrombus in both arteries. Maybe it was also culprit. Just touch a little bit. It was not opening. Why not escalating to a fielder XTA? Okay, we have a knuckle. Okay, we have a diagonal dissected. So
Did you have contralateral views? Did you do this with?
Next slide.
Okay, thank you.
So she did this in the acute procedure. At this point, she realized she was probably messing around. Time to stop. Patient was doing well. Culprit lesion was treated. But after this imaging, she acquired another projection. You can see a diagonal branch that is large and is dissected in the left. And then if you see the right image, she even positioned a right catheter in the right just to see what was happening. She could see the LAD, and at this point, she stopped. The patient, as I said, was doing well. So we programmed the case a couple of days later. The circumflex was still okay. We tried some retrograde approach, but we tried 3 septals and were not connecting. So we decided to move antegrade, and you can see here that we were able to advance in the right image Gaia second wire in the LAD. But now we have a problem. We have a dissected first diagonal, CTO of the ostial LAD, not the ostial, sorry, at the level of the bifurcation. And let's have a look at the IBUS. First one in the left is from the diagonal, second one is from the LAD. This is from distal diagonal. I will let you have a look. So we are coming to the proximal part, and this is the wire going in the LAD. And this is the pullback from the LAD. Distally was a very good vessel, not very diseased. We will go through the CDO. And well, there is not much information here to add, just within the traject of the CTO. And now with this imaging information, we have to decide our strategy to treat the patient. Okay, so please, the panel, what would you do in this patient now? If you mean in the diagonal, let's have a look at it, because you can see that it's all the way in the false lumen.
You can see you can see the true lumen, which is collapsed. This on the side, which was at 3 o'clock, which is now at the 3 o'clock position. So probably I was guided puncture of that and then open this artery, because already retrograde has been failed. So you have to do an image guided puncture.
Or you go retrograde to the diagonal. To the diagonal. They were trying retrograde to the LAD. If there are some collaterals to the diagonal, you can go to salvage the diagonal through the retrograde.
But this is just the theory, or this is really what you would do? Try to do subintimal re-entry with a stingray maybe, or try to find an epicardial, or in actual practice you would do something different? That's a reasonable.
Forget the diagonal, exactly. It was occluded LAD, but the diagonal, both of them were occluded. The collaterals from the right coronary artery, I'm not sure they were perfect or not, but only the septal branches. You open the LAD, it's okay. I mean, send the patient home.
Our colleague here presented a nice star technique with proximal dissection, but distally wasn't true lumen. But here we are all along in a false lumen because my colleague did a knuckle. I understand she was in the middle of a primary PCI, but now facing this situation with a stable patient, I think.
Do we need to do anything now? I mean, why not let that heal and come back for it in a few? I don't know why go back 2 days later, because it wasn't the culprit lesion, was it?
Okay. And on the LAD, we also wait for stage procedure?
Because it wasn't the culprit. You've treated the culprit. Bring them back in a few weeks when it's healed.
One more option will be to aspirate hematoma. You have definitely hematoma. You could aspirate, and then true lumen will be much larger, and then you can go with double lumen micro and try to puncture.
Yeah, we already had the Sasuke microcatheter that we use to access antegrade, so maybe we could try to aspirate, but the dissection was so large that I think the hematoma would compress again very quickly. The true lumen, the only option maybe was stingray because it will block proximally and aspirate, or the straw technique with proximal balloon inflation and a microcatheter aspiration. Well, so to do antegrade fenestration, we could do several dilations with the balloon proximally, but we already have, again, a very large dissection.
Well, if patient is stable, patient was stable, no ischemia, no chest pain. So another option could be that you can leave it and come back within 2-3 weeks after healing of dissection and hematoma.
So the patient was stable, but after the primary PCI, there was ischemia test, moderate ischemia in the anterior wall. So not located in the diagonal, but on the...
Question?
So,
just one question. I think Marek had a very good remark that maybe we could evacuate the hematoma to have the true lumen, have a larger true lumen. But what about treating the LAD with a drug-coated balloon and this wait for a couple of weeks if you cannot evacuate the hematoma in the diagonal, not to have a larger, but this setting, maybe evacuating the hematoma from the diagonal and treating the LAD without stent, but with, for example, drug-coated balloon would be a good option, and to wait 3 or 4 weeks.
Okay, so we have got two options. Who sacrifice the diagonal? Okay. Why? Yeah. Who is doing something? Whatever. Yeah. Half.
But there are a lot of options
Yeah.
on the side
There are
of
a
doing
lot of options,
something.
but we will not describe all the options because it's very difficult at this stage, and we have to move. So half and half, I think. Half sacrifice and half is doing something.
So we were very classic, and we just put a stent in the lady. Okay. But after that, we decided to perform so we put an Agomi stent to the lady, we recrossed. The wire was still in false lumen. We did kissing balloon, and we decided to do after kissing balloon DCB to the LED. This was the approach we follow. So I have a second question for the panel and the audience. So now we did that. The flow was similar. All the diagonal was dissected. What do you expect to find? What do you expect to do? Would you do follow-up angiography?
If he has no symptoms and it's a diagonal, then I don't think there's any need to go back and look at it.
You can see the LED as a symmetry flow, but the dissection of the diagonal is still there all along. On top. Right.
Is the distal LED also occluded?
No, the LED is patented. We place the stent here. This is the kissing. As you can see, the LED is a long LED.
It was a kissing with a DCB on the diagonal.
No, first kissing,
yeah?
and then DCB to the diagonal.
And
so
DCB to the diagonal in the false lumen.
In the false lumen. But if we go back to the IBUS, the first 2-3 millimeters of the diagonal maybe were intraplaque because it was occluded. So I cannot make sure distal is clearly in false lumen, but the ostium of the diagonal, I'm not sure. Look at that. So we could see it here. You can see the LED there, on the right. And this was after stenting. The LED is a long vessel. Yeah, it's the septal we try to use. So we were in this question, what we would do, what to expect to find. and we brought back the patient 3 months later, we could see still the same angiographic image of a dissection of the diagonal. But if we check the IVUS, distally, it seems like this time the wire is in true lumen. But then when we come a little bit more proximal, it goes again in the false lumen. Probably this was in a branch of the diagonal. And here we can see the true lumen. And we will see an image that, like a fish mouth with some flow in the true lumen. Look here. So I think that the DCB created some connections between false and true lumen and allowed to have a T3 flow. Look at the flow through the true lumen. And well, I think this conservative approach was adequate for the patient. So my conclusions were, we can try to do provisional stenting technique even when the branch is dissected. Of course, imaging is crucial. This was said in all the sessions, and the session was about that. But I think that in a dissected vessel, in a branch that is dissected from the beginning to the end, a DCB strategy could be a safe alternative. I could create some communications between true and false lumen that might allow a sequential approach with different alternatives, trying to re-entering or keeping it like that. Thank you very much.
Thank you very much. So now it's the music is on, so we have no question anymore, and we have to vote. Have we got the results, or should we wait? Yeah? Yes. So it's Dejan. Dejan. Congratulations. Maybe a woman, yeah. Thank you very much. It's the end of the day. Tomorrow morning, it's beginning at 8 with first introduction, first new session. 3 sessions, 3 news from EBC, and beginning with introduction in Warsaw. Have a good night and a good dinner.